ছি। Good morning, ladies and gentlemen. We welcome all delegates and faculty to this PSG Proctology Update 2023 Fistula Demystified, organized by Department of Surgical Gastroenterology, PSG Hospitals, in association with Associations of Colon and Rectal Surgeons of India. To quote the words of Claude Brunet, it is what we know already that often prevents us from learning. We commence our program with lectures by eminent national faculty. A word to our faculty. You will have 12 minutes per lecture, followed by 3 minutes of question and answer. Anatomy is to physiology, as geography is to history. It describes the theater of events. To start things off, we have Dr. Kamal Gupta, who will talk to us about anatomy of the anal canal. We welcome Dr. Gupta to the stage.
Is it on? Yeah, dear colleagues, a very good morning to all of you. So without wasting much of time, I will directly start with my talk. And 4 topics I'm going to discuss with you. And whatever cases you are going to see in the afternoon session, they are all correlated with the very first talk of the day. So coming to the anatomy of sphincters, 3 functional groups are there: internal anal sphincter, external, excuse me, the slide is flickering. So it is it's still flickering. Just help me out.
We'll try with them.
Is it fine? Okay, thank you. So it is the internal anal sphincter, then CLM, that is conjoined longitudinal muscle, and the external sphincter and puborectalis. So coming to the internal anal sphincter, it is continuation of the circular muscle of the rectum. By nature, it is a smooth muscle and involuntary. Thickness is approximately 3 millimeters, and surgical significance. Now, this sphincter does not reach up to the anal verge. It is approximately 1.2 centimeters below the dentate line, and below we get subcutaneous part of the external sphincter. So, in between a groove is formed, which is called intersphincteric groove, and that is a groove which is important when we are operating for lateral internal sphincterotomy. And secondly, according to Park, if you read the original publication of 1961, it is very clearly mentioned that internal anal sphincter can be opened up to anorectal ring without any incontinence. So that is something which is important for us to understand when we are dealing with extensions of intersphinctic tracts or intersphinctic abscess formation. CLM, now CLM is a longitudinal continuation of the longitudinal layer of the rectum. Now the few fibers, they cross medially, the pointer is not working, please see this. Cross medially, and they form ligament of Treitz which holds the anal cushions in their normal position. Now once these fibers they weaken, after that there is sliding of the cushions, and the very popular theory by Thompson, sliding anal cushion theory of 1976, is based on that. Three expansions are there of conjoint longitudinal muscle. The medial most is the intermuscular septum. Lower, the CLM gets inserted into the perianal skin where it forms corrugated cuticini. They are like loculi, and the main structure which is present is the external hemorrhoids, external, or we can say inferior hemorrhoidal plexus. Then laterally, excuse me, your pointer is not working, please. Just see in case it can work. Okay. So over here, you can see the outward extension which is there, that is the Milligan septum. Now, what is the importance of Milligan septum? It lies in between the subcutaneous and the superficial part of the external sphincter and divides the ischiorectal fossa into two. That is, the lower one is the perianal space and the above is the ischiorectal space or ischiorectal fossa. So, surgical importance, intermuscular septum, it prevents any infection from the perianal area going upwards toward the submucosa. Corrugated cuticini, now that is where the external hemorrhoidal plexus are there, and this is a part where we get thrombosed external hemorrhoids, a very painful condition because it is present in the formation of a loculi. And Milligan septum, now this prevents any infection from going from perianal area towards the ischiorectal space. At the same time, any abscess which is formed in the ischiorectal space will not have any signs of inflammation on the perianal skin until and unless it pierces the Milligan septum. So that is the importance. External sphincter, three parts, all of us know about that: subcutaneous, superficial and deep. Subcutaneous gets inserted into the perianal skin along with the corrugated cuticini muscles or CLM. Superficial, it gets inserted into the coccyx and form the anococcygeal ligament. And the deep part, it continues with the puborectalis, which is a part of levator ani. So it continues with that to form anorectal ring. Thickness is approximately 6 millimeter, and it is a voluntary muscle, and it is skeletal muscle type 1 and type 2, and maintains approximately 15 to 20% of the resting anal tone. 55% to 70% of the resting anal tone is maintained by the internal sphincter. Now, what is the surgical importance? It all depends on how much sphincter we have to sacrifice. Now, if we are dealing with low end fistulotomy, for intersphinctic fistulas, we cut only the lowermost part of the internal sphincter and the lowermost part of the external sphincter, that is the subcutaneous part. Chances of anal incontinence are negligible. At the same time, if we cut up to 30% of the external sphincter, that means the superficial part is also cut little bit, then the chances of anal continence are there, but that is just a transient. But if it is involving more than 50% or up to 50%, and if you cut the subcutaneous and superficial part, primary sphincter repair should always be done. So that is how we should be dealing with external sphincter. Under no circumstances the deep part of the external sphincter or the puborectalis should ever be cut. Nerve supply and the blood supply. Blood supply is by pudendal artery and vein, and nerve supply, both internal sphincter and CLM, they are supplied by sympathetic and parasympathetic, and external sphincter is supplied by pudendal nerve. Now, what happens when we go for procedures like finger guided hemorrhoidal artery ligation or hemorrhoidal artery ligation? Now, what happens, we always take fibers of the internal sphincter, and postoperatively the patient says there is some pain, and we think the pain is because it is supplied by the pudendal nerve, which is not true. The pain is there because at that time the internal anal sphincter muscle goes into spasm. So, the muscle is supplied by sympathetic and parasympathetic only. Now, coming to the anatomy of paraanal and pararectal spaces, the most important space that I will be discussing. Now, the most important is ischiorectal. As you can make out, medially there is external anal sphincter that forms a boundary. Above it is the levator ani, and laterally it is obturator internus along with the pelvic bone. Now, the most important structure which is present over here is Alcock's canal. Now, when we are dealing with conditions like ischiorectal abscesses, many times people keep on putting fingers inside to break the loculi. Loculi are never present, it is a loose fat. Now, what happens once you are breaking, feeling something and breaking it, we are breaking the fibers of the inferior rectal nerve, which is a branch of pudendal nerve. So, if you do so, postoperatively the patient may complain of paresthesia in the region of ischiorectal fossa. Another thing to understand, you are going to see all these cases today, so just concentrate on this slide. Now, anteriorly we have got, we know perineum is divided into two parts, the upper is the urogenital triangle and the lower one is the anal triangle. So, in the urogenital triangle, which is up over here, now this forms the anterior boundary, and posteriorly there is sacrotuberous ligament and the gluteus maximus. So, posteriorly tracks, if you see 10-15 centimeter long tracks involving the gluteus maximus, it means there is a posterior spread. You are going to see one case in the afternoon session of both the diseases, both the places, anterior and posterior spreads. Perianal space, it is medially it is intersphinctic and laterally it is continuous with the fat, the lower one, and the most important structure already I have told you, it is the external hemorrhoidal plexus. And secondly, once any infection starts at dentate line from the inner glands, if it takes an intersphinctic plane, it forms a perianal space abscess. So, that is very important for us to understand related to fistula. Submucosal space, as the name indicates, it is the submucosa where anal cushions are present, and we know the main content is the superior hemorrhoidal plexus, but that is a common place for abscess formation also, because 80% of the glands they are present in the submucosal space. Intersphinctic, now this is something interesting. Intersphinctic is between the two sphincters, all of us know, but if any infection starts from here and goes upwards, it will go towards the levators and it will give rise to supralevator abscess formation. Then another very important space is deep postanal space. Now, just imagine a patient lying in the lithotomy position. So, how we see which is the area where the deep postanal space is there? From the superficial part of the external sphincter up to the coccyx draw line. So, that is the place where anococcygeal ligament is there. Below that is the anococcygeal raphe or the levator plate, and this is the space which lies in between. Now, the ischiorectal fossa on both sides, they continue with the deep postanal space. So, we are going to demonstrate one case of horseshoe fistula in the afternoon and just see how deep postanal space can be opened up. And until and unless you open the deep postanal space, any patient of ischiorectal abscess or ischiorectal fistula is not going to heal, because the chronic infection which is lying over there in the post-deep space has to be tackled. Now, this is another important part, infralevator space. Now, we know that wherever except for the abdominal wall, anterior abdominal wall, there is only superficial fascia which is present in the anterior abdominal wall. But in the ischiorectal space, immediately below the skin, there is the superficial fascia. But the deep fascia goes up right from here, and it goes up like this, and this is the suprategmental space it forms. This is called fascia lunata. Now, what is the surgical significance? Now, we can see the second septum which is lying in between the superficial and deep part of the external sphincter. This is called a septum of ischiorectal fossa. Now, this divides the space ischiorectal fossa into two parts. The lower one is the clinical ischiorectal fossa or ischiorectal space, and the above is the infralevator space. And the muscle which you are seeing over there, the levator ani, this is the levator ani. So, below that is present the infralevator fascia. So, any abscess which is formed over here from the ischiorectal to or inferior this infralevator space, it can pierce this muscle and go and form the supralevator abscess. Then supralevator space, we can see from the picture, immediately it is the rectum, and laterally it is always the obturative fascia and or obturator internus. Superiorly we have got peritoneum. Now, two layers are there, one is the peritoneum, second is the transversalis fascia of the anterior abdominal wall, and inferior is the levator ani. Now, any infection from the ischiorectal space can go up and form the supralevator abscess. At the same time, any infection from the pelvis can come down and again form the supralevator abscess. Retrorectal space, as the name indicates, behind the rectum, and is a common place for presacral tumors. Now, this is a space which is very important, and all of us should be opening this space when you are operating for ischiorectal for any type of fistulas. Any fistula means any fistula. Now, this is a space which lies between the anal verge and the anorectal ring. The space is called deep intersphincteric space. Now, surgical importance, once you are going for excision of the internal opening, that is pass technique, we always take the incision about half a centimeter above that. So, once you remove mucosa, submucosa and few fibers of the internal anal sphincter which form the anterior boundary, below you will find unhealthy granulation tissue. And unhealthy granulation tissue means you are into the deep intersphincteric space. Until and unless you remove this, you clear this space, curate it and irrigate it, the patient is not going to be fine. Coming to the pathophysiology, now the most important structure which remains is the anal gland. Now, anal gland, as you can make out, that in about 80% of cases they lie in the submucosa, and this around 8% up to CLM and remaining 8% up to the in between the CLM and the external sphincter. So, they have got either tubular form or ramifications. Ramifications which are present, they are 4 to 16. Now, what happens once these glands they become infected? We get fistula of various varieties. Any ramification going up can give rise to intersphincteric abscess or suprasphincteric abscess, which is going down, which most of them go down. The most common presentation in our clinical practice we get is a intersphincteric fistula. Why? Because most of the ramifications they are downwards caudally, not cephalad caudally. Now, what happens if the glands becomes obstructed? There may be stasis, infection, formation of an abscess, and many times or most of the times or always we always send the pus culture for culture sensitivity or to rule out tuberculosis. And secondly, we send the specimen for histopathology. Why so? Because these glands they are having lymphoid follicles on its surface. So, that is the reason that the tubercular infection can be present over there. So, coming to the pathophysiological spread, well, as you can make out, the infection once it starts in the intersphincteric space, it can go upwards towards the intersphincteric space and levators, outside ischiorectal, below is the perianal, and that is the way posterior can also spread. Posteriorly is from the posterior part of the rectum and the anal canal, And the most important space which is present over there is the deep post-anal space. So that has to be opened. Anterior spread, just see this, how the anterior spread takes place. All of us are very much familiar with the superficial and deep perineal pouches. We know about the anatomy of that. Now the important thing to consider is this anterior spread, it takes place in between the superficial transverse perineum, which is a part of the superficial perineal pouch, and the deep transverse perineum, which is a part of the deep perineal pouch. So you have to, if you are going for a open surgery, you have to cut this muscle to remove the extensions. Now many times when we get anterior horseshoe, we always think the internal opening is going to be at 12 o'clock, which may not be true. Any infection which is at 6 o'clock position can also travel anteriorly and form a horseshoe fistula. Another important thing, it pierces bulbospongiosis and ischiocavernosus. So the space which is there, that is a deep anterior anal space. This is a space. Now that is the reason once the fistulas they travel anteriorly, in males we get an external opening in the scrotum, at the root of scrotum or somewhere in the scrotum or inguinal canal, and in females it is present near the labia. So once we understand the anatomy, only then we can operate it in a better way. Now this is another picture. You should know that it is very well demonstrated or written in the literature that there may be spread of fistulas towards the medial aspect of thigh. So now what happens? We know the Colles fascia, which is there, I think I have opened the second lecture, the Colles fascia which is there. Now Colles fascia is a part of the superficial perineal pouch, and it continues above with the scarpus fascia of the anterior abdominal wall. So that is the reason any spread of abscess gives rise to a fistula formation in the anterior abdominal wall. At the same time, this fascia, when there is fascia of the superficial and deep fascia of the thigh, now that is called fascia lata. So once there is a communication between fascia lata and the scarpus fascia, then it will give rise to one external opening in the medial aspect of thigh. So that is how anatomy should be interpreted in cases of fistula and abscesses. Thank you very much. So any questions, if they are there, we can take later on. I think we are already running late by 1 hour. There are questions we can take later on. Any questions anybody wants to ask? Please go ahead.
The lecture was very good, sir, and I came to know many spaces which I was not aware before. So I'm just wondering, with this complexity, what is the investigation of choice to find?
Can you just put the mic a little bit up? Yeah.
With the complexity of the spaces, I'm just wondering what will be the investigation of choice to pinpoint the location of the abscesses. Thank you.
I could not understand your question actually. Your voice is not audible to me.
Oh, sorry, sir.
Yeah, can you just loudly?
Sir, can you hear me now?
Yeah.
So what I am saying is, with the complexity of the spaces, what will be the investigation of choice to pinpoint the abscess and its space? Thank you.
Investigations, MRI, okay. Only MRI. Okay. Any other question? Okay, thank you.
Thank you, Dr. Kamal Gupta, for the enlightening talk. Next, we welcome Dr. Samrat Jankar. Sir will discuss fistula classification and a novel algorithm for fistula documentation.
Good morning, everyone. I am just thank you for organizing Balu and surgical gastro team, and thank you for Acrsi giving opportunity to talk on the topic. Fistula, I am talking about the regionasucal patterns and mapping for better fistula understanding. When it comes to fistula, one MRI report, for a surgeon it will become, we will go through the report, at the end of the day, we will conclude that lot of thing has been written and we can't interpret. At the end, our conclusion is it is a complex fistula. And when surgeon think complex fistula, whole vicious cycle runs, I need to do less or I need to do more. At the end of the day, recurrence is acceptable, incontinence is not. We will do less and lot of time recurrence is the problem. For that purpose, Dr. Rajuna Sukal has introduced the patterns and mapping about the fistula to understand how to interpret that fistula. I am just quoting this. So I bring greeting from Symbiosis University Hospital, Pune. I am here a consultant. So disclaimer, this is a presentation, all the concept belong to Dr. Rajuna Sukal. Nothing of mine I am delivering here. And many of the animation and slide I have prepared, with his permission I am presenting. So let's go for the purpose of any classification of the fistula. If it comes classification, that has to define at least three things for us. The simplify and standardize communication between the clinician. So some classification is there. If we tell it is acute gallbladder or simple gallbladder, something we can interpret from that thought of the radiologist or next surgeon who is sending to me. Second is, that should guideline the surgeon to appreciate about the complexity, and also appropriate treatment option has to guide. So coming to third question, it is more important that at the end of something we classify the fistula, surgeon should be at the stage to tell prognosis to the patient and think about the complication. If at all we are telling simple appendix or perforated appendix, I will tell the patient that I am going to do the open surgery for complicated or abscess. I will tell the patient that it is a complicated patient, I need post-op longer recovery, I need open surgery. Something should come in the fistula. So everything is crumpled up, because of that we get a lot of confusion. For that reason, we need to first understand what is available classification as a surgeon, as a radiologist we are following. This is a one famous classification, and I think this is the first intent has been done in fistula history by the Park to give the Park classification. It's a wonderful classification and it is a commendable job done at that time around 35-40 years back. So he has given 4 types. In fact, it has been sub-classified and given as a 14 type. Lot of thing has been put on the picture, on the book. In fact, we are all following this. Let's go into the minor details of it. It is a surgical classification based on physical examination, because MRI was not that available in that era. And it's an most easy, most simple, and most easily can tell that is it a transpintric, it is a interspintric or supraspintric fistula. And it is based on only coronal plane. Axial plane are more important, has been not considered because it is a pre-MRI era where this classification has been proposed. Now coming back, should it be used in this present era, this classification? That's the question. It is a pre-MRI area, and at present whatever we do fistula, it comes a complex fistula. In fact, few of the studies are going in favor that even it's simple fistula, do the MRI, because lot of fistula, 30% will get converted into the complex when you do the MRI. And more important is, not doing MRI, we are not justifying the patient in every case. It's not that every case should be done, it's not bold statement, but doing MRI, our understanding will improve. At the same time, we may be better with seeing. If we see 100 of CT, my diagnosis on the CT image will improve. Doing MRI, that will also going to improve. So if we see these patterns, what is happening is a mixed fistula in every class, because interspintric high is different, low is different. Transpintric low is what sir has told, very good. Low we can do blindly fistulotomy, but high we can't do. That everything has been mixed and put in front. If we see this interspintric means both are there, high interspintric, low interspintric. Treatment for both is absolutely different, but has been clubbed and put in type 1. If it is coming to transpintric, low transsphincteric, high transsphincteric. Treatment for both is different, but as put in one. But at the end of the day, if you tell transsphincteric, I cannot conclude what to be done. That is the problem. Data is skewed. If you see, more fistula has been classified in a first two type and less in the last two type. So data has been skewed towards the simple and has been mentioned lot. So third thing is coming is extrasphincteric, suprasphincteric. As per the many of the legends who has been doing work in the fistula is, these type may or may not exist, and many of the papers are there, they couldn't find. In fact, if we see Park's only paper, starting from the Park classification, over the period of 3 or 4 big paper what has been published, the extrasphincteric, suprasphincteric portion was reducing. And in fact, one of the Eisenberg paper also is mentioning that it may be erroneous or it may be iatrogenic. It cannot be a classical cryptoglandular fistula. Coming to the thing, St. James, basically this is 1992, I think, I may be wrong. That has been done by St. James University classification. This is also belongs to the Park's university only, where Park's classification has been done. It is nothing but just replication on MRI, based on the MRI, same classification. What has been done is, it is MRI based, mostly used by radiologists. Even this classification comes, it doesn't give a conclusion for the surgeon what to be done for this case. So it is more or less like a Park classification, doesn't have much in surgical planning. If you see intersphincteric, abscess, it is intersphincteric fistula only, they have given 2. Transsphincteric abscess, it is a type 2, it has been just separated into 2 classification. And type 5 has been made as a separate. So it is also not much helping, and in fact, present true condition is we do MRI for many cases, but at the end, again we will put our thought process, Goodsalra and our surgical inception and do the case. So coming to what Arun Rajanasukal quotes is, this is very important quote, what he quotes is, if it is a classical cryptoglandular origin fistula, he tells as anal sepsis. To demystify fistula and abscess, there is many of the time we see that it is a fistula having a abscess, and many of the time it is an abscess which is having the fistula. It's not too different, rather than he call it as a anogenital or anal sepsis. Anal sepsis is predictable. It always spread between the muscle and spaces, and anal anatomy and pattern is constant. We need to understand, means we need to understand that. So coming to that, what he tells is, to understand the anal anatomy, particularly for the fistula, we need to understand 3 things. That is, one is anogenital muscle, second is anogenital spaces, third one is anogenital fascias. That sir has also given a complete overview. Just we will focus more about what is surgeon's fear. It's not an internal sphincter. Internal sphincter we can divide, but the external sphincter, how and where we need to divide, that we need to clarify. And every time fistula we see, we need to focus on that part only. So coming to that, he has given the 3-level concept of anogenital striated muscle, where upper level, middle level and lower level. If we see lower level is counterpart to bulbocavernosus, which is a subcutaneous external sphincter, which blindly you can cut. It is a 8 mm to 1 mm and nothing going to be incontinence. Second level will come is anococcygeal ligament to superficial sphincter, and that is superficial external sphincter, which is separated by the perineum by the superficial transverse perineal muscle. This is caution. Every case cannot be divided. If it is anterior fistula in female, it become a complex fistula where you should not divide it, where it apply the sphincter preserving procedure. If it is coming the Crohn's patient, we should not divide. If it is coming recurrent prior fistula surgery done, having the sphincter weakness, you should not divide. This land into the incontinence, should be cautious. And coming to third, levator ani, deep part of external sphincter and levator muscle clubbed together, he call upper level as a levator ani. This at any cost we should not divide. That should be the principle. So he has demonstrated over the hundreds of cadaver. That cadaveric image, levator is, upper part is levator, middle is superficial external sphincter, and lower part is subcutaneous external sphincter. This is simply to understand what is relevant to the fistula. Coming to 3-level concept, that's levator is upper level, which should not be cut, and middle level superficial external sphincter, which can be cut in few cases, should not be cut in few cases, that we need to understand. Last is you can cut without any fear, that is a subcutaneous external sphincter. Coming to next concept about the perianum is anal fascia. Anal fascia is also very important to understand the pattern. If it is coming to anal fascia, there is something called intersphincteric fascia, we all know. There is a fascia in the intersphincteric space. And second, sir has mentioned that Milligan's fascia or transversalis fascia, which goes across and divides the lateral part into two, and above another one is infralevator and ischioanal, which divides by the ischioanal fossa fascia. There is three fascia which we need to understand. Coming to that, it will divide the perineum. If we see, this is the, if we see, this is the part of ischioanal fossa fascia and transverse fascia, which divides lateral part. Below the levator is infralevator space, that is below the levator, above the ischioanal fossa fascia. Between the transverse septum and ischioanal fossa fascia, he called ischioanal space, and below the transverse septum fascia, he called perineal space. What he suggests is, when we call ischiorectal, again surgeon get confused about rectum and other thing. So simply he avoids using the quote of ischiorectal, he always talk about the ischioanal space. Coming to next is, there is a spaces. When we understand the muscle and fascia, it is very easy to understand the spaces. There are mainly 7 spaces which we need to take into account when we are dealing with a fistula. Those are, that is laterally above the levator is supralevator, below the levator above the ischioanal fossa fascia is ischioanal space, and coming down is a ischioanal space, and lower is your perianal space. In between the internal sphincters is intersphincteric space. Posteriorly deep to the ischioanal fossa, it is a deep postanal space. Anterior counterpart is perineum space. So if abscess is there at area, we can call it as intersphincteric abscess, perianal abscess, ischioanal abscess, infralevator abscess, supralevator abscess, and deep postanal abscess. That is a perineum anteriorly, perineum abscess. So it will become easy to understand what's going on in the perineum. So this much if you understand, we can classify any of the fistula and any of the thing, and we can predict. That's what his concept is. Coming to the fistula pattern, he suggested rather than the classification type of fistula, let's understand the pattern. Understanding the pattern, what he proposes, this abscess always travel in the path of least resistance. It never crosses the muscle. That is the basic principle of any fistula. We know that how fistula form. 80% of the cryptoglandular lying medial to the internal sphincter, which will get burst and which will subcutaneous mucosal abscess, we may drain or it may get burst. If it comes to the internal sphincter goes into the spasm. Spasm of internal sphincter, then it's find out the path. There is only 3 paths where abscess can travel. Either it has to go down, it will become a low intersphincteric. Either it had to go up, it will become a high intersphincteric. Either it has to cross the sphincter, it may be low transsphincteric or high transsphincteric. That's what the pattern every fistula follows. Based on this pattern, he classifies, this is a low transsphincteric and high transsphincteric. Based on this pattern, he classifies every fistula into 5 patterns. That is, if it is coming down, it is a low intersphincteric fistula. If it is coming through the lower external sphincter, that will become a low transsphincteric fistula. Because anteriorly we have perineum, posteriorly we have deep postanal space. For that reason, transsphincteric, high transsphincteric, he classify into anterior high transsphincteric, which goes into the perineum, comes out, and posteriorly which goes into the deep postanal space and comes out, he classify it as a posterior high transsphincteric, and leftover last is high intersphincteric. So these are the 5 patterns. If we understand the pattern, we can justify our patient. And last 3 years I am using it. It can be easily, we can chop out what pattern is going on based on our experience. So let's talk on the low intersphincteric type. Low intersphincteric type, it's very easy. It is coming down. Just do the sphincter cutting procedure. There is no harm to the patient. Coming to second one, low transsphincteric pattern, which is very easy because it is going in the superficial or subcutaneous part. You can go for sphincter cutting procedure, whatever is a procedure which is preferential. But these are the most common type where fistulotomy, that is sphincter cutting, which can be done without any fear. Coming to next is anterior high transsphincteric. When it comes to a female patient, it will become a complex one. Even in the male also, if it is going in the perineum, it will become complex. Here role comes the sphincter preserving procedure. Whatever the sphincter preserving procedure of your choice, coming to lift, waft, laser, whatever is there, we can apply that. Coming to next is posterior high transsphincteric. Posterior high transsphincteric, again, this is the one of the space, one of the pattern which make more complicated for the surgeon. Routinely 80% will go to the deep postanal space, go right or left and present as a ischioanal or horseshoe tract. This is 80% what he labels. Another one 5 to 10% where it starts at the 6 o'clock, goes to deep post-anal space, open at the pyloneedle area, which confuse with the pyloneedle opening. And last one is, which make a more problem is, it goes in intersphincteric and comes out as a short arc, it is a less than 5%. So posterior high transsphincteric fistula we need to understand. Coming to last one is high intersphincteric type. That is, he label as a intraanal fistulotomy, transanal fistulotomy. Just understand where it is going to be. And another thing what he club is, when we do procedure repeatedly, there is possible that we may have combined pattern. Combined pattern, most complicated pattern is combining with the high posterior transsphincteric with high intersphincteric. It is the most complicated pattern where we need to worry for the patient to treat. So this will be high post transsphincteric and high intersphincteric. Combined pattern will be the most complicated. So coming to a mapping, to understand the mapping, MRI, how we need to ask the radiologist, give me a pattern, give me a map. It will become more easy over the period of time. What is the problem with radiologist? He gives a Saint mask classification, surgeon read his finger, and at the end it is a weak link. What surgeon want, radiologist doesn't give. What radiologist give, surgeon doesn't understand. At the end, we are not accepting his MRI report and we are doing whatever we are continue to do better for the patient. If what has been proposed by Dr. Rajana Sukal is anal fistula map. It is a template to report anal sepsis. Purpose of fistula map, document anal sepsis, where it is going, direction and associated cavity. So we need maybe in a better position to deal the fistula, we may be mapping the patient. So for mapping purpose, he gives a standard mapping format. Internal opening, where it is, we need to start, as every fistula start from inside to out, we need to start that internal opening where intersphincteric, what is available, level, it is a low intersphincteric, high intersphincteric, low transsphincteric, high transsphincteric, what spaces out of 7 we need to mention, end, is it a external opening is there or blind end is there, we need to mention, and distance, it doesn't matter, but sometime if we are planning for laser or what, distance matters. So that's what he has given. These all things we can get from the MRI. We need to ask the radiologist, these are the things we need. So if we get those all things written in the map, we can assess that internal opening where it is. We can assess intersphincteric space, is there any abscess, cavity or tract. At the levator, is it a intersphincteric, low transsphincteric, high transsphincteric or translevator. Anogenital space out of 7, which one is involved. External end, where it is ending, is it a external opening is there or blind end, we need to tell everything. So we can see that if we are pro for the lift doing, we can use a prone position, this diagram. If we are pro for the routine procedure, we can use this diagram as a lithotomy position. For example, if radiologist give this much of track, surgeon can understand. This much if he write, surgeon can understand. Let's see how the mapping works. Internal opening, IO6 at 6 o'clock, internal opening is there. Coming to intersphincteric, there is a track is there. Coming to high transsphincteric, it is going up in the high transsphincteric space. Infralevator space and ischianal space, there is abscess. Perianal track is there and external opening at 7 o'clock. So it makes a surgeon life little bit simplifier so that we can talk in a same page with a radiologist. So take home message is understanding anatomy before any procedure is most important. It's both anal anatomy and fistula anatomy. And map your fistula based on mapping system and define your pattern based on your input from the clinical MRI based input, and then choose your procedure based on the fistula pattern. Wherever possible, do the sphincter cutting procedure. Where your sphincter at the risk, that is complex fistula, you can think, and always think about the core surgical principle, save the sphincter. Laser is a tool which we can use, added advantage, but core surgical principle should not be forgotten to treat any kind of fistula. Any question and answer, I will be happy to answer. Thank you.
Thank you, Dr. Jankar, for that interesting talk. We now welcome Dr. Arshad Ahmed for his talk on sphincter function and its significance in fistula surgery.
Thank you. At the outset, I must thank the organizers, Dr. Kannan, Dr. Balu, and the entire team who have organized this event. And it's a fantastic place. The guest house is like a 5-star hotel, so I must acknowledge and appreciate. all the organizers for inviting me and sharing this platform with me. So most of the things which I wanted to cover actually have been already covered by Dr. Samrat and beautifully by Dr. Kamal Gupta, sphincter function and significance in fistula surgery. So we all know that the fistula surgery aim is to cure the fistula, to prevent recurrence at the same time to save the sphincters. And most surgeons' reputations, this is the line written in Corman that their reputations have been impugned because of the fistula surgery, and it is because either there have been recurrences or there have been, if they're very aggressive, they can lead to incontinence. So the balance has to be made between recurrence and incontinence, and the fistula that we are discussing, mostly they are all primary fistulas, not secondary ones. 97 to 98% fistulas are primary, and they are of cryptoglandular origin, and we can see that the slide is not this one. Okay, so this is the place which is the initiation or the beginning of infection. This is the anal gland which is present in the intersphincteric plane. So this is the central disease, or this is the gateway of disease, and from this place the disease gets access to so many places as Dr. Samrat depicted. So we need to understand that the disease starts between these two sphincters. So internal sphincter and external sphincter, between these two is the intersphincteric space where the disease usually begins. And the external sphincter is more important because internal sphincter and longitudinal muscles, these are the two native muscles of large bowel. They are coming from above. But the external sphincter complex is a new muscle which is coming only in this region. And the function of continence is basically the gross continence is maintained by this muscle, which is primarily of type 1 and some type 2 fibers also, which is giving this additional force, additional enforcement to this area for this function of continence. And subcutaneous, superficial and deep, these are the parts, along with, and deep part of external sphincter is is directly communicated with the pelvic floor muscle, that is the puborectalis, the medial most pelvic floor muscle. So this triple loop theory, which also assists, not only it maintains continence, these three muscles also assist in defecation, in the process of defecation. So the most important factor which is giving continence, gross continence, fecal continence, is anorectal ring. And this anorectal ring is formed by not only puborectalis, but also it gets fibers from the deep part of anal sphincter, external sphincter, also the internal sphincter which is lying in that area. And this maintains the anorectal angle. And this is the most important factor contributing to continence. If you look at various factors which are contributing to continence, we can divide them into A, B, C. The most important is A, and this A is formed by anorectal ring, and this anorectal ring is due to the pull by the puborectalis, which is the medial most muscle of pelvic floor. Then B is the other muscles of external sphincter, that is the superficial and subcutaneous, and also the internal sphincter. And C, which is very fine level of continence, continence to gas, continence to sometimes diarrhea, and content sampling, that is the ability to distinguish between feces and flatus. This comes by the hemorrhoidal cushions, which also perform content sampling, the reservoir capacity of rectum, and of course, the compliance of rectum. So A is most important, followed by B, and followed by C. This is how we see the contribution of continence. So external sphincter is having both types of type 1 as well as type 2 fibers, the fatigue fibers as well as non-fatigue fibers, and that is why when we do internal sphincterotomy in cases of patients of anal fissure, in chronic anal fissure, over a period of time, these patients do not develop incontinence because this external anal sphincter takes over the resting tone part also, because it contributes substantially to resting tone also. Parkes classification, I will not come, I will just try to give two messages. This 3-tier muscle has already been described nicely by Dr. Samrat, and this is the cadaveric description of the same space. You can see this is the intersphincteric space, and this is the ischioanal or ischiorectal space. So this is the space which is most important because the infection travels sometimes in this space in a horseshoe manner because most of the anal glands are located posteriorly. So in posterior fistulas, often you see that there are multiple glands which are involved leading to a horseshoe or U-shaped infective process in the posterior intersphincteric space, giving rise to horseshoe disease. Anterior glands are few, they are sparse, so usually anterior fistula there is only a single gland infected, there are no adjoining glands, no glands nearby, so usually you get a single tract. So those procedures like lift procedure or slot procedure, they are more suitable sometimes with a single mature tract. But when you are getting a horseshoe-like disease, we will describe that part later on in the clinical management of fistula, that this horseshoe extension of disease, which is mostly seen in the posterior part of intersphincteric plane, that is the reason for a horseshoe disease. So again, going up, you can see transverse perineae, and then high up, this is the pelvic floor muscle. So again, this is puborectalis, the upper part of external sphincter complex, and then the other muscles of pelvic floor. So the important part, clinical part is in fistula assessment, that whether this fistula can be managed by a simple fistulotomy or we need to do a sphincter preserving procedure. That is the applied part. When a patient comes to us in OPD, sometimes in OPD also, during OPD assessment, we are able to understand this is a simple fistula. We may not even need MRI. Straight away, we can take the patient up in OT and do a fistulotomy, simple fistulotomy. Sometimes in OPD examination, we need further information because the disease is not completely understood by our examination part. So we need these patients to subject to MRI to see the extent of disease and then take a decision. And then finally, when we pose these patients, examine them in anesthesia, whether saddle block or GA, and then we do a complete mapping of disease, especially for the complex ones, and then we take up the case, then we decide that what procedure would be suitable for these patients. Now, how do we start this examination in OPD? How do we assess that this patient is having a simple fistula or a complex fistula? So first of all, in OPD examination, you can see in external opening is here. If the external opening is within 1.5 centimeters to anal verge, it means it is an intersphincteric fistula because that is the place of intersphincteric groove. So external opening in intersphincteric fistula would be within 1.5 centimeters of the anal verge. If the external opening is beyond 1.5 centimeter, it means it is not an intersphincteric fistula. Then the second step, just feel the place from external opening up to anal verge. If you are feeling a cord-like structure going just below the skin, it means it is a low transsphincteric fistula. It is crossing only the subcutaneous part of external sphincter. So that's a simple fistula, we all know. So intersphincteric fistula, external opening is within 1.5 centimeter. If it is outside 1.5 centimeter, it is not intersphincteric. If you can feel that cord-like structure, it is low transsphincteric. Then if you can't feel it, it means it is not a low transsphincteric. It is not intersphincteric. Then if you can probe it, and the probes, don't probe it fully, just see the direction of probe. If probe is walking towards anal canal in a straight manner, it means it is not a high transsphincteric, it is some sort of intermediate transsphincteric fistula. Because in a high transsphincteric fistula, the probe will go up, 45-degree up, not towards the anal verge. So this is a very simple clinical way to distinguish that these are very simple fistulas, maybe low intersphincteric and low transsphincteric fistulas, which may not need further evaluation with the help of imaging. All other fistulas, where your clinical assessment does not give you a true 100%, you are not 100% confident. If the disease is not coming completely between your two fingers, you should take the help of imaging. And as of now, MRI is gold standard because it is reproducible, and all surgeons who are doing good proctology volume, they should know, they should understand how to see MRI. So fistulography is obsolete. Ultrasound definitely has a good role to play, but it is operator dependent. Intraoperatively, if you have ultrasound facility, then nothing like this, but MRI definitely continues to be a gold standard as of now. So in MRI, we have to see axial view, we have to see coronal view, and we have to see sagittal view. As Dr. Samrat said, the Parkes classification, it is based on coronal view, it does not take into account the axial view. Axial view tells us about the transverse spread of disease coronal view tells us about the vertical spread of disease. Definitely when we are planning treatment, vertical spread is more important because that is where sphincters come in picture. External opening may be far away, maybe sometimes on abdominal wall, maybe sometimes on thigh, laterally on the gluteal region, posteriorly towards natal cleft. So that is far away. So that is only traversing the subcutaneous tissue fat. So we are mainly concerned in fistula surgery, our concern is to cure the fistula without damaging the sphincters. So vertical extent of the disease, which comes in the coronal view, this view is more important definitely. But axial view tells us about the horseshoe disease. So this is the axial view, and you can see the disease is horseshoe in the posterior intersphincteric space. In the fourth film you can see. This is the extrasphincteric disease in the ischianal fossa. It is coming close to sphincter complex, and then it is coming in the intersphincteric plane, and in the intersphincteric plane you can see it is horseshoe. So mostly horseshoe fistulas, majority of them you will find the horseshoe component is in the intersphincteric plane. So this is the sagittal view, which tells you about the presence of infection in the postanal space, maybe in the superficial postanal space or deep postanal space. And this is the coccyx, this is the anal verge. So this is the anococcygeal line, and you have superficial postanal space, deep postanal space, supralevator space, like that. So this coronal view is most important because this tells us about, this is the topmost part of external sphincter complex, that is the puborectalis, and this is the anal verge. So now one more important thing which I want to tell here is that when we are doing hemorrhoid surgery, no matter which surgery we are doing, whether we are doing MIPH, stapler, laser, DGHL, hemorrhoidectomy, whatever procedure we are doing, the reference line is always pectinate line. We take all the references from dentate line or pectinate line. But we are doing, when we are doing fistula surgery, no matter which procedure, whether it is a sphincter cutting procedure or a sphincter preserving procedure, in a sphincter preserving procedure, whether it is lift, VART, Phylac, whatever it is, the reference line is always anorectal ring. So anorectal ring is the reference line in fistula surgery because you have to save that. Just like in gallbladder surgery, people say always keep the CBD safe. In pelvic surgeries, always keep the ureter safe. So something which you want to save should be, you should see that thing. That should be visible. Then only you can keep it safe. In the same manner, in fistula surgery, anorectal ring you should be able to feel, and all the distances, all the references should be made from there. So this is again MRI picture, how this infection can ascend within the intersphincteric plane. We have a case also today, going all the way to the abdominal wall, the disease still limiting itself into the extraperitoneal space. So you can see from below it can travel supralevator space, lateral pelvic wall, and then coming anteriorly to space of Ritzius, and then from space of Ritzius it is offshooting to abdominal wall or groin areas. So within the sphincter complex, it can go up and then it can lead to infection in the abdominal wall. We have one case also for demonstration this afternoon. So this is how MRI can help you about the extent of disease and its relation with the sphincter complex. So now this is a very important slide where you can see what is a simple fistula and what is a complex fistula, because it is basically the relationship with the sphincter complex which makes a fistula simple or complex. Okay, because this is the crux of this presentation, that how to differentiate clinically or radiologically or intraoperatively between a simple and a complex fistula, because that will be the deciding factor whether you are going for a fistulotomy, which is a gold standard for simple fistula, or you are going to venture into a less invasive or minimally invasive procedure to save the sphincters. So now, because all these fistulas are primary fistulas, so internal opening in all these fistulas is at pectinate line. Earlier it was thought of that internal opening is high up. Internal opening is never high up. If it is high up, usually it is iatrogenic. So internal opening is at the pectinate line. It is not the internal opening which is high or low. It is basically the tract which is high or low. So relationship of the tract with the sphincter complex. So you can see this red line, all the disease which is below this line is simple. If the disease goes above this line, it's complex. So I will just show you with this straw that how a disease can be simple or complex. See, this is my fist and this is a pen. This is continence. I'm holding this pen. This pen is not dropping down. Even if I try to force it down, it is not dropping down. And this is the external sphincter complex. This is the topmost muscle, which is called as puborectalis or anorectal ring. This is the lowermost muscle, the 3 tiers as we described earlier. This is the subcutaneous part of external sphincter. This is the superficial part of external sphincter. This is the deep part of external sphincter, and this is puborectalis. So these 4 muscles, they are holding this grip. The pen is not falling down even on pressure. This is called as continence. Now a fistula is like this. This is a simple fistula because it is only crossing the subcutaneous part of external sphincter. In order to treat this fistula, I will cut this muscle. The fistula is gone. And the grip is still good because the pen is not falling down even on pressure. So fistula is gone and continence is maintained. That is the purpose of your fistula surgery. And the second type of fistula would be this, which is, again, you can see the internal opening is here, but the tract is crossing the superficial part of external sphincter. In order to get rid of the fistula, we cut this muscle, we cut this muscle, we do a fistulotomy, the fistula is gone, still the grip is good, pen is not falling down. Again, continence is maintained, fistula is cured. So this is also a simple fistula. Now you see the third situation, that is this. This is the subcutaneous part, this is the superficial part, deep part. This tract, internal opening is still there, but the tract is crossing the deep part of external sphincter. So in order to get rid of this fistula completely, I have to cut this muscle, subcutaneous, superficial, and deep, and the fistula is gone. So I do a fistulectomy, the fistula is gone, pen is still there, but now the grip is not so strong, so if I put the pressure, pen is gone, and there is incontinence. So this is what we have to prevent. Now you have another situation like this. The fistula is crossing the top muscle, that is the anorectal ring. In order to remove this fistula completely, we divide all these muscles. The fistula is gone and the continence is also gone. So this is how we have to understand that the reference line is this, and that is anorectal ring. All the distances, intraoperative distances, when we are doing a clinical examination, we can ask the patient to do, to just hold back the feces, and you can feel the anorectal ring. So all the distances should be measured from there. The reference line is, you know, all these classifications can be sometimes difficult to interpret, but if you just give, you know, importance to these small little things in your clinical examination, see the MRI, talk to the radiologist, and intraoperative assessment, always try to feel the anorectal ring and then see the disease, how far the disease is below the anorectal ring. And when you're doing a fistulectomy or fistulotomy, again, then you have to go and feel the anorectal ring. So relationship with the anorectal ring is very important, and that's how you can, simple fistula can be treated by simple method, that is a fistulotomy, which gives excellent results, 100%, almost 100% without any incontinence. Complex fistula, if we do a fistulectomy, then we need to do a primary sphincter reconstruction because we have cut, we have divided substantial muscle. Or the other option is we do a sphincter preserving procedure, that is we try to treat this fistula without cutting the sphincters. So 2 things are important. One is proper mapping of the disease, which you can do in OPD, and then with MRI, of course not in all cases, very simple cases you can omit MRI, selective use of MRI. For all the complex cases, recurrent cases, or where OPD examination does not give you adequate information, go for MRI. And of course, intraoperative mapping, and accordingly, you have to always keep anorectal ring intact and take that as a reference line and do all the procedures based on that. Thank you so much. Any questions?
Thank you, Dr. Ashraf Ahmed, for that innovative talk. Finding the internal opening in fistula, it might be easy or you might never find it. Now, Dr. Kannan will enlighten us on strategies to finding the internal opening in fistula.
Very good morning to all. First of all, I thank Dr. Balu and the Department of Surgical Gastroenterology hosting this ASRSI South Zone Proctology meet. It is Fistula Demystified. You all know our ASRSI national faculties are here and our other senior faculties all over the South are here. So Balu is very well known for conducting all these sort of programs. And I'm seeing a lot of my classmates and friends and the seniors and the known faces. So in the management of the fistula, the identification of internal opening is very, very important, at most important, because whenever there is failure of identification of internal opening of the fistula, there is more chance of failure. In fact, the recent study shows there is 20-fold increase in chance of recurrence if you are not finding the internal fistula in case of fistula management. What happened? Okay. And the duration of the history and as well as clinical finding is very important. So invariably the patient coming to the hospital with the complaints of all these clinical findings, especially perianal discharge, sometimes pain, sometimes there is swelling in the external region, it could be sprout out granulation issue like that. So for which the detailed history of the patient and as well as the physical exam is the key in case of management of fistula and as well as for it helps the identification of the internal opening. Invariably the external opening, you know, you all know very well, there is a sinus, some sort of fit or there is a redness in the region or discharge from the external fistula side. But good cells role, you all know, there is a imaginary transverse horizontal line. Anterior to that, there is invariably radial opening into the anal canal, and posterior to this line, invariably it is curvilinear and opens at 6 o'clock position. But in some of the situations, there are some exceptions. If the external opening is beyond 3 centimeter or further away, even in the anterior, it invariably curvilinear and opens in the posterior midline. But it is not true in all cases. That's why nowadays we are doing MRI is the gold standard procedure for assessing the fistula. So how to locate the internal opening? This is the key element of our topic. One, invariably the opening of the internal fistula is at the 6 o'clock position in the midline. Invariably it is at dentate line because already the previous speaker told you that you all know very well it is arising from the cryptoglandular gland secondary infections. And there may be at the opening site there may be hypertrophic papillae or puckering will be there. Sometimes it's associated with the scar, sometimes it's associated with the ulcer. Sometimes there might be a fibrous fit. If you examine carefully, there may be a fibrous fit, and there will be soft granulation tissue at the site of internal opening. So these are the clinical identification marks in location of the internal opening in the anal canal. And there should be some elevation because of the edema and inflammation and infection, and that could be pus discharge from the internal opening, and there will be cord-like structure of the fistulous tract will be there while palpating, and in bidigital or bimanual palpation there will be induration, and the surrounding mucosa will be immobile. But the important things in case of assessing the internal opening is digital rectal examination, for which you have to assess first the externally where the external opening, and then if it is anterior, invariably most of the time it is opens radially in the anterior midline. Suppose if it is in the posterior, most of the time it opens in the 6 o'clock position. There are some exceptions, but invariably. So for which first you see the external opening, and as well as the whether it is single opening or multiple openings, whether associated with the just infection or some other local systemic inflammations like IBD, like Crohn's disease we are getting some days much cases. And if the patient is having any associated boggy swelling like abscess, if there is abscess, the opening will be either below or above. So if it is subcutaneous abscess, the opening will be above the abscess site. If it is supralevator or ischiorectal abscess, the opening will be in between or lower the boggy swelling. And invariably the ischiorectal region examination and as well as gentle perectal examinations key element in case of identifying the internal opening. So this picture shows the internal opening site at the site of dentate line. These are all already very denoted. This is the gentle palpation of the fistulous tract and goes along the fistulous tract while doing the perectal examination, especially if you are following the tract from below upwards, then you can reach the internal opening where it is. So most of the time it reaches at the dentate or little above. Sometimes it may be associated with multiple openings. Some of the cases there will be multiple openings, but primary internal opening will be at dentate line. So like that we have to see by palpating like this, invariably there will be a pit or papilla-like lesion or ulcer or puckering or induration will be there. So anoscopy is another very important diagnostic tool where you can directly visualize the internal opening, whether it is in the midline or some other places. And imaging study, that is next important thing in the assessment of the internal opening is images. We are not doing images for all the cases. Only in case of primary opening not clinically able to assess, or in case of recurrent or patient has with multiple fistulas, or patient is having suspected high fistulas or complex fistulas, or sometimes there might be missing of primary openings. So these are the numerous number of investigations. You all know fistulography, endorenal ultrasound, MRI, CT scan, but each and every one is its role. Here fistulography is it is absolutely one, but pallidal canal is used, and you can take the AP view, anterior posterior view, and as well as axial view to assess the primary and secondary tracts of the fistula. Even in periphery of the centers, most of the centers, they are doing the fistulography, want of money and affordability of the patient factor. And the endo ultrasound, since we are having the separate talks in detail, after that, no need to go through in detail, but this will assess the anatomy of the anal canal, the muscle intensity, and as well as the opening site of the internal fistula by doing the endoanal ultrasound. And the CT scan. CT scan in case of fistula, especially if you suspect any systemic infection or IBD or tuberculosis, if the patient coming with the multiple openings, there the CT scan is very important. It will assess associated abscess or associated systemic inflammations or pelvic inflammations like that. So there the CT has very good role. And the MRI, this is the gold standard. Usually you can invariably assess where the internal opening is. Sometimes, though there is some assumptions, we cannot assess properly on the table, but MRI will tell us probably where the internal opening is. So these are the MRIs that we are having a separate talk, we'll discuss. So what are the procedures clinically we are able to locate in the internal opening. One is proper external opening by injecting the hydrogen peroxide, saline, methylene blue or betadine. So these are things on the table we have to inject through the external opening into the internal opening that we can assess. Second one is gentle probing of the fistula tract from external to internal. Third one, you can divide the external opening and then cure the tract and then pull out and then assess the length of the tract. There you can visualize where the internal opening is. Fourth one is the waft, you know very well. Here let us go one by one. Full screen, Varma. Full screen. So here, after putting the anoscope, suspected internal opening at 6 o'clock position. So we are injecting the hydrogen peroxide through the external opening. There, just visualize where the hydrogen peroxide is coming out. That is the internal opening. So this is the one of the best method, invariably in all clinical setup. We can inject the hydrogen peroxide through the external opening and look for the internal opening in the anal canal. So see this video till the end. So patients having multiple openings. I injected the hydrogen peroxide in the upper opening, but it is not coming out through the anus and as well as other openings. And then I suspected this could be the primary tract. So I injected the hydrogen peroxide through this opening. So through this, see it is coming into from the anal canal and as well as the upper tract. So this is the primary fistula tract. So it has to be dealt very much. Otherwise, patient will have the recurrence. And the gentle probing is the key element in the case of identifying the internal opening. Otherwise, invariably it leads to false passage. See, after injecting the hydrogen peroxide, we identify the internal opening. After that, before the procedure, we have to gently probe the tract from the external to internal. So this video also shows a gentle probing, where sometimes there will be edema and inflammation, abscess, and there will be cavity associated with the internal opening. In that case, you cannot get the straightforward pushing of the tract. So for which you should be judiciously gentle and probe the metal probe from external to internal and then gently bring out through the internal opening. So here we should be very careful, otherwise this will lead to false passage, invariably patient come with the recurrence. So another one. So cure out the external tissue around the external opening and then pull it out. It appears like, I will show you this video again. It appears like the internal opening is superficial or in the subcutaneous plane, but it is not true. So after coring out, it goes deep and it is superficial to the dentate line. So since it's eye fistula, the opening was deep inside, I put this sheet on for this patient. So another one patient has with the piles and as well as the fistula. There, sometimes even after the video is upside down. So if the even after injecting the hydrogen peroxide is not coming through the internal opening, and then after remove the piles, I cured the tract and then pulled out and then slowly I dissected the tract and then complete the procedure. So sometimes patient may come with both piles and as well as fistula. This will lift, the success of the lift is based on the identification of internal opening as well as the ligation of the internal opening at the intersphincteric plane. This is another patient actually came with prolapsed piles and pain. So clinically assessed as a fissure. But on table while examining the patient, see, there is a pit-like lesion at 6 o'clock position. It is nothing but fissure associated with the buttonhole deformity. So that is the buttonhole deformity site. So that is the initial stage of fistula for which I just open the pit site in the external, that is the fistula. So fissure fistula complex, that is piles, both has to be dealt. So sometimes what happens, patient complains only the piles. If you do the piles only, they will come with the fistula later on. That's why the on-table examination is key in case of fistula medicine. Sometimes patients having multiple internal openings, one primary and other secondaries. And the final one is the waft. This is the another one, those who are experienced the waft, those who are doing the waft, it is easy way of identification the internal opening by injecting the fistula scope from external to internal, where if you look out the mucosal plane, there will be bright dot, that is the internal opening site, the lower end at 6 o'clock position. So, in case of fistula management, the identification of the internal openings is the key element in the success. If you are failure in attempting identifying the internal opening, there is chance of recurrence and as well as relapses. So, no matter what procedure you are doing, which procedure you are experienced, which procedure patient requires, the key element is identification of the internal opening. Thank you one and all for patient hearing. Any questions? Because since it's a very common topic and everyone knows about the technique and details, I don't think there won't be much doubts. See, clinically, if you assess if the patient is having only low fistula, and you can easily identify the internal opening below the dentate line, in that case, no need. Suppose patient is having suspected opening above the dentate line, or associated abscess, or complexity, or multiple openings outside, in that case, we have to go for the imaging. See, it is not for all cases, especially in the obese cases, sometimes we missed out. For the obesity patients and the chronic diabetic uncontrolled, those are the main candidates for the fistula. In that case, clinically, if you suspect there is high fistula or complex, definitely you have to go for the MRI. Otherwise, you are very confident that patient is having only low fistula or small subcutaneous abscess, there won't be any extension. The problem in the abscess is sometimes patient may not allow us to examine. So invariably we should not burn our fingers. So in that case, if the patient is affordable and if you are suspecting, go for the investigation. The ideal one is MRI. Medico-legal aspect is compulsory, but clinical aspect, if you are confident, no need. But the indications are, you know very well, it's a high fistula in ano or complex or recurrent or having associated abscess like that. Yes, because the primary associated with the blind ending, sometimes the primary itself blocked due to inflammation or some reaction. So in that case, even the arterial vessel not coming out. We have to assess and reassess. That's why the traction technique of the fistula tract is very ideal one. Even for the in-between fistulas or low fistula or high fistula, sometimes we may not be able to identify the internal opening. But if you core out the tract and then pull, you can easily identify the internal opening site. Thank you.
Thank you, Dr. Kannan. Next we have with us Dr. Tilagarajan, radiologist, PSG Hospitals, to take us through the nuances of MRI imaging in fistula.
Good morning to all. My talk has been already covered by the previous speakers, so we'll see briefly about the MR imaging in fistula. Why MRI? Why not CT or fistulography? Fistulography is not, we are not doing routinely nowadays because it is very difficult to identify the tracts. Sometimes if the tract is not active, the contrast will not enter. Then why not CT? CT is a good tool for to assess the perirectal inflammatory disease, but sometimes subtle thin tracts can be missed in CT. So MRI is the ideal choice. MRI, it is non-invasive. We can do multi-planar imaging. We can take images in all planes, axial, coronal, and sagittal. It gives good soft tissue contrast and resolution. It is better to identify the fistulous tract in relation to sphincters and pelvic anatomy, and to assess the tract in terms of length, extent, internal opening, activity, branches, and abscess, etc. Coming to the anatomy, it has been covered by the previous speakers. The internal sphincter is formed by the extension of the circular muscles. The external sphincter is formed by the condensation of levator ani and puborectalis muscle. Coming to the MR image, the sphincters, the internal sphincter, it appears bright on T2 weighted images, whereas it appears dark on T1 weighted images. The external sphincter, it appears dark on both T1 and T2 weighted images. On contrast images, the internal sphincters, it enhances more compared to the external sphincter, because the internal sphincter, it has got more blood supply than the external sphincter, so it enhances brighter than the external sphincter. This is the internal sphincter. And this is the external sphincter. Coming to levator ani, in classification of the fistulous tract, whether it is supralevator or infralevator, the levator ani muscle plays an important role. This is the levator ani muscle. It condenses with puborectalis muscle and to form a external anal sphincter. This is the levator ani muscle forms the external sphincter. Physiology, pathophysiology, it has been covered by the previous speakers. It is because it is primarily due to the cryptoglandular abscess. When the abscess ruptures, it enters into the various planes to form a fistulous tracts. Epidemiology, I'll skip this slide. Protocol, generally we do contrast enhanced imaging to identify the tract and the activity, or is there any abscess or inflammatory changes around the anal canal or around the abscess. Generally, T1 hyperintense marker like vitamin E capsule is kept at the site of the discharge in the external opening, because if the tract is not active, it guides us to assess the internal opening or the path of the tract. Anal clock, I'll skip this slide. St. James, Parkes classification, it has been dealt already. And St. James sinuosity classification, it was proposed by radiologist. It has got grade 1, 2, 3, 4, and 5 according to the tract and the intersphincteric space. I'll skip this. The other one, latest one is like it has been already covered. Low intersphincteric, low transsphincteric, anterior high transsphincteric, posterior high transsphincteric, and high intersphincteric fistula. Low intersphincteric, it travels between the two sphincters. It occurs all around the anus, whereas low transsphincteric crosses both the sphincters. It occurs around the anus, but more commonly in the anterior and posterior location. So low intersphincteric around the anus in all directions, whereas low transsphincteric predominantly in the anterior and posterior location. And anterior high transsphincteric The internal opening is located at 11, 12 and 1 o'clock position. It passes above the sphincters into the perineal space and to the external opening. It extends laterally to the ischial-anal space at 1 to 11 o'clock position. The anterior high transsphincteric, the opening is at 11, 12 and 1 o'clock position. Coming to the posterior high transsphincteric, internal opening is always at 6 o'clock position. It passes between the external sphincter levator ani and to the post-anal and ischial-anal space. So the extension is into deep post-anal and ischial-anal space. It does not have intersphincteric abscess or intersphincteric granulation tissue. Coming to the last one, it's a complex fistula. There are 3 types of spread. It can spread upwards to form a supralevator abscess. It became a chronic abscess without external opening. The second type, it spreads laterally above the external sphincter at 5 to 7 o'clock direction into ischial-anal space to the external opening. The third one is, it travels posteriorly to deep post-anal space and ischial-anal space to the external opening. The internal opening is always at 6 o'clock position. Coming to the MR appearance, generally the fistulous tract, it appears hypo or iso-intense on T1 weighted images. If the tract contains blood, it will be bright on T1 weighted images, and always hyper bright on T2 or stir images. When there is surrounding inflammation, it shows peripheral post-contrast enhancement. The shape is mostly curvilinear or sometimes horseshoe shape, with or without associated abscess. Abscess, they show restriction on diffusion weighted images. We will see some MR images. This is the intersphincteric fistula. You can see this is the external sphincter which appears dark, and the internal sphincter, it appears bright. 2 hyper-intense tracts in the intersphincteric space on either side. And both the tracts are coming down and opens at 6 o'clock position. This is an intersphincteric fistula with abscess. There are 2 peripherally enhancing tract in the intersphincteric space. The other peripherally enhancing collection in the intersphincteric space at 4 to 5 o'clock position. These 2 tracts combine together, joining with the abscess, and opens at 5 to 6 o'clock position. This is intersphincteric abscess with perianal abscess. If you see, this is the normal intersphincteric fat. On the right side, there is some hypointensity in the intersphincteric plane, which appears bright on stir images and showing enhancement in the post-contrast images. There's another tract in the intersphincteric, from the it shows enhancement in the post-contrast images. It is combining with the abscess in the perianal region on right side with surrounding inflammatory changes. These 2 extrasphincteric fistula, this is the external sphincter. There is a fistulous tract on right side and on the left side, which is limited by the levator plate. This is the extrasphincteric tracts, complex fistulous tract, and showing multiple ramification. One of the tract is seen above the supralevator extension. There is extensive perianal inflammatory changes showing post-contrast enhancement. There is no definite communication with the anal canal, suggesting perianal abscess. As a case of extrasphincteric abscess, enhancing tract in the extrasphincteric space, showing restriction on diffusion weighted imaging, suggesting extrasphincteric abscess. In this case, there are 2 collection, two tracts on either side in the intersphincteric space and the horseshoe-shaped fistulous tract. The definite connection between the this tract and with this tract is not identified, but in the post-contrast imaging, it crosses the sphincters, suggesting transsphincteric fistula. This is the case of transsphincteric, extrasphincteric tracts with supralevator extension. Right side there is a extrasphincteric tract. Left side there is multiple collections or multiple tracts with extension into supralevator space and the base of the bladder. Again same, two collections in the supralevator space and the another collection in the perirectal space to form the horseshoe-shaped fistula. Perianal sinus, some inflammatory changes in the perianal region with no definitive communication with the anal canal suggesting perianal sinus. This is the transsphincteric tract at 12 o'clock position extending anteriorly into urethra, forming urethral extension. Extrasphincteric collection in the ischio-rectal space with surrounding inflammatory changes suggesting ischio-rectal abscess. Reporting checklist is already covered and the fistula map already covered. This is the recording of the anal fistula map. Internal opening at 6 o'clock position, intertranssphincteric tract, high transsphincteric, deep posterior anal space tract, and intersphincteric tract with cavity, external opening at 9 o'clock position, and the total length of the tract is 5 centimeters. Differential diagnosis, acne coagulobeta, hidradenitis, pilonidal sinus, and actinomycosis, tuberculosis, proctitis, HIV, lymphoma, and carcinomas. Thank you. Sometimes if the tract is not active, if we contrast, or clinically if there is no signs of active inflammation, after giving contrast, if the tract enhances, we can find the internal opening or we can assess the extent of the tract after giving contrast. Mostly without contrast we can identify. Without contrast, we can identify mostly 90-95% of the cases. Some centers, they are injecting the contrast into the external opening, and after that they do MRI with contrast, IV contrast.
And is all sequences needed? Can you be little selective in an uncomplicated patient if you do an MRI?
Yeah, axial T2 stir images must. Diffusion weighted, if we suspect any abscess, we can do diffusion, and post contrast in all 3 planes.
Thanks.
Around 10 to 15 minutes.
Thank you, Dr. Tilakarajan. Next, we have with us Dr. Vikrant on his talk on transrectal ultrasound in fistula.
Good morning all. I thank Dr. Balu and the organizers. As we all know that MRI is the gold standard imaging for anorectal fistula. but ultrasound has its role. It's a preliminary investigation of choice, whereas it is cost effective and less time consuming. It's dynamic and easily available. So ultrasound we do with mainly 3 types of probes. Endocavitary probe. This probe is a end-fire probe. And next one is the transrectal biplane probe. Here we have the field of view from 120 to 180 degree. And the third probe is high resolution 3D side fire probe. Here the field of view is 360 degrees. So most of the images we see today are done from this probe. So preparation, preferably routine cleansing enema 2 hours before the examination can be done, and sedation is not necessary. We know the clock position 1 to 12 o'clock. The anterior aspect will be the 12 and posterior 6. Right lateral will be 9 and left lateral will be 3. And coming to the imaging, this is a 5-layer pattern of the anal wall. So the first layer will be the interface between the probe and the subepithelial tissue, and the next layer will be the slightly echogenic subepithelial tissue, and the next one is the internal sphincter, which appears hypoechoic ring, and the next is the thin longitudinal muscle, and the periphery is the thick echogenic. This is the external sphincter. So we have to do 3 levels of assessment of anal canal in axial plane. So the first level will be the topmost level will be the where we will see the puborectalis muscle. This is the sling of puborectalis, and the next layer will be the where we can see the middle layer is the thick external sphincter, and the internal sphincter will be visualized, and the lowermost level is the subcutaneous level where we can see the subcutaneous level of external sphincter. Internal sphincter will not be visualized. So these are the reconstructed images. This is the coronal and longitudinal image. Here you can see the topmost layer is the puborectalis muscle, and next is the external sphincter, superficial part, and the subcutaneous part. And the internal sphincter, you can see the hypoechoic area, which ends at the junction of superficial and subcutaneous level of external sphincter. Here in the coronal image, you can see the internal sphincter and the thick external sphincter. And next, the 5-layer of rectal wall. The rectal wall is we have alternating hypo and hyperechoic areas, thin layers of interface. This hyperechoic area is the interface, and the next one is the mucosa, which appears hypoechoic, and the submucosa hyperechoic, and the next layer is muscularis propria hypoechoic, and next is the serosa, which appears hyperechoic. So there are 5 presentations of anorectal abscesses. This is a perianal abscess, next is the issue anal, and submucosal, and supralevator, and infralevator. The horseshoe extension of anal abscesses are 4 types. That's a perianal, ischianal, intersphincteric, and supralevator. And this is a classic classification of by Parks. 4 types of fistula, we all know this: intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. And what's the need for TRESS? It's a preoperative ultrasound image can prevent the difficulties expected during surgery. And these are the scenarios where we can do preoperative ultrasound. Internal opening cannot be identified, the fistulous tract cannot be probed, and unexpected fistula anatomy, and fistula without external opening, and synchronous fistula, and compromised anal canal. So the limitations for ultrasound are, it's operator dependent, and insufficient penetration of ultrasound beyond the external sphincter, and it limits the ability to see the issue anal and supralevator infections. So we will see some images done with the 360-degree probe. This is the axial plane and this is the coronal plane. Here we can see a hypoechoic large abscess in the left anterior perianal space. Here we can see the external sphincter, but internal sphincter is not visualized. So it's the lowermost part with the abscess in the perianal space. So this is the abscess in the posterior intersphincteric space. This is the external thick external sphincter and the internal sphincter. The abscess is between the external and internal at 6 o'clock position. And here in this clinical image, we can see an inflammation in the left gluteal region. So in image, we can see a large left lateral ischioanal abscess. This is a coronal image, the large abscess appearing hypoechoic. And this, in this axial image, you can see an abscess just adjacent to the puborectalis muscle. It's a ischioanal abscess extending to the supralevator space. This is a coronal image. You can see the puborectalis muscle. It's traversing the puborectalis muscle, the ischioanal and the supralevator abscess. This is an intramural abscess at the level of prostate. Here you can see the anteriorly the prostate, and at that same level there is a large intramural abscess. In this image, you can see a tract in the intersphincteric space at 3 o'clock position. You can see a small hypoechoic tract at the 3 o'clock position. It's an intersphincteric. You can see the internal sphincter and the external sphincter. Here in this coronal image, we can see the arrows are pointing a long intersphincteric abscess traversing down. You can see the internal sphincter and the echogenic external sphincter. This is the next image. You can see a posterior intersphincteric space tract. Here, hypoechoic area. Here in this longitudinal image, we can see the intersphincteric tract. This is the tract between the internal and external sphincter. Here, another intersphincteric tract. You can see in the anterior at 11 o'clock level. The same at longitudinal image, you can see the tract, hypoechoic tract. Here there is a right lateral high intersphincteric fistula traversing the subcutaneous external sphincter, and the length of the fistula, it's less than 1/3 of the anal canal. You can measure the length in this coronal plane. Here there is a posterior intersphincteric fistula traversing the middle part of the external sphincter. It's a thick echogenic external sphincter. This is an internal sphincter. This image, you can see the posterior intersphincteric fistula. Arrow cartoon. In this axial image, we can see a posterior intersphincteric fistula. In this longitudinal image, we can see it's blindly ending below the puborectalis muscle level. This is the tract. Here in this axial image, we can see the left lateral transsphincteric fistula. It's traversing the superficial external sphincter. You can see the tract. This is a high right lateral transsphincteric fistula. The length of the fistula is more than 2/3 of the anal canal. You can see the length. This is a suprasphincteric tract. It's extending through the puborectalis muscle. You can see the puborectalis sling here. It's extending through the puborectalis muscle. This is a posterior transsphincteric fistula with primary and 2 secondary tracts extending through the ischioanal space. This is an anterior horseshoe transsphincteric fistula. These are the coronal images. You can see the horseshoe fistula. So to identify the internal opening, endosonographic criteria is there. 3 criteria are there. The first one is the root-like budding seen adjacent to the internal sphincter. And the second one, root-like budding with a defect in the internal sphincter. Here we can see the defect in the internal sphincter. And the third one is there is breach in the subepithelial space, subepithelial tissue and the internal sphincter. Here you can see the tract extending. So with this, in ultrasound we can identify the internal opening. And the next is contrast enhanced imaging. We can inject hydrogen peroxide and we can here in this we can see the anterior transsphincteric fistula. Due to microbubbles, there will be enhancement in the ultrasound. So we can easily identify the fistula. So here you can see the microbubble air artifacts. This is a tortuous fistula we can see in this reconstructed image. So as Dr. Samrat has detailed about this anal fistula map, we'll move on to the next one. This is a schematic diagram. Here we can see the internal opening and as secondary internal opening and the external opening at 9 o'clock. Here it's detailed pro forma is there. The internal opening it's mentioned at 6 o'clock and in the intersphincteric space there is a tract and the level high transsphincteric spaces involved and the external opening and the distance between the internal and external opening. And next is the transperineal ultrasound, which is easy to perform, non-invasive, and it gives less discomfort to the patient. In children, we can employ transperineal ultrasound in emergency situations, and it acts as a complementary tool with TRUS and preliminary tool in patients with Crohn's disease. The advantages, it provides information on the fistula extension into perineum, major labia, and scrotum. And it provides differential diagnosis with Bartholin glands infection, pilonidal cyst, and hidradenitis suppurativa. And the probes are which we use commonly are convex, linear, and microconvex probes. It's performed with the patient in the left lateral position. Here, this is the image of the perianal transperineal ultrasound. You can see the hypoechoic internal sphincter and the thick hyperechoic external sphincter. This is the anal canal. So this is the image of a perianal abscess, the longitudinal image, and then it's a transverse. We can see a abscess, posterior abscess. So this is a transperineal image, and this is a transrectal image. You can see the intersphincteric fistula between the internal and external sphincter, the same in 360 degree. This is a transsphincteric fistula between the external sphincter. So TRUS along with elastography, we can differentiate between the fibrosis and the inflammation, whereas fibrosis will be very dense and thick, whereas inflammation it will be very soft. So with elasto we can detect the fibrosis and inflammation. So to sum up, TRUS is of high value in preoperative diagnosis, and ultrasound combined with MRI, it can complement each other. Thank you. Any questions? Abscess, sir. Actually, we try to do TRUS. If not possible, we'll leave it with transperineal. If it's difficult to enter, we'll do only transperineal. So assessment, it takes 10 minutes time, that's all. Actually, the thing is, we have different types of probes. With the images which we saw are a 360-degree probe, which will be very easy to identify the tract. Whereas with other probes, endocavitary probes with end firing, it will be difficult to identify the tracts. Mostly we'll do with transperineal only. So if 360-degree probe is available, it will be easy to identify the tracts. Almost 80 to 90% we can identify the tract if it's superficial. If it's very deep abscess in the ischoanal space or a supraelevator, we can't identify. So preliminary investigation we can do with ultrasound and then proceed to MRI. Yes, sir, we can do it. Okay, thank you.
Thank you, Dr. Vikrant. Next, we welcome Dr. Rajat Raghunath to outline the principles of fistula surgery and algorithm for fistula management.
Thank you to the organizers for giving me this opportunity. When Dr. Balu called me and said, I'm going to be talking about principles of fistula surgery and an algorithm of fistula management, I realized that either Dr. Balu likes me a lot or he doesn't like me at all. Because every surgeon has his own algorithm in his head, which when he sees a complex fistula or a difficult fistula, he knows what he's going to do, what works for him, and what gives him the best results. And it would be extremely naive of me to tell a group of senior faculty and teachers that this is how we should manage a fistula, and it will be very wrong of me. So I'm just going to present a little bit about fistula surgery, what we have learned, what my institution gives me as an experience, and a basic algorithm which works for us. And I'm going to stress on that, works for us, and that is what we do. So whenever we think of goal of fistula surgery, we think of you have to make sure that you eradicate the fistula, you want to preserve sphincter function, and you want to make sure the patient is not unhappy, doesn't come back with a recurrence. But fistula is a very interesting surgical option because a lot of it, unlike many other fields, depends on the judgment of the surgeon, the experience of the surgeon, the finger where it is going. Is this muscle enough for me to cut? Have I cut enough sphincter? Have I cut too much sphincter? All this makes a big difference in the management. So a lot of it has already been covered and I'll rush through these things. So assessment, what do you want to know when the patient walks in? I want to know what type of fistula this is, what is the continence of the patient, what is the general status of the patient, and are there any red flags that I'm missing? So examination, as previously by my speakers, we do a distal rectal examination, a proctoscopy, and a rigid sigmoidoscopy. We do a perineal examination, look for external, internal, palpable tracts, scars. We hope that usually there's a single internal opening with one main tract, and we look for branching patterns. Hopefully most fistulas are like this, where you see one external opening and hopefully one internal opening, which on table gives you a nice tract that can be probed. Sometimes fistulas are like this, where the external opening is at the base of the scrotum. Again, internal opening at 12, which you can lay open. I don't wish anybody has fistulas like this, which you have to manage, which we struggle with multiple times, with multiple external openings, not knowing what to do. So somebody asked, when would you do an MRI? I would do when I'm not sure, when I'm confused. When the anatomy to me in my head is not clear, then you do an MRI or an endoanal ultrasound. These are beautiful pictures already been shown of the MRI and the ultrasound, and I won't repeat them. What we do is we assess all patients for continence, both subjectively and objectively. History, you look for patients with previous surgery. Incontinence, we do a clinical examination. As the previous speaker said, you ask them to cough, and you look for the puborectalis sling. All our patients undergo anorectal manometry to look for both squeeze pressures and resting pressures, and all of them have continence scores with the Sen marks and the Wexner score documented in the chart to know how good their continence is. We look at general fitness, old and frail, comorbid illness, fitness for anesthesia, and we look for these three red flag signs that we are seeing more and more. Tuberculosis, something like this. In our own published series, we have shown that 7% of the fistulas that come to Vellore are tuberculosis positive, and for them, ATT works very well and does not need any surgical intervention. So all our patients have MGIT and TB PCRs done in the fistulous tracts when we take them to theater. We look for Crohn's, quite obvious, and you see it with the multiple scars and wounds that are seen in a Crohn's perineum. And rarely we also see these kind of patients with a malignant fistula and ano. So in summary, anatomy, primary, secondary tracts, incontinence status, general fitness, and other diseases. So finally, the management. So usually we do a staged approach. If a patient comes to us with an abscess, we just drain the abscess. I'm sure in hands of a very senior and experienced surgeon, they're able to find the tract, they're able to, even some people are able to do a lift in a primary abscess situation. But in our setting, we tell our juniors, just drain the abscess, drain the pus, and wait. This is because we feel that a lot of times the abscess always doesn't lead to a fistula. And if the over-enthusiastic junior surgeon tries to find the fistulous tract by probing, very likely he will make a false tract. So we drain the abscess, and if the drainage persists for about after the operation for about 6 to 12 weeks, an average about 3 months, we take the patient after evaluation for the examination under anesthesia to make the big difference between whether this is a simple fistula or a complex. Preoperative preparation from our side, antibiotics, we don't give any preoperative antibiotics for our operation. Anesthesia, we usually like to do it under general and spinal, but it can be done very, very well under pudendal nerve blocks. All our patients have it in lithotomy, rarely in prone jackknife. We do an anal examination, and as Sir said, we try and definitely find the internal opening. So questions we ask on table is, can this fistula be laid open? You already know this before going to theater, if you've already seen the patient before, you know whether the fistula is laid open. So for an intersphincteric, low transsphincteric, good baseline continence, and no Crohn's or TB, usually we would lay the fistula. But we are very wary of women patients who have anterior fistulas, because it's very easy, especially in older women, to cause incontinence in them. And then look for multiple previous surgery. So simple fistula, by definition, minimal involvement of the external sphincter, less than 30%. Low-lying fistulas are usually simple fistulas. So for simple fistula, what we do is a primary fistulotomy. Lay it open, healing is over 90%, but you have to make sure you lay open the tract, you curate the tract and the internal opening. Some people have found that marsupialization of the tract helps. We generally don't, but it's a choice that can be made. Outcomes, fantastic. Success in healing, 79 to 100%. But if you look, incontinence rates in literature is from 0 to 82%. Now the 82% is a patient who should not have had a fistulotomy, but ended up having a fistulotomy. And that judgment is what is very important. This is just a pictorial diagram of a fistulotomy. I'm sure you'll see this afternoon. Some people like to do a fistulectomy, excise the whole fistulous tract, causes longer healing time, higher chance of incontinence. not really recommended because it really doesn't change the healing rates. So then, if it's not a simple fistula, it's a complex fistula. So more than 30% suprasphincteric, women with anterior fistulas, multiple tracts. And these are patients who are not fit for fistulotomy. What do? At that first instance, we drain the sepsis, we establish tract anatomy, and usually that means we put in a seton. We put in a seton. For us, we usually put in a draining seton, which is usually a vesiloop or a very thin infant feeding tube. There are companies now who come with ready-made tubes, which can also be used. So a seton placement, what does it do? Keeps the fistula tract patent, helps drain the sepsis, prevents symptom recurrence. I'm not saying recurrence of fistula, but a symptom recurrence. And what do we use? The same thing that we said, shown again, a beautiful picture by Dr. Kannan of using a silk thread. This is one of our patients who had very complex fistula where we have put vesiloop setons. Other side, a high fistula where we put an infant feeding tube as a seton. Finally, seton is placed, sepsis is controlled. Usually we wait for about 6 weeks to 12 weeks. And then this is what we're thinking about. What are the options of treatment next? So there's a myriad of options available. There are so many acronyms. I'm very grateful I passed that stage that I need to mug up these acronyms. So, but these are all the general possibilities. I'm just going to go quickly through them one by one. Cutting setons, quite popular sometimes, where you put what they call in the Western world a snug seton. It slowly cuts through. The idea is it will cut through the sphincter, but if it cuts through slow enough, you won't cause incontinence. But the best cutting setons do have higher incontinence rates. So not really something we do regularly. Mucosal advancement flap is one of our go-to procedures. I'll be showing a video of this afternoon, something that we do quite often, and we find our success rates are quite good with this. Lift, fantastic results. I feel it's not the easiest operation unless you're really experienced in this, but we do it in a few patients, very good sphincter preservation rates, and if done well, excellent success rates. WAFT, video-assisted anal fistula treatment, again, something very popular in the West, because in the West, they're extremely scared of incontinence, very high chance of taking you to court, the doctor to the court if you cause incontinence. So WAFT, where we go into the tract, look for secondary tract, and burn the tract completely, very, very low chance of incontinence. You tell the patient, as one of my teachers would say, there's a 60% chance this will get better. But you're not going to, and there's always a chance of doing this again and again, which improves the success rates. So something that has come up quite recently, quite popular, especially in the West. Bit expensive, this whole setup, very easy to break that scope. Next is FILAC. This is laser ablation of the scope, something that we are recently getting in our institute. Initial controversies was it's a bit blind-ended, and but in junction with WAFT has shown good results with good healing results and less incontinence. Then fistulectomy and sphincter reconstruction. Sorry for that. Fistulectomy and sphincter reconstruction. You take out the whole sphincter, take out the whole fistulous tract, cut the sphincter, and at that then and there, repair the sphincter. In the hands of senior surgeons with experience, excellent results, but we are a bit worried about doing this for every fistula because of the risk of incontinence. I'm going to skip this. This is a small video of us in the very, very early days of doing a fistula plug, which we are now thankfully not doing anymore. Other methods are fibrin glue, permacol, stem cells, multiple other methods and modifications. So this is a very controversial slide. It shows the results of the fistula procedures. Now, if you see, most of the results are in ranges, and there is not one result that you cannot come and argue with me and say, but isn't this the paper that shows this? So cutting setons, very high healing rate, in my opinion, unacceptable incontinence. Advancement flaps, good healing rate, but some amount of incontinence and sometimes a bit tricky to do. Lift, again, good healing rates, almost negligible incontinence. Waft, almost no incontinence. Fistula and sphincter repairs, excellent healing rates, but incontinence, not so sure that's great. Plugs started off fantastically, big marketing, but now the healing rates are close to 20%, so not really an option anymore. Thylac, again, good healing rates with almost no incontinence. So how to choose? One thing all trials agree is that no method is best. Multiple trials have shown that one over other is not the best. Choose a procedure you have experience with and are comfortable with. Choose between sphincter preserving always versus sphincter cutting, because sphincter preserving gives you an option of coming back again, and a cut sphincter, the patient really suffers. But most importantly, tailor it to the patient, anatomy, cost, and resources. So basic algorithm, rule out secondary causes, establish anatomy, fistulotomy if possible. If not, we would drain the sepsis with a seton and establish a clean, mature tract, and then choose any of the methods that you are comfortable with. So again, just a pictorial, treat associated sepsis, just drain it, examination anesthesia, simple fistula with all this not there. I'll just take 30 seconds more. Fistula, all this not there, you do a fistulotomy. If any of these are present, we would put a draining seton. Draining seton, wait for 6 to 12 weeks, and choose a sphincter sparing surgery based on anatomy and surgeon preference. High transsphincteric, people do lift, advancement flap, sphincter reconstruction. Suprasphincteric, usually advancement flap. Horseshoe fistula, advancement flap, lift. I leave this to your judgment, which is what the patient is doing when he's coming for the fistula surgery. Thank you. Happy to take any questions. So many times, Dr. Balu has worked with us a little bit, so he knows. Many times when we put in a draining seton, what it helps us to do in about 3 months is to establish the anatomy much better. And then we realize that what we thought initially a mid-transsphincteric fistula or a high transsphincteric fistula, actually, once the sepsis is all settled, is actually a low transsphincteric fistula. And the draining seton, then all we have to do is do a seton exit. Just exit the seton, lay open the fistula, and that itself is the treatment. So sometimes, yes, draining setons help us. So there's a lot of controversy whether draining setons actually do a little bit of cutting on the side. But draining setons, ideally not supposed to cut, but what it helps us to do is to delineate the anatomy better and maybe get it right next time, and we realize it's a low fistula and we lay it open.
Cut the mucosa and then put the seton around the external sphincter, leave it. Once the internal part heals, they pull it out and they say 90% success rate. Looks very impressive. Anyone has an experience to share?
Dr. Senthil.
Yeah, it happens. What I generally do, you put a seat on and then put in 2 or 3 tubes, silicone tubes, fix it there. Then after 2 months, you remove 1 tube. Then it comes closer. Then again remove another tube. Last you remove the seton. Then it sometimes close. Not we can't say it is 100%. It works for me.
Sir, may I, sir?
Sir.
Sir, in the trailer before the actual discussion, there was this multiple fistula. I was just wondering whether you did a diversion colostomy and then controlled it, or?
I was told I should not put up the picture because this is the kind of question will come. So yes, in this patient, we did have to do a diversion. So if you saw my algorithm, there was one that I left empty because sometimes you actually don't know, and this one required us to do a diversion, wait for all that perineal sepsis settle, and then multiple setons. Unfortunately, this patient needed about 6 to 7 operations, staged procedures before we could say that he was cured.
Thank you, sir.
So,
Yeah, Dr. Rajat, one small question for you. In your talk, you just mentioned you are planning to buy laser for fistula surgeries. So what is, in your opinion, role of laser in fistulas?
sir, very difficult question, sir, as I can expect from you. So we have the waft with us, and we do a few wafts. We have seen some evidence to say that when waft is helped with laser to burn the tract, some recurrence rates are better. So what my boss tells me is that fistula surgery is like having a whole panel behind you, and you see the patient and you think, okay, in this patient, maybe this operation is better, sir. So we are thinking of adding laser or RFA to our waft armamentarium to hopefully get better healing rates, sir.
I have seen at St. Mark's, all the cases are being taken for waft and laser ablation. Success rate, according to their chief, 40 to 50%.
Yes, sir. Yes, sir. So I'm sorry, I'm taking a bit more time. When we do quite a bit of advancement flaps, sir. And when we have to do the advancement flap for an anterior fistula at 12, it's what I would be told is like the Leonardo step of operating like this if they're in Lloyd Davis. So there, the prone jackknife makes it easier. Sometimes we find that a lift procedure for a posterior tract also, I'm sure people have more experience than me. Sometimes a lift procedure also for a posterior tract, sometimes it's easier access. As a junior, when you're assisting your boss and you're trying to help like that and there, having a prone jackknife makes it easier assistance, better vision. So for a few patients, we do get prone jackknives.
Excellent talk. In what are the cases you are doing fistulectomy? Because in your talk you showed fistulectomy invariably you are doing.
Almost, so I'm going to say again, we almost don't do fistulectomies, sir. But if we think the fistula is low transsphincteric, we will just do a fistulotomy without marsupialization, and usually the healing rates are quite good, sir.
Dr. Rajat, I think marsupialization should be mandatory.
Sure,
Why?
sir.
Why?
Yes, sir.
Because once you are cutting it, there is submucosal plexus. So there may be torrential bleeding from that place. Secondly, once the fistula tracts you are opening, both the edges, if they fall together, they will be having a bridging effect.
Yes.
Third, after fistulotomy, the wound size decreases. And last, the fecal matter does not go below the edges of the wound. So marsupialization is mandatory.
Thank you, sir.
Thank you.
Thank you, Dr. Rajat. Next, we welcome Dr. Karthikeyan to educate us on the principle and practice of seton in fistula surgery.
Single theme workshops like this, we'll always have certain topics which, whether practiced or not, will be added into the theory discussions for the completion's sake. And ceton is one such topic, and not many would be really interested in taking up this topic for a discussion, and then it will ultimately end up on the organizing persons to ultimately take up this topic and do the presentation. Ceton is one such topic. Do you think that is why I have selected this topic for this presentation? Respected professors, teachers, colleagues, postgraduates, and my dear friends, I am here not only to present about the principles and practice of cetons, but also to justify how ceton is a very important armamentarium in the treatment of fistulas, how we routinely practice fistula surgeries with ceton insertion in our institution. With the availability of limited amount of time for the presentations, I would not like to go in through the routine way of presentation with introduction, methods, techniques, etc. I would like to wander here and there, put in a lot of pictures, discuss some scenarios, and then try to tell you about the principles and what we practice in our institutions. The first is, this is an incident where we were sitting in one of the remote village for a camp, where a patient attended our camp, not because we had come from the city, not because we are eminent doctors, just because the person who's treating a fistula in that village gave him an appointment after 2 months. So that made me think about what these people do. So there's something called Sharpshutra, which they practice in Ayurveda. And this only opened up my idea, stating that these ceton pathologies is very easy and simple to understand. Ceton is basically a foreign material which is inserted through the fistulous tract. You see a picture where you see a ceton which produces an inflammation in the foreign body reaction, which obviously heals it. So this has been practiced from ancient times, from Shishruta in the history of Ayurveda to Hippocrates as well. So how does these cetons really help? There are 4 ways with which they do help in the treatment of fistulas. First is they decompress a prior fistula repair, which has already been discussed by Dr. Rajat. The second is they dry secondary tracts. The third is they convert a high fistulous tract to a low fistula. And the fourth is to do it as a primary fistula, that is time-controlled fistulotomy with regular tractions. So these are the basic 4 steps with which these cetons help us to treat fistulas. This is a patient's photograph which I took yesterday. We had operated this patient about a year ago. He is a patient with a Crohn's disease with multiple perianal fistulas. But now you see that he's got only one ceton which is placed in the left side of his gluteal region with not much of fistulous tract. So this patient has been operated about a year back with insertion of multiple fistulas in various areas. You're not able to see the scar. But I would openly like to admit that we did do a stoma for this patient because he presented to us with a perforation because of Crohn's disease, for which we did an ileostomy along with this ceton placement. The second is a scenario where we would like to convert a high fistula to a low fistula. Here is a fistula probe that passes through the internal and the external opening. We won't be able to put in such a big ceton. So what we do is we convert this into a low fistula. We try to dissect the proximal part of the fistulous tract, cut it up, and then only the sphincterous component is where we put in these cetons. At times, cetons can be used as a single modality treatment for low fistulas with not much of a sphincter involvement. So coming to these pictures, I would like to present the 2 types of cetons which has already been discussed, which are the cutting cetons, which again has been classified into tight and loose cetons, and next is the draining ceton. Cutting ceton, as I already said, acts by the principle of inflammation, foreign body reaction with perisphincteric fibrosis. Recently, the cutting cetons is used less, and as Dr. Rajat said, the incontinence rate is more for cutting cetons, and then periodic tightening with muscle division and necrosis are all the results and the complications of these cutting cetons. So for these cutting cetons, if at all planned as a primary modality of treatment, you do not need a secondary surgery, but then they do cause undue pain. So when do you have pain? When you tighten these cetons every time, patient do have pain, and the pain indicates that you need to stop that at that position, ask him to come back for another month, and then start tightening. Divide the sphincter in an uncontrolled manner, which is the most important cause for causing incontinence in these cases. A non-cutting ceton is basically used to drain, postpone the fistula surgeries, make the fistula dry, and then treat at a later date. Usually staged fistulotomy is done around 6 to 12 weeks later. So these non-cutting cetons may result in higher recurrence or persistent rates and sometimes need secondary surgeries. So what are the materials that you use for making a ceton? Here you see a picture where we use a hybrid technique of both a cutting as well as a draining ceton which is inserted here. We have placed a vessel loop as well as a proline which has got a knot. This is a second picture where we do have a infant feeding tube which acts as a ceton here. This is a third picture where you see a small amount of a silk which is kept there. So what kind of cetons do you use? There are multiple things that can be used as a ceton. You can use silicons, rubbers, stainless steels, catheters, even the cut strip of gloves when you don't have these vessel loops or any other material, and sutures can be used. Correct use of cetons minimizes symptoms from the ceton itself and optimizes its effectiveness. So this looks like a very busy slide, but what I would like to point upon these things are various materials are used. You can use monofilament as well as polyfilaments, silicons, drains, medicated cetons and not-free cetons. Of these things, silk is known to produce a lot of intolerability because it causes more amount of foreign body reaction. Cost-wise is very effective for rest of the cetons except for the medical cetons and the not-free cetons. So how do you pass these cetons? The first important step to passing a ceton is obviously the identification of the internal opening, which is the primary most important part which has been already discussed. Coming to the various techniques of passing cetons, there are various techniques that we try and improvise on. The one is the direct insertion, where you have a big tract, easily passable tract. You would be able to put in a ceton very easily without any instruments. The second is a railroading technique. The third is a thread-on-thread technique, and fourth is the infant feeding tubes. The first is a picture where you see a probe being passed. This is a reverse probe where we find the internal opening from inside, put this reverse probe through. The reverse probe has got a small knot in the end. Through the knot, you can railroad the proline and then bring it out. The second is a place where you sort of use like a cobbler needle, where you bend the tip of your IM needle, put it into the vessel loop, and then you can bring it in. The third picture is a knotting technique where you take a proline first, then tie it to that of a ceton, that is a rubber ceton or a vessel loop, and take it up. So these are some of the techniques, and the fourth one is you can pass an infant feeding tube, cut both the ends, you can railroad either a proline or any other material through those bigger opening tubes. How do we tighten? The normal method that we follow in our institute is the routine Melzer's knot or the Roder's knot that we use for the laparoscopic appendicectomies, where we put in these threads. In laparoscopic appendicectomies, we use our finger as a hook, ask the sisters to put it in, then we tie these knots and then use it for appendicectomies. We use the same techniques. Instead of the finger, we use the sphincter complex. Make sure that we don't do undue tension on the sphincter complex. Put these knots and slowly slide these knots. Once you do it, ask the patient to come back after about 2 weeks and then start to tighten these knots. These knots usually slip very well. You need to just put one proline alone. Doesn't produce any amount of discomfort to the patient and easily tightenable. But then once the patient says he's got pain, that is the indication where you have to stop putting or tightening these. Ask the patient to come back. These cetons starts cutting these muscles. They produce fibrosis and then helps to convert a high into a low fistula, and at times helps in the treatment of fistula as a primary modality itself. So coming to the recurrence and complications, this is a study which shows that there is a definite recurrence rate of ranging from 10 to 19%. And coming back to the incontinence, which doctor had already said, which is the most important and the dreaded complication of these cetons, which do occur primarily when cutting cetons are used as a primary modality of treatment. But then using specific techniques, using proper methods, using the proper techniques of tightening, the uncontrollable cutting of these muscles can be avoided, making this ceton at times, cutting ceton at times a primary modality of treatment. What advice do you give and what queries does the patient ask? The first thing is, will this fistula drain? Yes, the fistula will drain. The fistula will keep draining, not that you put a draining ceton and these drain stops. It facilitates the drainage of pus, whatever it is, easily. Drainage may be high initially because of a foreign body reaction, but then subsequently reduces. Routine activities can be done. So diet only to prevent constipation and stool softeners has to be given. Personal care, you don't need anything excess. The patient doesn't feel anything uncomfortable because it is going to be only a proline or a rubber. The concept is to keep the wound dry and clean. Ceton breakage, at times you get a call from patients saying these tubes or the cetons have fallen down. All you have to need to do is ask them to collect the cetons, get them back to your OPD, see whether there's any break or any slippage in the ceton. We do have come across a lot of patients with where we have used these infant feeding tubes, at times have slipped in. So that requires maneuvers to remove it. So that brings up to my end of this topic. Management of fistula is like a war field, and you need to use multiple modalities of treatment. And the take-home message is fistula Ceton still plays an important role in the fistula management, at least not as a primary modality, but as a supportive method, helping the rest of the treatment to enhance the management of fitons. Thank you very much for a kind and a patient listening. I'd like to thank Dr. Praveen himself for presenting and making this slide, helping me to do all these slides. Thank you very much, gentlemen.
Thank you, Dr. Karthikeyan. Next, we welcome Dr. Jaspal Singh to the stage for his talk on post-surgical perianal wound care.
Good morning, everybody. Respected faculty members, senior colleagues, and my dear friends. I firstly thank the PSG institution for inviting me for this topic, and Dr. Balu, head of the Department of Gastroenterology, for doing so good hospitality to us. And my topic, I'd like to just give a preamble, though it is a post-operative care of perianal surgery and the management of wound. This has got two aspects. One is iatrogenic as well as one is non-iatrogenic. But I am covering both here and emphasizing on mainly surgical wound. So going to the introduction, anorectal wound is a very common problem which all surgeons do see in their lifetime many times. But there are associated challenges with this particular wound because it is in the perianal region, and what is more challenging here is the wound is associated with lot of fecal soiling and also lots and amount of drainage which keeps occurring multiple times in a day, which might require multiple dressings in a day. And the awkward position of these wounds, which is actually the patient also will not be able to see the wound but only experience the pain, the irritation along with it, and the surgeon finds it difficult to keep this wound dry and keep dressing it very regularly and also keep the anus open. Now, what are the causes? Causes are basically broadly classified into iatrogenic and non-iatrogenic, that is general. In iatrogenic, it is the anorectal procedures, the perianal procedures. Anorectal procedures mainly surgery of the hemorrhoids, fissures, anal fistula, which is the most commonest, and the perianal abscesses, which are drained and kept open. Open surgical wounds here take 6 to 8 weeks to heal. That should be kept in mind. So you have to keep educating your patient who are very apprehensive about the time the wounds are going to take to heal and give them a good healing result. Perianal procedures. Basically, perianal procedures are obstetric related, and there is sphincter injuries. So oasis, which occurs more commonly during vaginal surgeries. There happens to be 3rd or 4th degree perineal lacerations, which involves the anal sphincter complex and many a times the mucosa. Especially seen very well in forceps delivery, which has higher rate, that is 44% higher rate incidence has been also seen with sphincter injuries. So other injuries, non-iatrogenic, could be anal sex related injuries or foreign body insertion injuries. Penetrating injuries and traumatic anal sphincter injuries also can be seen in bull-gore-like injuries or gunshot and crush injuries during RTA. Now, what is the role of a surgeon here? First, he has to do a physical examination, assess the extent and the gravity of the wound. So he aims at examining the wound thoroughly to check disruptions of the skin, sphincter, muscles and mucosa, to assess wound size and the tissue loss, to note type of wound collection and the type of discharge, which could be purulent or which could be serous. This has to be done by either positioning the patient in the Sims position or the lithotomy, which is very commonly used depending on the surgeon's choice. So the Sims position. Sims position for a right-handed surgeon, making the patient lie down in the left lateral position. Patient's left lower extremity is straightened and the right lower extremity is flexed at the hip and the leg is flexed at the knee, keeping the bent knee resting at the bed surface or a pillow which provides the stability. The arms should be comfortably placed beside the patient and not underneath. So this is the posterior view of the Sims position and the anterior view of the Sims position, and depending on the comfort of the surgeon or the preference of the surgeon, we can he can examine also on the lithotomy position as shown in this picture. Now coming to the evaluation of the perineal wounds. Many of our speakers here have already highlighted the evaluation methodology, but I'll just go through in rush. Basically, after DRE, it is the proctoscopy which is required to assess the size, extent of the wound and the injury. Injury I am using here because of, we have bull-gore injuries or RTAs also which can cause these wounds. So, colonoscopy especially in crush and deep penetrating injuries is required, and CT MRI in deeper wounds to evaluate the sphincter status, extent of the collections, presence of foreign bodies and intracutaneous fistula associated. Examination under anesthesia may be required in certain cases which require because of two reasons. If the patient is not cooperative, and the second one, if you would like to do it under anesthesia, there is another benefit that you can explore, debride, curate and remove the necrotic tissues. So this is how proctoscopy, colonoscopy is being done. And what is now the surgeon's role in management of these anal wounds? Primarily, most importantly, a orderly evaluation and resuscitation is the most important element. So to see the size, cavity, extent of the wound, where it is tracking. After once this has been done, to note down all this. After this, you can start your planning of the wound care. Here, one thing what has to be kept in mind is life-threatening conditions has to be kept first. Like if in case there is severe bleeding or hemorrhage, you have to treat the hemorrhage. If the patient is having severe pain, treat pain first, and all associated conditions associated with the wound has to be taken care. Other than that, surgical intervention is only indicated in those cases which are associated with abdominal injuries and where you need to do an exploration higher up. Debridement of devitalized tissue is also to be done, and this can be done on and off to prevent sepsis. Frequent dressings which are required in a day may be also, you have to educate the patient to go in for alerting the surgeon or the person in the ward to take care of the dressing and spraying these wounds with water jet sprays and taking frequent sitz bath. Oasis is a sphincter defect wherein again sphincteroplasty is required. So what is the surgeon's role in managing these rectal wounds? Especially when these rectal wounds are associated with bull-gore injuries or fracture of the pelvis as seen in the RTA, there is a surgeon's role of exploration and treating accordingly. Prompt management as may be required to prevent the blood loss has to be kept in mind first, following which the sepsis. Sepsis, again, all the protocols of sepsis management, if you require You will have to do multiple debridements. After that, you will have to take cultures. After once you get all the picture in your this thing, you can control the sepsis and treat them. And a stepwise approach is most important in such cases because resuscitation and hemorrhage control, first you have to take care, following which identify and treat the injuries, and then next aggressive initial debridement and pressurized irrigation with jet spray, followed by sitz bath regularly has to be told to the patient, which he can do even after discharge. Then following which you have to do debridement and daily dressings, multiple specialty approach of other modality if warranted can be invited, and you can do a multimodality approach to the particular wound by taking care of other aspects. DVT prophylaxis has to be kept in mind. Colostomy, if indicated, then care of the stoma has to be also managed. So this is how I'm just running through some of the pictures. Post-operative irrigation after Henle's procedure, wherein after putting a rubber tube, the wound was tried to be stretched and then irrigation was taken up. I'm just showing a small video. After stretching, we had to, in a lithotomy position, then irrigation was taken up. Following which, again, this is the same irrigation done in Sims position. Because previously I have shown in lithotomy, this Sims and lithotomy, it is surgeon's preference, and most of the surgeons do it comfortably in the lithotomy position. Here we are taking normal saline with betadine solution and spraying with a syringe, and some people take a infant feeding tube and put it in the wound and try to spray and remove all the fecal remnants from the wound, and this has to be done on and off, and this can be followed by sitz bath on regular basis. You can see after making a solution ready with betadine and normal saline. Spraying of the wound is being done, and this particular method has to be done 1 or 2 times in a day depending on the soakage and the fecal soilage of the wound, which is very must, because in fistula surgery it is not only the surgery, it is the aftercare which is very important. Yeah. Now going to the management of wound complications. So management of wound complications is, again, if you find a lot of slough, debridement and dressings has to be done, followed by infection. If you find negative pressure, VAC dressings are indicated only if the wounds are away from the anus. Flaps in case where the wound healing is delayed, and if the beyond 3 to 4 months, if the wound healing is delayed, then and the wound size is bigger, then you can plan for flaps, and if the patient is tolerant enough and physically fit, you can go ahead with flaps. Sitz bath, saline irrigation, shower sprays, handheld in deep wounds are also to be done on regular basis. Curettage, drainage of the wounds, and packs, which is to be done on regular basis. This is again application of silver nitrate stick in hypergranulation tissue. We find alternatively copper sulfate is also used. So once the patient goes home, the patient education aspect is very important when you are managing a post-op surgical wound. It is to be, educated in a way how he can handle his pain, how can he take care of his pain by taking anti-inflammatories what you prescribe, and he should not be having constipation or diarrhea. Whenever he has to take care that his bowel movements are regulated normally. If there is any swelling or edema, you have to just approach the doctor back to find out what is left behind. And if sutures, on regular basis, he has to follow up with the surgeon. Drains and packs, and if we are left behind, he has to follow up with the surgeon for the removal. Bleeding, if it is little bit, which can occur at least in a few ml, he doesn't have to worry. If the bleeding is more higher or in a large amount, he has to see back his surgeon. Itching, pruritus, that is urination, infection, diet, activities like exercise after 2 weeks can be resumed. Patient education and counseling is very important in most of these cases. I'm just showing you a video after this. Yeah, this is how we educate our patient and ask them to take care of their wound, which is primary important in any perianal wounds. He keeps asking whether he can do it with normal water. Yes, he can do it. He has to take sitz bath. Yes, each time, twice a day, and after defecation, he has to take a sitz bath. Must clean the wound right after the defecation. That is very, very important. Can clean the wound as many times if he feels sore, itchy, or when the wound is discharging. Avoid constipation. And if at all he is having constipation, don't force the feces to pass. He has to see and take care of his constipation. The wound, which is swollen, again he has to see his doctor and find out what is the cause for it, and we shall flatten after 3 weeks. During feces, like there might be bleeding. If it is lot, which I have already said, he should see the doctor, and if it is in minimal amount, he need not see the doctor. Within 1 week after surgery, there may be secretions which he has to be educated, and this secretion should not be worried about. He has to resume his exercise after 2 weeks after surgery. And we have to very clearly tell the wound, especially hemorrhoid, 1 to 2 months, and 6 to 8 weeks, fistula and abscess. And if there is any kind of an abnormal bleeding, or if there is progressive pain, or if there is swelling in that area, or any discharge which could be purulent, he has to see the surgeon who has operated. Thank you.
So based on the wound character.
The best way to irrigate the wounds is a bladder syringe.
Bladder wash syringe, yes.
Large volume bladder syringe. You can pour a lot. You can even use some force. That's the way you can. It will be very handy. It's available everywhere. Just a tip.
Yes. Thank you.
Thank you, Dr. Jaspal. We'll now proceed with inauguration function, which will be followed by Dr. Balu's talk. So, we welcome you all to the PhD Proctology Update 2023, organized by Department of Surgical Gastroenterology in association with Associations of Colon and Rectal Surgeons of India. I call upon the following dignitaries to the stage. Dr. T.M. Subbarao, Principal, PhD IMSR. So please. Dr. Balu, HOD, Surgical Gastroenterology. Dr. R. Kannan, Vice President, ACRI. So please welcome to the stage. Dr. G. Mahendran, Dr. Kamal Gupta, Dr. Arshad Ahmed. Delegates, please wait for the inauguration function, after which we'll break for tea. I call to the stage for the following dignitaries: Dr. Subbarao, Dr. Kannan, Dr. G. Mahendran, Dr. Kamal Gupta, Dr. Arshad Ahmed. Dr. Jaspal Singh. I call Dr. Balu Kupuswamy, HOD, Department of Surgical Gastroenterology, to deliver the welcome address.
Good morning, everyone. It's indeed a real proud and privileged moment for our institution and also for our department to be hosting this program, which is a single-themed CME focused on one of the vexing problems for the clinician and patient, which is fistula in ano. I first of all thank the institution for giving us the opportunity and support for everything, for making this possible, and also the Association of Colon and Rectal Surgeons. My job as an organizer is to welcome you all wholeheartedly for this function. To get 100 odd people for this single-themed fistula conference really says the curiosity and the interest about this problem and what is needed. So I welcome first my principal, Dr. Subbarao, the head of our institution, to this function on a Sunday. Thank you, sir. I welcome you. I would like to welcome the office bearers from the Association of Colon and Rectal Surgeons of India, which is one of the most vibrant branches of the entire ASI in this country, and consistently it is becoming the best section in ASI for years together. So the South Zone has been very active, and I welcome Dr. Kannan, the Vice President, South Zone, Dr. Jaspal, who is our EC member who has come down from Karnataka, Hubli, two esteemed faculties who have taken all the pain to travel quite some time to come here, and they are leaving this night and probably staying overnight in Delhi. So I welcome Dr. Kamal Gupta, who has recently published a textbook of lasers in proctology. He has come down from Jalandhar, and Dr. Arshad, who was a professor of surgery in Lucknow KGMC Medical College. He has come down to join us. I welcome you all, sir, for this program. And not the last, I welcome every single participant here, senior faculties, professors, my colleagues, junior surgeons, and PGs. I welcome you all to this program, and hopefully we will all learn together. And we have kept only difficult cases for the live. It's such that my department gets most of it recurrent cases, and few of them are my own recurrences. So we have kept a lot of complicated cases. I'm sorry that we don't have simple cases kept, which is straightforward to manage, and I request you all to stay back and participate actively in the interaction, and thank you one and all for joining us.
I call upon our dear principal, Dr. Subbarao, sir, to deliver the chief guest address.
Respected dignitaries on and off the dais, organizers, delegates, and my dear friends. I am very happy to be a part of this inaugural ceremony of the PSG Proctology Update 2023, organized jointly by the Department of Surgical Gastroenterology of PSG Hospitals and the Association of Colon and Rectal Surgeons of India, the South Zone chapter. And the theme is interesting. It's on Fistula Demystified. I commend the efforts taken by Dr. Balu and his team for bringing the who is who in proctology surgery to this podium so that they can share their experiences with the audience. Learning becomes more meaningful when we listen and then we visualize and then we start accepting the pearls of wisdom. Thereby, we get to have a lot of takeaways from this meeting. Like the way, Balu, you have planned your entire program, you initially had some lectures followed by which helps in upskilling the cognitive domain. Then we go to live surgeries, then case-based discussions, and finally your master videos. I think they will elevate the levels of learning. As a pathologist, we very often come across the recurrent fistulas tissues and the complex fistulas. And while the common denominator remains the presence of a chronic granulation tissue, I think we'll have to be very focused and careful looking for those cues that you can get and help the surgeon arrive at a diagnosis. The use of special stains definitely with positive controls wherever required will be useful for the team. I request the participants to give us an honest feedback on the process so that we can improve, and I wish the program a grand success. Thank you all.
Thank you, sir. I now welcome Dr. R. Kannan, Vice President, ACRSI, to address the gathering.
Very good afternoon to all. For the outset, I thank our principal accepting to conduct this ACRC South Zone meet in the prestigious PhD institution. And I must thank Dr. Balu. He is very much willing and interested in conducting this program as a ACRC South Zone program. In fact, we have planned 3 months before, and then some reasons we have postponed to this, but it is coming in a big way. And I must thank Professor Kamal Gupta. He is a laser man. In our country, he is spreading the importance of the laser in the proctology, and immediately he has accepted and coming to our program. For that, I must thank you, sir, for in your busy schedule, you have come all the way from Jalandhar and greet us. And Dr. Ashrat, you know very well, he is a very much busy professor, and as well as he is a specialist in the proctology surgery. So for which Ashrat Ahmed has consented and is coming under grace our CME program. And our own EC member, South Zone, Dr. Jaspal is here. And all our friends and seniors, my dear colleagues, and as well as senior professors, I must thank all you all for coming to this program and grace this CME event as a great one. So conducting the single theme program, the main idea is focusing on the one topic, and we have to discuss each and every aspect of the topic and spread over the message of the importance of the disease. So like that, we have taken up this fistula as a single theme, and so far the talks are extremely good, and they have conducted and they have committed all those things on the full time to present these excellent lectures and with the video clippings. So after this, we are having the live surgery followed by the master video class and as well as panel discussion. So on the whole, I once again thank Dr. Balu and as well as the principal of this prestigious PhD institution for keeping this ACRSI South Zone CME. Thank you, Randall.
Thank you, sir. I request the dignitaries on stage to light the Kuttuvilakku. I now call upon Dr. Praveen John, Assistant Professor, to deliver the vote of thanks.
Good morning, one and all gathered here. I would like to personally thank each and every one of you for making it to this PSG Proctology update conducted with the ACRSI. I would like to thank the management of PSG Hospitals for making this event possible. Thank you, faculty, for your time, for bringing us the evolving concepts in fistula surgery. I thank the organizing team for the tireless efforts in bringing us here today together. I would like to thank the Department of Anesthesia, OT staff, nurses, paramedical staff, the people behind the curtain who are caring for our patients today. I extend my thanks to the audiovisual team, IT department, maintenance, electrical, dietary, and other supportive staff who are here in the hall with us today on a Sunday and supporting us in this endeavor. Last but not least, I would like to thank Abbott for their continued support throughout this event. Thank you.
We will now break for a quick tea break, which will be followed by live operative session. Before the live operative sessions, we will have Dr. Balu's talk.
check hello, check hello, check hello.
Shiva sir.
Hello.
Hello.
Hello. Can you hear me?
Shiva sir.
Sir. சார் சொல்லுங்க சார்.
ஆடியோ செக் பண்ணுங்க.
ஆடியோ பேசிட்டு தான் சார் இருக்கும். ஆடியோ கரெக்டாக இருக்கும். ஒரு நிமிஷம் சார், டாக்டர் தரேங்க ஒரு நிமிஷம்.
சர்ஜனோட மைக்கும் செக் பண்ணிருங்க பஸ்.
ஓகேங்க சார்.
Good afternoon. We welcome you to the live operative session of this PSG Proctology workshop. The live operative session will start now. I request the following surgeons to kindly make their way to the dais to moderate this session. Dr. John A.C. Danakumar, Coimbatorepsg. Dr. Rajesh, HOD of Surgery, PSG Hospital. Dr. Sarveshwaran, Ramakrishna Hospital.
Can somebody from the auditorium say the case details, please? Can you make the patient details slide a little bigger, please?
Check.
கொஞ்சம் ரொட்டேட் பண்ணிருங்க.
Hello. Good afternoon, everyone. We are going to start the live session from OT. Our first patient is a 40-year-old male. He is a diabetic. He is a case of recurrent fistula in ano. First surgery was done on 23rd of January this year. The procedure was lift and the tube was placed in track. This is a clinical picture showing external opening about 8 cm away from anal verge with the tube in place. We have taken an MRI. This is an MRI showing the external opening on the right luteal region. And this is a fistula tract which is in the transsphincteric plane. And this is the internal opening around at a 12 o'clock position. So the final MRI report is linear enhancing intersphincteric fistula tract in the right perineal region, and it is coursing anteriorly and cranially. So at the cranial end, the tract is coursing towards the left to reach the midline with internal opening at 12 o'clock position. And it is coursing predominantly anteriorly to reach the root of scrotum. The secondary tract, there is a small secondary tract which appears to be predominantly fibrous in nature. So our plan is lift procedure. So we will start the session soon.
வியூ கரெக்டாக இருக்க பார்த்து பேசுறது. மைக் வால்யூம் ஓகேவா? கேட்டுக்குங்க.
குட் மார்னிங் பார்த்தா. ஹலோ.
ஆல்ரெடி அங்கே வியூ போயிடுச்சு. எனக்கு ரைட் லெக்குக்கு வரணும். ஓகே, பைப்போலர் இங்கே வச்சிருங்க, கொஞ்சம் தள்ளி வச்சிருங்க. ஓகே.
Partha, good morning.
Confirm all team members have introduced themselves by name and role.
Dr. Parthasarathi, surgeon.
Assistant surgeon.
Hello. Can you hear me?
Hello.
OT?
Yes, sir.
Surgeon, anesthesia, proportional and mass variability confirm.
Can you, good morning, John Danakumar here. Can you tell us where the internal and where the external openings are?
Sir, good morning, sir.
Good morning.
So actually the patient is in spinal anesthesia and I keep there in prone position, sir. It is totally prone.
Okay.
And I put a plaster. Now you can see the plaster here.
Sure.
So I strap the buttocks.
Yeah,
So that I stitch the buttocks so that I can able to see this, stitch the sphincter.
Yeah.
And this patient underwent already surgery. So here is the 10 o'clock is the external opening, sir. Since the patient is prone, this is the 6 o'clock, this is 12 o'clock.
Yeah.
10 o'clock is the external opening. And the internal opening, they put at the level of anal verge, but I could see inside. I could see inside the internal opening.
Okay.
Anyway, I'm going to remove the ceton and then I'm placing the hydrogen peroxide so that it will show where the internal opening very clearly.
So this is an anterior fistula, correct?
This is, it looks like almost a straight fistula, sir. 10 o'clock internal opening and 10 o'clock external opening. This is anoscope.
Pata, good morning. Rajesh here.
Rajesh, good morning, Rajesh.
Good morning. Do you always prefer the prone position?
Yes, yeah, always prone position. I started in 2012 end, almost 2013, almost 10 years I'm doing. And initially select cases very choosy with a straight fistula, not a semi-horseshoe and semi-horseshoe for the first 50 cases. And then I learned the technique, and then after that many surgeons referred, and then I did many live surgeries. And so nowadays any fistula I'm able to do with the lift surgeries.
Are you using a typical prone or you're using a prone with the jackknife?
No, sir, it is a typical prone, sir.
Okay,
typical
because temps we do it with the
jackknife,
prone.
yeah. If it is anterior, so that will be helpful, sir, in the root of scrotum or in the labia majora in females, so that will be helpful.
Anterior, yes.
Yeah, anterior fistula. And can you see this anoscope, sir? In the coming in. So this is the anoscope. It is, I bought it from Dr. Arun Rajanaskal. He gifted me, and you can see his sign also in this anoscope. And this is the first time he designed, and first version. And this is the cut anoscope, and you can, the bottom will be heavy, and it has a hole inside, and this is a conical tip. So that if you place it inside, so because of this heaviness, it will stretch the anal mucosa and low rectal mucosa. And this will be 4.5 centimeters. So up to 4 centimeter from the anal verge, more than 2 centimeter above the dentate line, if internal opening is there, we can approach with the lift. And now he modified with a little bit, but this is the basic version.
Father, this patient also has a tract anteriorly. That's what Dr. Balu says.
So, Rajesh, your voice is a little bit low here.
This patient also has a tract anteriorly with the opening at the root of the scrotum.
Yeah, that is almost healed.
Okay.
So this is the root of scrotum, and that opening is healed. And most of the time, the opening inside will be the Now you can see how much exposure after this anoscope. And keep it here. Sister, good sister. Scrotum opening.
What exactly was the first surgery?
First surgery is, this is a lift done, sir, for this patient, and then record, then they put seat on. The first lift done, this case. So now I remove the seat on, and there is no opening here.
After lift also you do lift, is it Partha?
Yes, sir, yes, Rajesh. 3 times I have done it in my patient. Few of my cases I have done 3 times. All 3 times I attempted lift, and the plane is a little bit difficult, but we could enter the plane.
What is your recurrence rate after lift?
See, mine is, I have published my first report in 2016, 15, that is 250 cases, and now the recent 1,200 cases it is in press, and according to this 1,240 cases, the recurrence is 6.4%. It is less than 10%, yeah. See, now this is the external opening. I'm injecting hydrogen peroxide. See, now it is coming. See, this is the, what I suggest is, this is the lift wound. This opening, the superficial opening, this opening, the ceton was there in this opening. This is not a true fistula. Maybe this may be the lift opening, and they made it ceton here. The internal is here. So that is the internal opening. So that's why the internal opening is not closed. That's why it got recurrence. And this time the ceton is not placed in the internal opening. It is placed through the lift wound, external opening and the lift wound. So I'm going to do again lift here, and then I have to find out the track. Find out the track. It's a little bit deep track, so we can able to find it.
In a case like this, theoretically, would you, since facilities are available, would you consider operative ultrasound?
Sir, under anesthesia, most of the time during surgery, the ultrasound will not be much helpful, sir, because of the laxity of the sphincter. And most of the time, I tried few times, and some of the patients, some VIPs, they don't want to have endoanal ultrasound. They come with MRI, and MRI also sometimes not clear. And I thought of doing a preoperative endoanal ultrasound, but they're not accepting it. Those kind of patients I did during a surgery, but I'm not getting much information during intraoperatively. So preoperative endo ultrasound will give a good report, sir.
Okay.
So I'm going to make, so this is the external opening, stretch panniking. And we have to make an incision at the level of the internal opening. Here the internal opening at 12 o'clock, 12 o'clock. And I'm going to make the incision at 12 o'clock at the mucocutaneous junction. So this is the hairline. So this is the mucocutaneous junction. So if you open the mucosa, then we cannot get it. So we have to go in the mucocutaneous junction. And I make around 2 centimeter incision. Sir, is it audible, sir?
It's audible, it's audible. It's a very good video transmission. Congrats to the Balu.
Yeah.
Very nice video transmission.
And this is a regular pencil, but the tip, what I'm using is the tungsten tip, sir. So tungsten tip, you can see this perianal is a high vascular area. You cannot see any bleeding here. I made incision, no bleeding because of this tip. Then after that I changed to the regular tip because that is a very sharp one. And then I'm using this retractor. It is called lift retractor. Again, it was me by Dr. Rajanaskal. Almost 11 years I'm using this retractor, and it is very strong. It looks thin, but it's very strong. And this is good for very minimal 1 mm this thing, and thickness is also less. So with small opening, and this retractor is good. This is too large. Any retractor this 1 centimeter size is it will occupy the entire area. The vision will be restricted. So my assistant here, Dr. Harsini, and then staff nurse is there. So he is assisting me. One hand this retracting the anoscope so that it will give a stretch the anus. Then other hand I am holding the retractor. So now you can, what we are seeing is the external sphincter, and I have to find out the intersphincteric space. Suction system. So if we touch the sphincter, can you see this, sir? The muscle is contracting. That means that is a sphincter. That is the identification. That means we have to come little towards the anus. The sphincter muscle should not get contracted. That means we are going through the muscle, we cannot get a track. So I'm coming little bit medially. Little I'm because of the seton, because the lift surgery will not give much difficult. This fibrosis is because of seton suture. Little bit fibrosis, not much. Here the fibrosis is there. That is because of the seton suture.
Father, can you tell us how will you identify the intersphincteric plane?
அங்கிருந்து வர volume increase பண்ண சொல்லுங்க.
Hello.
Yes, sir.
Can you tell us how you will identify the intersphincteric?
See, there is no identification point. That's why I stretch the anus nicely with a plaster before painting it. And then with the anoscope, my assistant is retracting, stretching. And here also you can see 1-2 hand is there to stretch. So if it is stretching there, then we have to make an incision at mucocutaneous junction. From the mucocutaneous junction, you have to see again I am stretching the muscle, and if we go to the muscle, it will get stretching. So you have to come, small fatty line will be there. There is a fatty line. Fatty line will be there. So that is the point. There is no landmark like this. So you have to go, and internal sphincter is only, can you see, sir, internal sphincter? It is very 2 to 3 mm thickness only. And then this external sphincter, So we have to go stretch nicely and then go in between. In some cases, even you can able to feel the groove. Intersphincteric groove we can able to feel in some cases, not in all cases. So what I did, because of the C-turn makes fibrosis in that plane, so I'm separating the plane in other places around 12 o'clock and 11 o'clock, 1 o'clock, and then I'm coming to the 11 o'clock.
I usually put a gentle artery mosquito clamp here and dissect with this. Comes to a similar thing.
Sir, your voice is little low, sir.
No, I usually use a mosquito clamp on either side. If it's
Okay.
anterior, for instance, coming at 11, I expect a good salt stool backed up with the MRI.
Okay,
and
sir.
Use a gentle artery clamp on either side. Once you make an incision, the diathermy like this.
Okay.
And put in the finger. It's a different way of doing it.
So I don't put any needle or probe or anything, sir. And initially I thought of probing will be helpful. I keep a probe inside.
Not the probe, the one from outside. What
Outside.
you're using for the diathermy.
Okay, sir.
That's
So I'm getting a good plane here between the internal and external. So I'm going towards the fistula side now. இதெல்லாம் சக் பண்ணும் சிஸ்டர் சக் பண்ணிட்டு எடுத்துடணும். See here it's a very thick fibrosed area. I'm trying to separate the muscle from here.
post-op also makes it more difficult.
This is because of the C-turns.
That handle of the retractor comes in the way. If the camera can be held a bit higher.
You can கொஞ்சம் lift பண்ணி காமிங்க. கையில தூக்கி காமிங்க. Yes.
Yeah.
Light.
Yeah.
இன்னும் லைட் கரெக்டா வரல.
Better, much better. Yeah, that's better.
இங்க லைட். Okay, sir. So it is very small opening. I made only 2 centimeter. Almost 6 hands are working in this plane. So it's a little bit cumbersome, sir. Because of the fibrosis, I extended my incision a little bit. So again, I'm coming here. So this is the intersphincteric plane, sir. This is the internal, this is the external. I'm going in between. Even we can go up to 4 centimeter or 5 centimeter without any difficulties if it is in the right plane. And with the probe itself, I could feel the fibrosis, no? So that means it may be tract or the fibrosis made because of the C-turn. இங்கே பாரு bleeding. Right. Okay. காசு வச்சு தொட. ஆற்றில் வச்சுக்கணும் சிஸ்டர், கையில் வைக்கக்கூடாது. Okay, now almost I reached the track level. So now I am going this side. Yes, sir. Here, we have to do very patiently, and each fiber by fiber we can dissect, and even any fistula, any difficult case, any deeper plane we could able to enter if you are in the intersphincteric plane.
What's the diathermy settings you use, Father?
Sir, it's 25, sir. Coagulation 25, bipolar 35. 40, sir. Bipolar 40. Here you can see the track is little bit open. You can see the unhealthy mucosa, and I'll confirm with the hydrogen peroxide. So the hydrogen peroxide now will come with the intersphincteric plane.
You don't use methylene.
See, it is coming. So my cautery tip, little bit small opening around the mm opening.
So you ever use methylene blue?
No, sir, I never use methylene blue because of the staining, and even the hydrogen peroxide, some cases the internal opening may be occluded or partially closed. The hydrogen peroxide will open it up. Maybe some food particle may block that internal opening area. Methylene blue, it will stain more, but it is not opening the internal, if it is blocked.
What sort of light are you using? Headlight? No?
Yes, sir?
What sort of light are you using? Regular theatre lights or a headlight?
No, sir, it is a OT, regular OT theatre light. It's not a headlight, sir, regular theatre light. Okay. Almost around 12 to 1 o'clock I entered deep. So now I am coming to the fistula side. Light inna kuda konjam adjust panningna na. Okay.
Have you come around the fistula tract?
Yes, sir. I went below the track here, this side. So now I am going this side.
How many in the audience do lift procedure for fistulas? Plenty. Okay.
Dr. Partha.
Any doubts?
Yes,
Feel
sir.
free to ask them. Yes, sir. Yes, sir.
Dr. Partha.
Yes, sir.
Dr. Sadasivam.
Yes, sir.
When you dissect, won't it be comfortable if you put a stent-like thing through the hole so that your delineation will be better?
Yes, sir.
You won't,
actually, I have done for my initial period, sir, and that is not much helpful.
No,
Then I
that's
stopped
how
doing.
few of us do.
Yes, sir. Initially, I thought of it is a good one, so I did with a metal probe initially. Then I changed to ureteric stent tube, a 7 French stent. I passed it and then it will give way. But it is not much helpful, sir, because I am feeling this tract fibrosis, the artery probe itself, so it is not much helpful. So this case, because of the recurrence lift and then sit down is a little bit fibrosis, it is oozing. Otherwise, it will be very clean, sir.
So and also, if it's quite a large one, it will take some sort of a instrumentation inside, even a plastic tube.
So you can
the
pass.
only thing is very often it's quite small, and probably it's good to get used to doing it without anything inside, so that you can do small recurrent response.
But if the tube is inside, you can dissect on either side of the tube. It's easier.
Sir, I tried it, but
even
it is not
if you
much helpful.
cut the tract, you will know that the tube is there, you cut the tract.
True.
Here also it will, hydrogen peroxide will come out, sir. So now my right angle is, just you can see, it is behind the track is there. So I am trying to take this right angle to this side. Sister. Your retractor is not good. Suck panna, inge suck panna, sister. நீ suck பண்ணிட்டே நான் சொல்றப்ப மட்டும் கொடு. கொடு. So I take the tip of the right angle to the other side. இதை பிடிச்சிக்கு. Leave that one. இல்லை இது கையெடுத்து நல்லா பிடிக்கும். Yes. So this is the track, sir. This is the track. Little bit wide track with the surrounding fibrosis is there. So I am going to suture. So again, this also, initially what I did, I passed the thread and then I did a simple ligature and then it is slipped. Then I did a transfixation suture. That is also because of the fibrosis, even if it tighten very much with the hand, again it slips. After division of the tract, it slips. So nowadays I am using loop, sir. What we do it in appendix, no, endo loop. The same type of loop I made it with the 10, sister. 10 vicryl. I pass through this plastic rod, passes through the plastic rod. I feed the thread, then I apply the endo loop. In anoscope. And the mari chipper. Yeah, yes. Yes.
You don't divide.
Sometimes I used to skeletonize the track because the fibrosis is more. It won't hold, thread will not hold. This case, maybe after that I can skeletonize it.
We had a doubt, Partha. Why not keep the
So again, I'm placing the this right angle.
Partha?
You can ask Professor Sadasivam.
Yeah. I mean, same question, sir. We can keep the seat on as well and dissect the track. It may be as a guide. Probe, sir, yeah.
So the sister is making the knot, sir. It is not a typical ruder. It is a gem loop knot. We made it in our hospital.
If there is a probe or metal,
since the metal probe will actually it will produce hindrance, sir. We thought it is it will helpful.
not miss the tract.
So it is
Otherwise,
so it is very much identifiable, sir, because of the fibrosis.
No, Partha, you are very experienced, so you can always feel the tract. But for a beginner who wants to do, if there is some guideline inside,
that maybe
that will be better.
helpful. Yes, sir.
But at least in difficult cases where it is difficult to identify with a lot of fibrosis, recurrent cases.
Yeah, maybe it gives better. And now we press this track like this. And the opening மேல எடுத்து system. See, I'm accidentally opened the track little bit. So I'm trying to make knot above the level of the opening. So it is, I tied it. So this we can tight nicely, sir. Even if a very deep place inside, and passing needle, taking a transfixation suture is difficult. So then I find this is very, you can see very nicely, you know, compared with hand knot, this mechanical knot is tightened. So I tighten nicely. I remove this right angle. So now I'm injecting hydrogen peroxide. Previously it come through the track. Now it come through this intersphincteric. It's a small one. Again, if it's not ligated properly, it will come through the internal opening also. So I occluded here. Very section put. So here it is occluded. So it has to come through the internal opening if it is not closed properly. Track is not closed properly. So it is not coming. It is trying to pushing here. Can you see, sir? I'm just giving pressure in the force syringe coming. The syringe coming. See, I'm giving pressure, sir. It is trying to come out through the syringe. Syringe is trying to come out. It is not coming inside.
Yeah, we can see that.
Yes, sir. So if it is that the track is not opened in the intersphincteric plane, then it will be nice. Okay, it's tightened again. Suction put, sister. It is quite deep track. So now, again I am introducing the right angle. Hold this. So I am going to cut the track, and here that is also again tungsten strip, but it is a little curved one. Can you see, sir, this one?
Yeah.
So this will be helpful. Even we can do it with a regular cautery also, but this will be a little bit difficult situation. Can you see this? It is a granulation tissue is coming out.
Yeah.
So this is the unhealthy granulation tissue, and we have to see this track, entire circumferential round track. Sometimes our right angle will go through the track. So that means again it will recur.
There is no need to tie the track distally.
Yes, sir. So now you can you able to see the suction?
Yeah, yeah.
Saline. See, sir, it is totally free now. See, that is the intersphincteric plane is free. So this is the track, sir. This round is the track. Again, this is the track. So again now I am going to tighten again because I tightened before division. So now, so it is come out. Suction. So now it is. So if I put hydrogen peroxide, see it is coming here. So that means the track is circumferentially divided. So I have to take out this track, and now here I have to take the suture. Usually after ligature, I used to make a bursting suture, and in this case the ligature is not hold well, so I am going to take a bursting suture here.
Is it always mandatory or?
Yes, sir. Usually I did two suture. One is just endo loop. That means there is not a transfixation, just like a simple ligature like endo loop. And then I take a transfixation suture or this kind of bursting suture. That will include I will include the external sphincter also. So that it is, include the internal sphincter, so it will hold well. The suture will hold in that particular place. It won't slip. See, now I am including the internal sphincter.
I agree. Everything has to be done to make sure that the tracks don't reform so that you don't get another recurrence.
See, this type of bursting suture, because just you take a figure of 8 or simple suture, it won't hold well. We have to take this type of bursting suture and including the internal sphincter fiber so that it will hold nicely. So the track is being occluded in the intersphincteric plane. So that will give that will prevent the recurrence. So this suture is the key suture. That is the ligating the track in the intersphincteric plane. Saline kodutho. Usually, if a ceton is there, my practice is I remove the ceton at least for a week. So I allow for a drainage, then I do lip surgery. Okay. So now I am going to excise this tract.
What was the histology from the last time surgery, any idea?
I don't know, sir.
Dr. Balu.
Karthi is there? Or Balu? If it is, it will not be tuberculosis, sir. Otherwise, they will inform me.
Was it sent?
Previous biopsy is normal. Last biopsy.
No TB, no Crohn's. I mean, obviously.
Yeah, biopsy is non-specific granulation, sir.
Okay.
There is no tuberculosis.
That's one thing to look out for. Another cause for a recurrence. But I'm sure it's been done. But just pointing it out for the delegates' benefit.
So if it is a superficial tract, I remove fully. And if it is a deep tract, then I take only the coring out the mucosa. I don't remove the tract. Forceps, tooth forceps. What is it? Take it. Almost entire track, no, it is coming out, okay.
In case of high transsphincteric fistulas?
High transsphincteric, I open and then I just do curating, sir.
Okay.
Can you see, sir, it is opening here?
Yeah.
So it is coming out. So entire track I removed, and this is the place, this is the place for site for the track. So now there is a defect in the sphincter. It is not a sphincter damaged because of the track travel through this place. So this defect I'm going to close with the Vicryl, sir. Since I remove the entire track, so I close the defect in the external sphincter because there is no track here, sir. See, this is a good thick one. See, it is going freely. So that is this is the transsphincteric fistula. So this is the external sphincter. So somebody is doing a fistulectomy, then all this sphincter will fistulotomy. This sphincter will damage.
Close the defect in the external sphincter.
So I'm going to go through. I'm going to make a figure of 8 in the sphincter. So this is the defect in the sphincter. Through this defect only the track pass through that defect. So this figure of 8 suture will.
It's a long track. One
oh,
can
okay.
also use a brush.
So after this, I just close the this lift wound with the 2 suture, 2 interrupted suture. That finished the surgery, and this also I made an interrupted suture in the external wound also. So if next case is ready, you can go, sir. Any doubt, I'll ready to answer that.
Do you close the wounds, Bala?
Yes, sir. I close the wound. After this, cut pannu. Glass piece kodu takka. So I remove the anoscope, and then I release the traction. Wait. Traction, and then this wound will be.
Now it's too late.
Wait. This wound will be closed with the interrupted suture, sir. Mattress, interrupted mattress suture, and then this also I will
from
close.
the audience.
Just regular simple mattress suture.
Hello.
Yeah.
Question from the floor. They want to know whether you will inject the dye through the internal opening and make sure it is closed.
Yeah, that is little bit difficult.
Okay.
And usually, if it is injecting the dye through the internal opening is difficult. Okay. Probe. So I made it, and this case, what my plan is, I'm going to do the closure of internal opening transanally also, because the track I made a loop, that will slip. So then I do posting suture, and if it is a loop is there, see it's not going inside,
okay.
But injecting syringe injecting dye through the internal opening is little bit difficult in this position. And anyway, I'm going to make a transanal suture also for this patient.
I usually take a stitch on the internal opening. Doctor, your
so internal
I
opening,
take a stitch on the internal opening as part of the thing, because while doing a waft, we do a stapled resection. So anyway, you want to remove that stuff at waft. So using a similar principle, I take a stitch there. In addition.
Yes, sir. In addition, some cases I do transanal closure.
20.
So it is not coming. Transanal closure also, but after making ligating the track in the intersphincteric plane, if I have any doubt like this patient, one suture is slipped, only one posting is there. In those kind of cases, then I do transanal closure of the internal opening. That I am going to do now.
Hello, Dr. Patsarthi, I have one question.
Any doubt, sir? Any question?
Infiltration around this wound.
Suction.
with xylocaine, adrenaline or normal saline adrenaline, and then procedure. Will that be more helpful to
Hello.
your
Sir, sorry for interrupting.
dissection?
So I'm not able to introduce this probe also. So the suture is holding nicely. So there is no hole. So I just do curating it. And I don't know whether that posting will be airtight or not. But I cannot do any more suture on the intersphincteric plane now. So that's why I'm doing a transanal closure for additional support. But this transanal closure will not be much useful because no, the anal mucosa will give way. And that is, I don't believe this transanal suturing of the internal opening, closure of the internal opening. Since this case, instead of two suture, only one suture is there, I'm going to make a transanal suturing.
Hello, sir. Sorry for interrupting, sir. We are about to start the second case.
Are you able to hear?
Yes.
Dr. Patsati, I just want to ask you about your take in infiltrating adrenaline xylocaine or normal saline with adrenaline around the tissue. That will make the tissues. Like
Sir, your voice is too low. What is the question? Normal saline or?
Adrenaline.
Adrenaline. Okay, okay. No, I never used. So far, I never used, and not even a single case. No, I think it is not required. These are all small superficial sutures.
I'm using adrenaline with normal saline.
Okay.
And the hemostatic effect is good and the planes are well seen.
Okay, 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 okay. So maybe I'll try, but so far I didn't use it.
I think it depends on what you're used to, sir. Like for instance, I don't use anything at all because your main idea is to get that tract. Sometimes the tract is small. If you inject some saline there, it becomes like a soggy thing. So that's the reason why I don't use it. But having said that, at the end of the procedure, you inject a lot of sensicaine to infiltrate for the pain.
So what?
But I agree with your point, but it can be done.
What
Obviously,
we do
also.
is, I'm sorry to interrupt, sir.
No, please go ahead.
Yeah, what we do is we make a solution of 100 ml of normal saline with 8 drops and only infiltrate around the section area. We go on with the tract dissection. Around that particular tract, we go on infiltrating.
Okay.
And that gives us a very good this thing,
Good idea. Good idea. Yes, sir.
Good afternoon, Partha sir. This is Dr. Mahendran.
Yes.
Partha sir.
Yes, doctor.
Regarding this opening, the closure of this internal opening, sir, I don't think the suture will stay at any time, sir. In this kind of infected area, this is going to be the source of the whole tract. The source is going to be at the tentate line of the internal opening. Rather, I would prefer excise the mucosa and submucosa at that area, which is going to be unhealthy, and just leave it open to heal by secondary intentions. Regarding this.
Yeah, that is also a good option, and this area you can open and then you can to close. That is also okay. But I most of the time, if it is a very deep one and then internal opening area, the mucosa is like no damage and it is like a cavity like thing, then I open that I divide the internal sphincter and then it is like a fistulotomy. So the up to intersphincteric space, so the fistulotomy like. But again, if it is open means you have to open the entire one. Again, if you open again, the fecal matter will collect in the intersphincteric plane. So somewhat this will transanal closure and then the closure of the intersphincteric plane will helpful to avoid the soiling of the intersphincteric plane. And then we can introduce the tube, irrigate with the tube for almost a week. Then before that the mucosa will get closed.
Most of the time this suture doesn't stay there, sir.
Yeah, transanal closure will not stay, and maybe I can say 50% of the patient it will stay, and if it is not, then again we have to think of that what you suggest, the fistulotomy thing.
Sir, sorry to interrupt, sir.
I think
We are
something
going
is
to
happening
start
on
the
the
second
other
case
side.
from OT.
Can we come back to you? Dr. Balu, is there anything happening on the other side?
Sir,
or is it the same
we are about to
patient?
start the second case, sir. Brief history about the patient. He is a
Yeah, go ahead, go ahead.
31-year male. He underwent lift procedure on 14/2 of this year. and he is a newly diagnosed type 2 diabetes mellitus. And this is a clinical picture showing external opening around 12 to 15 centimeter away on the right gluteal region. And this is again a clinical picture with external opening with a tube track around 12 to 15 centimeter at 3 o'clock position, around 15 centimeter from anal verge. And this is an MRI picture which is showing an internal opening at 6 o'clock position, around 2 centimeter above the anal verge with a transsphincteric tract. And this is again a picture showing, MRI picture showing a small collection on the left side also. And this is the external opening around 16 centimeter away from the anal verge. So this is a case of complex recurrent transsphincteric fistula, around 16 centimeter in length in the right gluteal region with internal opening at 5 to 6 o'clock and with a small collection on the left side. So we are going to start, the planned procedure is WAFT with laser ablation of the fistula tract. Thank you, sir.
Sorry, we didn't get the last part. What's the plan? WAFT with?
So, good afternoon. Am I audible in the hall?
Laser ablation.
Okay, can you see the pictures of the patient?
Yes, we can see that.
Is
yes.
it visible? So you can see the external opening.
Yeah, can you speak?
On the
Can you
right
ask somebody to
region?
adjust the mic so that it's closer to your mouth?
Is it? Okay. So, is it better now?
Yeah, better now.
So, can you see the scar of previous surgery and drainage and earlier whatever was done, and maybe this opening is there? Is
Yes,
it
we can
visible?
see it.
Then there is a large scar over this area. This
Yeah.
was also earlier patient had incision and drainage. That is approximately 4-5 centimeters posterior to anal canal. And then this is anal canal, we can see. And there was a lot of discharge coming from the anal canal. Am I audible? Am I audible?
Okay, left retractor kuda. Pudichuka, saline kuda.
Are we connected?
Yeah, you're connected. Yes, we can hear you. We
Okay,
can
so
see
you can see this scar and
Yes.
opening, perhaps this scar. And here you can see at the anal verge,
Yeah.
just inside the anal verge, you can see this puckering of tissue and lot of discharge was coming from here.
Yes.
And when I put my finger here, I can feel the sutures.
Right.
Patient was operated earlier, probably 6 weeks back, and these are likely to be PDS sutures, which I feel still some sutures are there. And now
How old was the surgery?
They told me that lift was done earlier in this patient, about 6 to 8 weeks back, and then some drain was put on the external opening.
Right.
Can I show you the MRI pictures of this patient?
Sure, please.
Please bring the camera here. This MRI was done recently, 4 or 5 days back.
Okay.
And can you bring the camera here? No, you have. Can you show here? Okay. Is this visible?
Yeah, it's visible, but not understandable.
Okay. So I think you need to bring the camera here. This is the axial view. In axial view, we have two aims basically, to see the location of internal opening and to see the transverse spread of disease. So I will show you the axial view. Is it visible here?
Yes.
Where I am
yes.
pointing my...
Yeah. Zoom? Yeah.
Okay. So you can see the internal sphincter, external sphincter, and in the intersphincteric plane, you can see this whitish color. This is ster film, basically T2 fat sat. So you can see the disease here. And we can also make out the internal opening at 6 o'clock. Internal opening at 6 o'clock. Is it visible, sir, here?
Yeah, is it T1 image or T2 image?
It's T2 fat sat, basically.
T2, okay.
T2 fat sat, we also call it ster image.
Okay.
So you can see this?
Yeah.
So fluid is bright and fat is dark here because T2, otherwise you have both fluid and fat, both are bright. But in T2 fat sat, you have to, fat is suppressed and fluid is bright. So you can see this is the internal opening 6 o'clock and slight horseshoe element in the intersphincteric plane. And then this is the extent of disease going laterally on this picture. You can see here.
Long tract.
If they can bring this to focus. This is the extent of disease going far off laterally in the gluteal region. Is it visible, sir?
Yes, yes, it is.
And then I'll show you the coronal view. And this coronal view is showing, this is the puborectalis here. puborectalis. This is the anal verge. So this is the height of a sphincter. And we can see the disease is going slightly above the 50%. You can see the disease?
Yes.
This whitish part
Yes.
is the tract. So we have to see the height of disease, maximum height of disease in relation to the height of puborectalis or anorectal ring. So anorectal ring is here. This part is anorectal ring. And this is the disease. This is the disease. This is anorectal ring.
Yeah.
Is that clear, sir?
Sure, it is, it is.
So now we are going back to the patient and we'll do examination in anesthesia.
Can I ask you a question?
For
Can I ask
mapping
you a
of disease.
question? When you get a failed lift, what is your next go-to procedure? In
Let
general.
me first examine the patient. Give
In
me a
general.
probe first so that
Very
I can.
briefly.
Yeah. नहीं, straight वाला नहीं है, butterfly probe. Do you have butterfly probe? Because the external opening, just let me see here. It is here. So give me an IFT, infant feeding tube, and a straight probe if you have. So I'm not putting the probe all the way, just seeing the direction. Can you see this?
Yes.
So I'm not trying to force it down all the way, just seeing the direction, and I'll put some saline solution to see whether it is coming from internal opening or not, to see the patency of entire tract. Give me some IFT or something. Don't have that cannula. So you can see
It's coming.
it's coming. This water saline solution is coming.
Yeah.
Though
Very
this is
clearly.
a free flow. We haven't probed it yet. So there is no chance of making any tract. Give me a speculum. Give me a speculum. Now this external opening is very far off away, very far away.
Yes.
From, you can see the entire gluteal region is traversed. So if we try to do something like a fistulectomy, fistulotomy, it would make a very large wound. Number one, and number two, because substantial sphincter complex is also involved. So it would, speculum, vaginal speculum, Sims speculum. Because substantial sphincter complex is also involved.
So you've chosen?
So it
lift.
will also lead to some degree of compromise incontinence as well. So now we will try to just put a section over there. and-
Localize.
yeah. So again we are pushing this water solution, and can you see?
Yes.
Just focus here.
6 o'clock, is it?
Can you see the internal opening?
Yes.
I don't know whether they are focusing it or not.
No, it's
Put
very
the
clear.
section.
Very clear. Cameraman is awake.
So it's clear.
Very.
Okay. So now we have two parts of disease, which I will also discuss during the talks. That is the central part of disease which goes from here up to the intersphincteric plane, and the other part of disease which goes from the sphincter complex up to external opening. So we can just, for purpose of understanding, we can say this is the central part of disease, which is from here up to the sphincter complex, and outside the sphincter complex up to external opening is the peripheral part of disease. So because it is the central disease which leads to recurrence, it is the central disease which leads to spread of all the disease everywhere. So first we need to take care of the central disease. In central disease, if there is a mature tract, then lift works. If the tract is not mature, then lift is not a very useful tool, because there is a spread of infection.
Very true.
And that spread of infection would not lead to proper disconnection of tract. For that we need a proper mature tract, and that is why in Western countries, when they are planning lift procedure, they routinely put a seat on 3-4 months back prior to lift procedure, and then they do a lift procedure. So routinely they are putting a seat on. Now give me a right angle. Just hold it here. Because earlier he was operated, so I can feel some sutures also here in this plane. So you can see this part. Can you see this?
Yeah.
From internal opening, I have put this right angle forceps so that I can enter in the intersphincteric plane. Because this patient was operated, this part is also sutured, and that was within 2 months. So the opening is very broad.
Yes.
The opening is broad so that my right angle forceps can enter right from the opening into the intersphincteric plane. So I want somebody to be holding from this side. Yeah. Okay. So can you see this area?
Yes.
Which I am going to open a little bit. I am going into the intersphincteric plane, right from the internal opening. So I will just cut a little part of internal sphincter. A small little part of internal sphincter, and that is below the actinate line. Only that part which we usually cut. Give me 2 retractors, sister. Hang it back. So first we are trying to deal with the central disease, and then we will come to the, okay, just retract it like this, retract it like this, okay, put a section. Some sutures are also there.
Have we tried a star retractor for this?
Lone star retractor.
Have you tried one?
Can you see the
Yeah.
sutures? Give me a mosquito or something, some artery faucet. I can take out these sutures. Lone star, are you talking about lone star retractor?
Yeah, correct, yes.
Yeah, I don't think they have the retractor in OT, but routinely we don't use. We use the retractor when we are dealing with perennial tears and...
Yeah, it's a good one in situations
It
like
is
this.
good. You can see some suture material coming out. Probably it is PDS suture. Just a section लगा लीजिएगा यहाँ पे. So this plane was violated actually earlier. That is why we are getting all this. So
It's going for biopsies as well.
we will take tissue for biopsy as well. So now
So how much do you cut here exactly?
I am simply entering into the intersphincteric plane, which I have opened. And just a minute, give me this. And you can see these sutures. Can you see these sutures?
Yes.
More sutures here, visible. So these sutures were put earlier. So any space which is infected, we tend not to close it. Give me a curate. More sutures you can see coming out. They are all PDS sutures. Give me a curate here. Now we will try to curate this area nicely. Yeah. So all this dirty granulation we will take out from the intersphincteric plane. Sister, मुझे wash करने को दीजिएगा, खूब सारा irrigation दीजिएगा. So we'll take out all the dirty granulation from here. You can see all this coming out. Is it visible, sir? Pictures are clear?
Yeah, it's very much visible, sir.
See, lot of granulation, dirty is coming out. Wash the whole thing, good suction.
So you never close the internal
So
opening.
what you are doing actually is getting into the heart of the disease, that is the central disease, which is in the intersphincteric plane.
So you never close the internal opening, sir?
No, we close internal opening or we do a lift procedure when the tract is mature. It is a fibrous cord-like tract.
Okay.
Not in this situation where there is an abscess cavity present. So we never tend to close any abscess cavity. We always keep all the cavities, all the potential spaces open whenever we are dealing with infective pathology, rather than closing them. When the tract is mature, cord-like, then you can either close the internal opening or you can also do a lift procedure or slot procedure, whatever procedure. But when there is, because in MRI also, which is done recently, just few days back, there is a horseshoe element in the intersphincteric plane. So it's not a cord-like thing there. Okay, now we will see. Give me a straight probe or some sort of probe. Okay, we will see whether this tract is going all the way. So you can see the whole probe is consumed, and it is coming. Yeah. Just put the suction. No, suction. Now can you focus here? So I can show the probe. So is this probe visible to you? Just to hold this. Is it visible, sir?
We don't see that, sir.
Focus here?
Yeah, we can see that.
Can you see the probe?
Yeah, we can see it coming up.
Audience?
Yeah, we can see that.
You can see the probe. Okay. Just a little bit of oozing, sister, touch. Sister, isko idhar, just a bit. Touch.
Should we go to Dr. Patsadi for a minute? Can we go to the other side if they're still operating?
Okay.
We'd like to wind up there.
So,
Dr. Patsadi?
So this intersphincteric vein is now open. Okay. And now what we will do, we will take a curette. Give me a, cautery. So we will excise some part of external opening from here. Give me a curette. We can see whether we can put this curette all the way or not. So a lot of curettage and debridement is to be carried out into the peripheral part of the disease, and we have to use fistula scope for this, and we can also use laser for this. But until we have taken care of the central part of disease, nothing will work. Now give me the fistula scope, please.
So John sir, the opposite OT has been completed, sir. But Parthasari sir will be happy to talk to you, sir, just in a few moments.
We just wanted to thank him, that's all.
Yes, sir.
So for any VAF procedure, how do you counsel the patient? Especially...
Sir, what I did, I closed the internal opening, the transanal closer. I did the transanal closer of internal opening, and then I closed the lip wound, and then external opening wound also I closed.
So, Dr. Ravi, you mean internal opening is not visualized at surgery, though you see it on MRI?
Endocautery.
That's why I was asking whether intraoperative, in a setup like this, where lots of experts are available, you can get the radiologist come down, do the intraoperative ultrasound.
So should I wait?
Accepted. They don't do it obviously in other settings.
Should I wait? Okay. So am I connected to the audience?
Yes, sir, you are connected.
Okay, so all the way the fistula scope has gone in.
Tell us a little bit about the scope you're using, 7 mm, or what diameter is it? And can you show it to us?
Focus the camera here. See, this is 18 centimeters length. Diameter is 3.3 into 4.7. This is oval. This is not circular. So the diameter is 3.3 into 4.7. 18 centimeter length, right? And the camera is 8-degree camera. And now you have these two sides. We put glycine mannitol either from this side or from that side, whichever side it is available. Some people put suction on the other side, that is not required. Then this is working port. You can put the endocautery, you can put the brush, you can put the forceps for debridement from this part. I'll show you later, right?
Yes.
So that's about, and we use glycine mannitol solution because we have to use endocautery. If you are using only for diagnostic purpose, you can use normal saline as well. But we use endocautery, so we use glycine solution for that.
Right.
So now the length is short for this patient. You can see the external opening is too far away. So even this 18 centimeter length is fully consumed. Can you see that? Suction. Still it has not reached all the way up to internal opening. The water is coming, you can see. The water is coming, but the tip is not reached there. because the length of the tract, but it is very close to that part. Okay. So can you see the inside? Can you show on the monitor?
Yeah, we have the monitor.
So is the inside of the tract visible?
Yeah, it is.
So now, since we have taken care of the central part of the disease, which is here, I will try to show you. So we have reached almost to that area. What I am pushing is, you can see this push is from my finger, from internal opening. So you can see this?
It's distended much better now.
Is it visible, sir?
Very, very visible.
So we are very close to internal opening part.
Yes.
So now we will start debridement. Give me cautery.
Do you use
Monopolar.
a brush at this stage? Or
We
you
will
go for
start
a cautery
debriding
straight
the
away?
tract. Since we have already
Clean it.
opened the intersphincteric plane
Yeah.
from inside,
Otherwise, you'd use a brush, no? If you go it.
we will use the brush also.
Yeah.
We will use curate also.
Make it as raw as possible so that it close off. That's the idea.
So now, endo, cautery, is it working? I don't see. No, it's not working. Sorry. Okay, it's working now. So we are in the lumen, very close to internal opening, because our fistula scope could not reach all the way up to internal opening, but just almost there.
Correct.
So I could feel the tip with my finger.
Yeah.
So we are going, debriding it. We can also use laser for this part, we will use. And then we will cure it. So
This is
basically
bipolar?
this is thorough
Is this
debridement.
bipolar or monopolar?
What we are doing is de-epithelialization or debridement. All the dead, dirty, infected granulation will be taken out. So that is the purpose.
What diathermy is it?
Pardon?
What diathermy is it?
Huh? Valley lab. Monopolar, Valley lab 30. So now see the peripheral part of disease, we can use mechanical curettage, but definitely waft offers an opportunity to do a under vision thorough debridement. So it is very helpful for fistulas which are having very far off external openings like this one. These are good cases for waft because the external opening is very far off, and the tract, if you try to curate out, if you try to core out the tract, it will leave behind very large wounds that will take very long time to heal. So for these patients, this waft is a very useful tool because you can do a thorough debridement. But the basic surgical principles, which are that you have to take care of the central disease, the source of the disease has to be addressed. That is very important because if we don't address the source of disease, no matter what we do, whether we use laser, we use fistula scope, the chances of recurrence will be very high because the source has not been properly taken care of.
That's very true.
So in this case, we will do further thorough debridement of the central part or the intersphincteric part of the disease. And we will not close anything. We will keep everything open. Once it has been closed earlier, and we have seen that led to a recurrence. So this time, we will not close anything. And any infected cavity, the basic surgical principle is not to close it. Any infected cavity. If there is a good fibrous tissue, fibrous tract, you can suture it. Like Dr. Paz Satri must have shown in the other OT, lift procedure. But not, so case selection, individualized approach, customized approach is very important. Otherwise, in a mature tract, we can do a lift procedure also. We would have done in this patient, but lift procedure was done earlier in this patient and it did not work, and the probable reason is that the tract was not mature. So putting sutures and slightly keep the tip of your cautery slightly away from your lens, otherwise the heat may cause damage to lens. So when you are withdrawing cautery, it is better to withdraw the whole fistula scope instead of, see, don't do like this. Do like this. The trick is to do like this. That is, I'm withdrawing the scope, not the tip of cautery. If I withdraw the tip of cautery, it will come very close to lens and then it can cause damage to the lens. So keeping the tip of cautery slightly away, because it's a very long tract, so it is taking time for us to come out all the way from internal opening to this part.
What's the role of glue to obliterate the tract during a waft, at the end of waft?
See, first of all, like in this case, there is no role of glue because we are keeping everything open. Our intent is to
Yes,
keep both
this is my
sides
acute
open.
one, but in-
So any role of plug or glue would be in those cases when we are trying to close the tract. Means we are trying to close the internal opening or that intersphincteric part of tract, the central disease. That we do in lift procedure. So you can put some glue when you are doing lift or when you are doing primary closure of internal opening or when you are doing mucosal advancement flap. So just for reinforcement, you can add glue just to reassure yourself that we have done something. So otherwise, for those cases, so first of all, important is we have to understand where we have to close and where we have to keep it open. That is the most important part.
Just to this side, please.
Methods of closure are many.
Sir, excuse me, sir.
But when we have to close and when we don't have to close, that is very important
Lift
to
failure
understand.
or improper identification of the tract?
Pardon?
In both cases, it is a lift failure. How to take it, whether lift failure or tract was not identified and ligated properly?
I'm not getting voice properly.
Sir, in both the cases are lift failure. How to identify, actually how to take it, whether it is
Means
lift
you
failure or,
want to ask that
improper
what are the
identification
cases
of
which are
tract
suitable for
ligation,
lift.
sir?
Case selection is important in fistula surgery. Lift procedure is a very good procedure and even I have been doing it since 2011-12 when I went to Dr. Arun. Since then I have been using it and very happy with the procedure. But I told you case selection is most important. Lift is a very good procedure because in lift you are going in the intersphincteric plane, finding the tract and ligating, dividing it. And then rest of the thing is just managed the way I am managing this. But important thing is that is happening only when you have a mature fibrous tract. In cases where there is a infective cavity in the intersphincteric plane, you cannot divide a cavity and ligate it. If you try to do that, it will lead to recurrence. So, so as I said, in Western countries where lift is very frequently performed, they have a routine that before lift, they will put a seat on. And they will leave this seat on for, 2 to 3 months and then do a lift procedure. So when patient comes to us, either patient comes to us in a stage where the tract is already matured, we can do a lift procedure. We can identify that on MRI or intraoperatively. And then if the tract is not mature, we find there is sepsis, intersphincteric sepsis. In intersphincteric sepsis, then either we manage it this way, that we open the intersphincteric space, drain everything out, leave the wound open, or the other part is that we drain it and then we put a seat on. And then after some time, we do a lift or whatever sphincter saving procedure we are performing. So the idea is that the basic surgical principles should be respected. All these are tools and techniques. Sure, absolutely. Absolutely. And in between we can come here. Give me the curate. So in the meantime, another OT is ready. So we will come back again to catch up with this case. So now you can see that we are curating all that we had, de-epithelialized. We want to remove it. All the dead tissue, we want to remove it. So
Sir,
all this
one clarification.
is being taken out.
Sir, do you listen?
Sure.
How deep is the tract from the skin level in your assessment?
This
See,
tract
it
is very
going-
deep. You can
it is
feel,
not
you can see
traversing
there's a
through
lot of
muscles.
muscle
If I am
bulk.
correct.
It is
Is
going
it?
deep to the muscle and that is evident on MRI also. It's not a superficial tract.
But what will happen if you lay open the entire peripheral part of the disease?
If
and
we
then
lay open the
excise
entire
the
disease,
tract
it will leave
and
behind
then
a very
repair the
large
muscle?
wound.
It will always heal and only deal the central part of the disease. That is how I have done few cases. No major damage is done even if you excise few part of the maximus or whatever muscle that
See,
comes in
both
between.
options are there, but you have to select a better option with your available expertise and your available, when more than one options are there, we want to find the best option. And at the moment, although patient has one recurrence, but still considering a very large wound leading to very long time of healing, and still we can go for one more, and that option still exists. We don't say ki what we are doing will give 100%
How are
result.
you
Nothing.
sure that you have cauterized the entire part of the disease, even if some viable?
I am cauterizing and I am debriding, sir. It's not only cauterizing. I am removing all the dead tissue. It's just like coring out. You are burning and you are removing, burning, removing, unless we get healthy tissue. So we are actually coring from inside. Try to understand. It's not just cauterizing and leaving that dead tissue behind. It is removing all that dead tissue out.
He did, I think, the internal opening.
So now you can see, can you see, the tract is cleaner from before. Can you appreciate? The tract is cleaner.
Sunay
Yeah,
Bhatt,
otherwise
Dr.
we
Sunay
can
Bhatt
have
to the
simultaneous
podium.
screens.
Dr. Chitra, Professor of Surgery.
It is much cleaner than
Hello,
before.
sir. Sorry to interrupt, sir. Our third case is
Dr.
going to
Chitra.
start.
Dr.
I'll
Sendil
give you a brief
Ganapathy.
description about the third case, sir.
Coimbatore.
So this is you can wear gloves. Just wear gloves and come.
Our third case, it is going to be again a recurrent fistula in ano. She's a 16-year-old female with
Okay.
no
No, no.
comorbidity.
अभी आप यही दीजिए. Monopolo दीजिए.
This patient underwent lift with tube in tracts on
Audio is going there, not.
4 months back. This was a clinical picture showing again
right.
two external
They are
openings,
connected
one is
from the
at
other
3 o'clock
OP.
position and another one at 9 o'clock position
Help with the track.
with tubes in situ. And internal
want me to
opening was
use
built
this?
around 0.5 to 1 centimeter
She's
from
very,
anal verge
you
at
know.
6 o'clock position.
I will use it. Okay.
This was
After
a
this.
MRI histogram picture showing an internal opening at 6 o'clock position. And it is horseshoe abscess. Again, this picture is showing the tract on the right and as well as the left side. The tract on the right side is slightly higher and it is going up to the right levator ani muscle. And this is a picture showing external opening on the both sides, right and left perineal region. So we are going to start this case.
Just keep 3 LCs. Yeah, it is done. Okay, make out. Very clear. Just hold it. Give me. Yeah, it's this end doesn't look me, okay? So what I'm going to do is, we are going to inject the dye first. So I will go for demarcation of tracks. Huh? So once you give me a go, I will start. Huh? Yeah. Yeah. Just keep a bucket over here. We have to throw the gauze pieces. No?
Complete removal of the dirty granulation, not for bleeding.
Arshad sir?
Yes, sir. Am I audible?
Yes sir, am I audible to you?
You are audible.
I just wanted to ask one question to you.
Yeah.
Whenever we are just laying open of this kind of the intersphincteric space,
Yeah.
in my experience, I'm finding that if we are doing this in the 6 o'clock position posteriorly,
Yeah.
it is taking a long time to heal, and if it is more anterior, it is the same.
Actually, you have to see that when you are opening right up to the anal verge, the lower part, so that there is good drainage. Because if you have simply made an opening there, and that opening does not find any place to drain itself, again there will be some collection there. So that slope is to be made. That slope from the opening up to the skin, so that nothing stays there, nothing collects there. So that slope is to be made.
Okay, the opening has to be big enough.
Yeah.
Okay.
So right now we are thoroughly debriding the tract from inside. This debridement doesn't mean only taking out the dead tissue, it also means just scrapping out the granulation tissue. So sort of coring from inside we are trying to achieve.
Yes, sir.
So we will use this fistula scope to burn that dirty tissue, dirty granulation, and unless we get some feel of some fibrous tissue or some healthy tissue. We'll keep on doing this process. So it needs a lot of patience. It's not just putting a fistula scope and just burning the tissue all the way, or putting a laser and burning the tissue all the way and coming out. It will not happen. It will not do any miracle. It is thorough debridement.
A lot of patience required for.
It requires, because the tract is big, tract is huge.
Yeah.
So you have to clean it. You have to thoroughly debride it. When you are not laying it open completely, then you have to debride it. So the idea is either remove all the disease or
click some pictures. You can take my mobile
Motion,
from there.
motion will
It
enter
is
the
out of pocket.
internal opening and cause infection in future.
So again,
Post-operatively, when we allow normal diet, motion will enter the internal opening as we have laid it very big opening. What about this?
pardon, I could not understand.
Sir, the question is, because the internal opening has been wide open now,
Yeah.
whether feces will enter into that and enter into the remaining tract and cause infection is the question from audience.
Feces will not be trapped. The idea is when it is wide open, then it will not stay there. Feces will go and it will be washed away. Problem happens when the internal opening is small. Infection enters but cannot be washed away. Problem is not when it is wide. So when internal opening is wide, it is not a problem. Internal opening is small, it is a problem. Just like a wide hernia neck, it doesn't lead to strangulation. When there is a small hernia neck, it leads to strangulation. So those principles follow. So wide open with proper drainage, proper sloping, it doesn't lead to, feces will enter to every wound. Even if you do a fistulotomy, feces enters there. Because feces will go to anything which is, in continuity to anal canal. But it will not stay there. It will not be trapped there. Problem is when that infection is trapped. So we don't want the infection to be trapped. We want the infection to move out. Healing is body's own, natural process. It will take.
Yes, sir. So it gets infected and gets automatically drained because it's a big wound. So
Yeah.
it starts healing. Yes, sir. Thank you.
Dr. Kamal is ready. So we are again having another OT. So in between.
We are getting pictures from another OT as well now.
So audio is being shifted to him now.
Oh, thank you. Thank you very much, Sir Arshad, sir, for
I'm
the
still,
demonstration.
I'm still not done.
We'll
Dear
come back to you
We
later.
will catch up, yeah.
Dear
Yeah.
faculty and delegates,
It will
lunch
take
is
some
being
time.
served. So you can
I will use laser also.
have lunch and come back. It's a
Sister-
working lunch. There's
Thanks,
no
Dr.
specific
Arshad. Can I start?
Yes, sir. I'm going to just tell them that I'm going
any
to
idea about how
use
to
laser also
manage the
in this
branching
patient.
tracts if there?
Okay. Give me laser
The
now.
main tract is being managed here. Suppose we have branching tracts.
Exactly the same way, because the center, even if it is a branching tract, the disease starts centrally.
Yeah.
So you have addressed the central disease, and all the branching tracts you just cauterize, clean it up, and then it will automatically heal.
No, will it be possible to cauterize all the branching tracts through the same wound?
No,
Yeah, you might have to do it patiently. It might take about 1 to
No.
2 hours, but
The idea is to clear the central disease. Yeah? Probably everything will heal then.
yeah. Now, some people just do curettage without laser or without diathermy, but it just adds to it. Maybe the discharge will be less and healing will be slightly faster with the laser and
Foot
cautery.
switch. No, that one.
Kamal
Yes,
Gupta,
sir.
sir?
Yeah. Let me start?
Hello?
Yeah, you can start.
Yeah,
Can you
good
just
afternoon, sir.
explain the patient
Yeah,
and the
good afternoon,
findings?
sir. So we are going to operate a 16-year-old female who was
it's ready?
operated for left 3 months back.
Is it ready? Arun, is it ready?
Hello, sir. Again, a recap of the same patient, third patient. It's a case
it
of
ready? It's not
16-year
ready.
female with no comorbidities.
It's not firing.
She's a case of recurrent fistula in ano. Previous surgery, lift was done with tube
I
was
don't see
placed
the
in
light.
tract, and it was around 4 months back.
The light is not there.
This is a clinical picture showing external opening at 3 and 9 o'clock position. with a tube in tract, and the internal opening was felt around 0.5 to 1 centimeter from anal verge, again at 6 o'clock position. This is the MRI picture showing
working?
internal opening at 6 o'clock position.
Light.
And this is again the
Sure,
tracts on
see
bilateral side. You can see tract on the right side and left side, and the tract on the right side is slightly higher and it is going up to the right levator muscle. And this is the external opening on bilateral side. So we are going to start the third case, sir. Over to sir. Thank you.
So this is
Yeah,
the
thank
third
you.
lift recurrence of the day.
Yeah, can we
Not a
start
good
now?
advertisement for lift.
Okay. So good afternoon, everybody. So as already been told to you, so this is a horseshoe track. I hope the pictures are clear.
Yes, sir, we can see the
us on the
pictures.
screen? Yeah. So this is a track which I am able to palpate, and just for the sake of better understanding for the audience or the delegates and colleagues, so I'm just going to mark it. So one track is going like this. It is like this over here, and another I can make out something
this.
like this. So
Give me curate.
internal opening is somewhere
Lights on.
at 6 o'clock only. Sister,
So-
can you have this thing, hydrogen peroxide? So most important is, first to, just give me forceps. The most important is to identify the internal opening.
Yes, sir.
So what I'm going to demonstrate after my findings, sister, hold it, please. Hold it.
Sorry
Is
for
that
the interruption,
original
sir.
Parkes technique. Can you make out
Yes, sir.
the hydrogen peroxide coming out?
So it's coming out.
Yeah, it is coming out now. This was at around 4 to 5 o'clock position. And now I'm going to inject it from the other side. Sister, forceps, please. Forceps, no.
Excuse me, sir. Sorry for the interruption, sir. Just small announcement, sir. Actually, lunch is being served, sir. It's going to be a working lunch. So whoever wants to have lunch, you can just have it fast and come and sit over here also.
See, so I'm not able to see any, hydrogen peroxide coming out of that. So I will just push it a little bit. Now I will just check it again. Ideally, it should be coming. So it is not there. It's okay. It doesn't change our findings in any way or the way we want to operate. Methane blue, please.
So the left side tract is partially closed.
Yeah, it looks like that. So I'm just going to demarcate the internal opening. So this is very nicely coming.
Yeah, okay,
So
sir.
once it is demarcated, I'm going to insert half-cut proctoscope now. Half-cut proctoscope. That is butterfly which we use in our practice. So that is the internal opening. Alice, please.
So how deep is it from the anal verge, sir?
It is at the dentate line.
At the dentate line. Okay.
Yeah. So I would like to just show it to you.
Are they two
Can you-
different tracks or ramification?
Sir, I will just have to check it.
Okay, sir.
Can you request anesthesia people to raise the head side by 15 degree? Yeah, please, please. So can you make out? That is the internal opening. Is it clear? Is it
Could
visible?
not clearly make out. Maybe you can inject hydrogen peroxide
Yeah,
again so
I
that
can
we
inject it again now. Give me direct. Okay? Can you
Yes.
make out now?
Now it's clear. Yes.
Suction, please, sister. Suction, please. So what I'm going to do is, I'm just going to demonstrate typical Parkes technique. That is excision of the internal opening. Excision of the internal opening. And along with pouring out of the fistula tracts. So this is the original Parkes technique and how we do it. Sister, please, Doctor, 15 degrees head end to be raised. Up, 15 degrees. Yeah, slightly more, slightly more. Yeah, that is better. Slides, please. So can you make out now the internal opening over here?
Can the camera be a bit more closer?
Camera, please. Just to keep it one piece in your hand.
Okay, that's better.
So can you make out the internal opening? I had injected hydrogen peroxide over here. Can you make out?
Just focusing it now. Yes, sir.
So can you make out the internal opening over here? Can you make out the unhealthy
Okay,
granulation
yes,
tissue?
yes. We can see a dimple there.
Okay,
Yeah.
so what I'm going to do is I'm going to demonstrate a typical Parkes technique. So what we do is we go half a centimeter above the dentate line or the internal opening and do the markings all around.
Yeah.
Elliptical markings all around. Like that. So now we are going to excise the internal opening.
So excision of the internal opening means, do you excise that part of the internal sphincter as well?
Absolutely, sir. We are going to excise the internal opening. Just to hold it. And hold this. Give me another analysis. Analysis, please. So that is the internal opening. This is the mucosa, some mucosa.
Yeah.
And can you, sir, make out the fibers of the internal anal sphincter? These fibers. Can you make out?
Yeah.
So I am going to go up to the deep intersphincteric space. So fibers are very clear. You can make out very clearly.
So by this you will be excising the that
I am
infected anal
excising the
gland as
internal
well.
opening along with mucosa and submucosa. And see, because it's a smooth muscle, there is no twitching of the fibers. So once we are cutting the external anal sphincter, then twitching is normally seen. That is one of the ways to make out, because below this lies the external anal sphincter.
Yeah, that'll be a good guide.
So one should be very, very careful while operating and try to avoid bleeding. And although we know about lasers, they work in pulse mode, but one of my friends, Mr. Sudarshan, who is an IITian, he told me, he's a manufacturer of laser, and he told me that he makes cautery also, that cautery also has got pulse mode. And that is the reason you should be very, very gentle, even when you are cutting with cautery, although the pulses are very small, very short as compared to other instruments. So this is how we are going to excise the internal opening. So this is this original paper published by Park in 1961. Sister, can you take a right angle, please? Right angle detector. Right angle detector. Just hold it very gently like this. Very gently, okay? No. You're out. You're out. Just hold it very gently. Yeah, thank you.
Picture is much better now.
Sir, how deep do you go usually while...
Sir, actually I am cutting mucosa, submucosa and fibers of the internal sphincter so that I am in the deep intersphincteric space. So you can make out that the thickness of the internal anal sphincter is approximately 3 millimeters, and below that is CLM, which is approximately 2.5 centimeters.
Sorry for the interruption, sir. We'd like to shift the audio to Dr. Ashraf for his completion of the WAF.
Yeah. So can you make out the internal opening has been removed?
Yeah.
Yes, sir. So sister, give me one RT.
So we are back with Arshad sir doing some laser for the long tract.
Yeah, I have already ablated with laser and then again curated. So now you can see it is much cleaner from inside.
Yes, sir.
The inside view, you can see that granulation has been scraped out after burning it with oscilloscope and laser. We have scraped out everything. So what you see is now very raw surface.
Yes, sir. It's nice, healthy surface in most of the areas. Sir, with respect to the laser, are you using the radial probe here, sir?
Radial probe, yeah.
And how are you applying laser, just the measurements on the machine? Can you explain that?
Basically 10 watts and 1 centimeter, 1 second per mm. That is for 1 centimeter, 10 seconds.
1 centimeter, 10 seconds, is it?
10 seconds.
Okay.
So accordingly you will have energy. If you have 1 centimeter, it will be... So now I am putting this oscilloscope from the internal opening. Can you see that?
So with the scope, you have gone up to the internal opening?
No. I am putting the scope through the internal opening.
Through the internal, okay.
Into the cavity.
Yeah, okay.
Seeing, because I have done thorough debridement on this side also.
From that side?
So I want to check whether everything is being taken out or not.
Okay.
So this is the cavity.
Yeah.
This is the cavity in the intersphincteric plane.
Yeah.
Which again, see, almost all the dead tissue has been taken out.
Yeah.
So it's quite clean now.
Sir, do you usually leave a drain or something like a small infant feeding tube here after the procedure, sir?
Pardon?
Do you usually leave a infant feeding tube or something in the inside the
No,
trach?
see, if the cavities, both ends are wide open, then I don't usually put. But otherwise you can put a seat-on also, but that I removed within the same week. Anything, any draining thing, we remove usually within a week. If the both ends, because I will widen the external opening also. I will also widen the external opening. So you can see from the internal opening, I have gone in the cavity and looking for any pocket which is undrained. Just give me the curate.
Please.
So whenever you have disease which you are not completely laying open, then make wide openings and debride thoroughly.
So just for some of the junior surgeons to be clear on how to use the laser, so you withdraw at the rate of 1 mm per second with 10 mm watts. Is that right, sir?
Yeah. Okay. And radial fiber.
With the radial fiber.
Yeah.
Okay. Thank you.
So do you have any upper limit for the use of energies when you bust the tract, sir?
Pardon?
Do you have any upper limit, like specific amount of energy beyond which you usually don't exceed or something?
No, the energy that is basically for hemorrhoid. Okay. But for tract, because this is almost more 20 centimeters tract. So it is centimeter, it is the joules per centimeter. So maximum energy will be depending on the size of the tract. If your tract is 2 centimeter, it will be say 200 joule. Right. If your tract is 5 centimeter, it will be maximum energy will be 500 joule. So accordingly, the size of tract you have to give the energy depending on that.
So
but in hemorrhoids, it is said 150 to 200 joule per.
Do you modify it according to the particular case or something, sir?
Pardon?
Do you usually keep it at 10 watts or do you modify according to particular?
No,
case?
usually 10 watts.
10 watts.
Usually keep it. Some people use. Yeah, okay.
So
sure.
We'll just cross over to the other theatre where Dr. Kamal Gupta is operating.
So we are crossing over to the other theatre, sir. Dr. Kamal Gupta, sir, you're on.
Sure. Give me
So
more
as
of
you
a
can
open
see,
cautery so
the
that I-
internal opening has been separated. Just clean the center. So can you make out?
Yeah,
It's a clean
so
space.
it looks like a wide defect after excising the internal
It's
opening.
not a wide effect, sir. It is excision of the internal opening. And now I will show you that it is coming freely. Can you make out, sir?
Yes, sir.
So that is a track which has been separated.
Yeah.
Right, sir?
Yes.
Now other side, I will just see in case I can go, or it is a fibrous tract over there. So I am not able to
So that
see any
tract is not
irrigation
patent.
fluid coming from the 8 o'clock. Just a probe, please.
Keep suction.
So now I'm going to insert one probe.
Give me Elise. Elise.
It is very nicely going and coming over here. Can you make out, sir, from inside? Just a one right
Actual
angle, please.
metal.
Right angle.
I think the camera needs to be tilted.
Just hold it.
Because the camera is coming from the left-hand side, that's why this side we are not able to see.
Please put the camera from the other side. It is somewhere over here the track is going. Sir, can you make
Yeah,
out?
the tip of- the tip
I am
of
not
that
putting
metal
any
we can see.
pressure on it, but it's just coming over here.
Yeah.
So both the tracks has been separated. While Dr. Ashraf was operating, somebody asked a question, what about the extensions or the branches which are going?
Yeah.
So once you remove the central source of infection, any branches which are going from there, they also get separated.
Yeah.
So Dr. Ashraf has demonstrated you the laser. I am going to demonstrate to you one more very nice instrument, and that is Fixation. Fixation is fistula tract coring instrument, and this is the instrument which has come from AMI. Mr. Shafiq is there. So I have been using this. I think in India, first case we had demonstrated. Just take it out. And this is from AMI. So limitations are that it will be a good instrument only. Just to take out other things also. If you have a track which is approximately 5 centimeter length, and the diameter is also not more than 5 centimeter. So these are the parts. So, okay. You have to come from there. You have to come from there now. Yeah. Okay. So that is a malleable probe.
Yeah.
This is a shaft. Can you make out?
Yes, sir.
So I'm going to take it inside like this, and then we are going to separate it. Just rotate, anti-clockwise rotate. You have to separate it. This part has to be separated. Just take one artery forceps. Anti-clockwise.
So you have done the coring now, sir?
No, I'm just starting it actually.
Okay.
So this tract looks very superficial. We can do just fistulotomy, sir. It is almost only subcutaneous. The tract is only subcutaneous. Fistulotomy will give very good result than any other procedure.
Dr. Kamal Gupta, there is a question from the audience.
Yeah, please go ahead, sir.
They are asking why not do completely lay open from the external opening to the already created wound?
Sir, actually I strongly believe in minimal invasive procedures. So whatever I'm going to demonstrate, that is minimal invasive. Even when I was writing the book on lasers in proctology, I was just concentrating on minimal invasive techniques.
Sure,
so, you know, when Park originally did this technique, he had surgical coring. So instead of surgical coring, I'm just going to do the coring using Fixation. So you can make out, sir, the blade, the cutter is going inside. So first was a malleable probe on a shaft. Then there is a button to hold it so that it does not slip. And then just remove it very gradually. So I don't have facility of laser in this OT. Otherwise, I would have first laser ablated it, and then I would have gone for cutting.
Okay. So that has a circular knife at the tip.
Yeah, that is a circular knife. So I'm just going to remove it. Let us see if something comes on this or not. Because if you use laser energy as a first step, that decreases the size of the tract because of a shrinkage effect. So let me see if something has come out or not. If the something is not coming out, that means nothing is coming out, that means the tract was bigger in diameter. Sister, give me water, saline, please. Saline. You can make out little bit of track is there, and then you have to wash it. Sometimes the track is present over there and it doesn't come out.
So fixation works better with us.
Fixation is very good instrument.
With the mature tracks.
Fixation is a fantastic instrument. I think, sister, give me forceps, please. Right angle over here. Sister, just push the water. There is some track over there. Yeah, just push it. So can you make out remnants of the track?
Yeah.
It just came out from inside. Just to clean it from the center, please. Now the most important step is, once we have gone for this, sister, give me a curate.
Dr. Coimbatorepsg, sir, we will be shifting the audio to Dr. Ashraf for a final word from his side.
Yeah, sure.
Dr. Ashraf, sir, you're on.
Okay, so we have thoroughly debrided the whole
the
diseased
shaft.
area from inside out.
Fixation shaft.
Yeah, so you can see
Fixation
this is
shaft.
the internal opening side and this is the
Fixation is
external
good.
opening side.
We
And
can't
we
see
have
anything,
also
sir.
widened the external openings. See the draining
We
area.
are not getting the pictures from Dr. Ashraf's OT.
Are you getting the pictures now?
No, we are just seeing some
Okay,
gauze or
sister,
something.
give me 20 bike then.
Okay, they are.
I
they're
think
not
we are
the
getting pictures only from the scope.
No,
Yeah, now we are
outside
getting the actual
Give me
picture.
Okay. So what I was saying that we have completely thoroughly debrided the tract using fistuloscope, using laser, using mechanical curettage. And we have made the both sides wide open. You can see this side. That is the side of internal opening.
Yes, sir.
Is it visible here?
More camera slightly more closer, please.
Bring the camera here. Is it visible here? This is the intersphincteric plane where my thumb forceps is
Yes,
going.
sir.
This is the intersphincteric plane.
Yes.
Okay?
Yeah.
And this is the external opening part, which also we have widened.
Yeah.
So both the draining areas are wide open.
Yes, sir.
Okay?
Yeah.
And the in-between tract is completely thoroughly debrided.
Yes.
And these fistuloscope and all these things helped us. If we did not have this, then we would have done it only with a curate.
Yes.
Blindly, as we do. But with the help of these instruments, you can see now the inside is quite clean.
Yes. We saw that while earlier.
So the inside is very clean now. What earlier we saw was a dead granulation, and now what we see is healthy tissue. Okay. So this is what we have done. We are not putting any drain. We are not putting any seat on. Another option is putting a seat on. From inside out, we can keep that seat on for a few days, and we can remove it.
Yes.
But that is optional. We have thoroughly debrided, and we have made both the openings, both sides wide open in this case.
Yes.
Wide open because the disease is there in the intersphincteric plane. Otherwise, we would have closed this side and we would have made this wide open.
Yes, sir.
But because intersphincteric plane, the disease is there,
Yes.
and that is evident on MRI also, and that is evident on intraoperative finding also.
Yes,
That is why we have made both the ends wide open. And
Yes,
that gives a very good chance of recovery in this patient.
Yeah.
So you can see that instead of making a very large wound, right from here up to here,
Yeah.
we have made two small wounds, one here and one here.
Yeah.
And we have tried to remove all the disease from these two wounds.
Yes, sir.
Right? So
Yeah.
I think that is best as minimal access or minimal invasive
minimal.
procedure we can do for this patient as of now.
If this can heal better than big, large ones, why not minimally invasive proctology? Definitely there is a move towards minimally invasive
So
procedures.
definitely for cases like this, had this opening been here, I would have opened it. Okay?
Sir, how often do you follow this patient in the post-operative period?
That is a very important question. I follow these patients.
Just give me that.
Voice echo. I follow these patients
the shaft.
until they are healed.
Fixation
See,
shaft,
if
the
the
long.
patient is living in Lucknow,
Sir,
every
Balu,
week I will
what I
call
could
him.
make
If the
out
patient
was
is living at far off place, I will ask him to stay in Lucknow for a few days, maybe 4 or 5 days, if not in hospital, maybe at some other place, and come to me daily at least up to 5 to 7 days. And then when he goes back, again I call him initially every once in 2 weeks. If he can come earlier, once in every week. So following these patients, sometimes wounds are dirty and you need to clean the internal opening again, this side again. So those things are required. Following these patients, and that is the apprehension when we are operating at operative workshops, complex cases, I fear. Not because operating part, we do whatever we have to do, but the follow-up sometimes is not as per your, as you do yourself at your own place. But Dr. Santhin is here, or Dr. Balu is here, so I will keep updating with them that how this patient is doing. Maybe we can share pictures. So that follow-up part is extremely important because these wounds take long time to heal, and in between sometimes you have to do a little cleaning, little debridement, small little things make, sometimes big changes. So that is very important actually. And the person who has operated should actually follow these patients. I follow all my patients myself, except those who are operated in operative workshops. That is a problem there.
Are there any instances wherein the post-op patient has come to you and the patient needed clean up once again, or examination under anesthesia in the OT or something?
So many times it happens. We have to clean the wound. Sometimes in dressing we do usually in lithotomy or proper operative position on an operating table. So we examine the wound whichever way, and we can do a little bit of cleaning on table, in OPD as well. But those patients who require examination in local anesthesia, some patients may require some little debridement in. So those things are needed sometimes. And when you are dealing with complex disease, you have to be prepared with all this, and those are not failures actually. If your patient needs a little bit of cleaning, debridement of wound during follow-up, that doesn't mean that your primary procedure failed. That is simply part of complex disease. It may take some time to heal completely, and during that time you have to keep following the patient. So post-operative wound management is very important, and I have dedicated a couple of technicians who are with me for the last 10 years, and they also know, but I always examine all my patients myself when they come in.
So Dr. Ashraf sir, sorry to interrupt sir. If you're done with, can we shift on the OT to Dr. Kamal Gupta?
Thank you very much, Arshad sir. It was an excellent demonstration, and you have given it every chance to heal now. So we will be shifting to the other OT where Dr. Kamal Gupta is also finishing his case, I think.
Thank you.
Thank you,
Kamal Gupta sir, you're on.
Packing.
Alice. Yes, sir, we have finished the fixation on one side, and on the other side also we have done it. Now we are just going to close it. The tunnel should always be closest at 20. The tunnel should always be closed so that the fecal matter or the liquid part of the motion does not enter through this tunnel.
Chair angi vechikla. I will sit and show the MRI. Give me something in my hand. Long something. Other than that, sterile, any long instrument, anything?
So for this closing?
Instrument in the tip, fine tip. Vidu vendor. Kudu.
Kamal Gupta sir, you are planning to marsupialize or close
Yes, sir,
the wound
100%,
partially?
Sir, I never leave any fistula tract without marsupialization. That is supposed to be mandatory. Just I will take a stitch over here, actually needle holder, which normally I use is slightly different, but it's okay. We will just take a stitch over there. Just give me another needle holder. Do you have? Good.
Sir, can I have a question?
So sir, actually I'm in a habit of using 2 needle holders. This technique I picked up from England, and it is very easy. So what basically I'm trying to do is, the fixed season openings I'm trying to close.
Okay. So that is the external sphincter muscle, the defect in the external sphincter muscle or the hole in the external sphincter you are closing.
I have not cut anything, no?
Yeah.
I have not cut anything.
Yeah.
So the sphincter will go, I mean that stitch will go through the internal sphincter also.
Oh, okay.
This is the subcutaneous part of the external sphincter. Just pull it gradually. Yeah, that is good. Clean it from the center. Clean it from the center. Good. Give me scissors. Boss, just keep the field clean. So just to make sure that I have not left the tunnel unattended,
He's just
I am going to inject some saline.
He's already excised the internal opening.
that will be left open.
So can you make out?
Along with the infected
Nothing is
gland
coming
and
out.
the internal opening.
So next
part
step
of
is
tissue was excised already.
the marsupialization.
The purpose of this stitch was
Just a one second.
the fecal matter not to enter
Okay,
into the...
give me thread. 20. So what basically we have done is a typical Parkes technique, and it was very easy to identify the tracks going into the
You have a question, sir?
deep posternal space,
Saying all the
deep intersphinctic space. So this is how marsupialization is done. So the idea is that there should not be any bleeding, and proper hemostasis should be maintained. Oh, sister, this is not working.
Excuse me.
Give me the
I
second
have a
one,
question
please.
from the floor, sir.
Hold it.
Saying all the first three cases are like
Clean
failure
it,
of the
clean
lift
it,
which was
please.
done previously.
Arey, keep my
Was
field
it,
clear.
Was it due to
Section,
the
please.
immaturity of the tract which was there attempted, the lift up procedure has been attempted prior before the tract maturity could be one cause, or was it as the lift has been attempted in an acute phase, just like draining a perianal abscess, they want to attempt a lift at the same time.
Yeah,
Was
we-
it maybe a cause due to the failure for the lift, sir?
Yeah, we can only guess at this point of time. So as Dr. Arshad said, it's case selection which is very important. Maybe the case selection was not good, or maybe technical failure, or but it could be anything.
If a patient presents in an acute presentation of perianal abscess or ischioretical abscess, and we find the internal opening is there, and when we inject a hydrogen peroxide, it comes at the 6 o'clock position. Is it advisable to open up the intersphincteric space and do as what Kamal sir did, just coring the internal opening and leave it open in the first sitting itself? And will it,
There should not be any blood
will
in
it
the
be helpful to prevent a fistula coming in future, and
This is
patient
clean
doesn't
from
require
here.
any second surgery?
There should not be any
Yeah,
blood
I
in
think
the
it's a
field.
very valid question. You want to drain the abscess through the internal opening itself without making an incision on the skin
No, sir,
outside.
from both sides. We get an pus pointing with it will be 4 or 5 centimeter away from the anal bulge. You give an incision there, drain the pus, you inject a hydrogen peroxide, you can see that coming through a 6 o'clock position or somewhere else. As the procedure demonstrated here by the Kamal sir, just if you can see the internal opening, we can core it out, and only the internal sphincter, and we can leave it like open. The chances of developing fistula can be reduced or not?
It can be reduced. It will be reduced. I think, yeah, if it is a patent internal opening, you can do that.
See, for-
With drainage, with fistulotomy at the same time, can reduce the chances of recurrence of the fistula in the future.
So this is proximal fistulotomy only if you analyze it. What I have done is proximal fistulotomy and distal coring of the tract.
The full tract, sir, making it the wound much bigger.
No, you don't need to open the full tract. It's just up to the anal verge. From the internal opening, you open the internal sphincter up to the anal verge. That's all.
Dr. Sendil, sir, we will be
Yes, sir.
starting the history of the next case. So we will be presenting simultaneously. So Dr. Kamal Gupta, sir, for a moment your video, your audio will be muted.
Yes, sir, we have already almost finished. Thank you.
Thank you, sir.
Good afternoon, everyone. Our next patient is a 35-year-old male who presented to us with the perineal discharge for 2 months duration. He underwent surgery for fistula in ano before 10 years, and the details were not available. He had no comorbidities. This is a clinical picture showing a old scar at 3 to 4 o'clock position around 5 centimeter from anal verge. And there is an external opening at 3 o'clock, 5 centimeter away from the anal verge. And the tone was normal, and there was an induration suggestive of internal opening felt at 6 o'clock at the level of dentate line. There was no obvious abscess or any other palpable side tracts were there. This is an MRI picture showing an external opening. And again, this is a picture showing the intersphincteric tract. And this is again the picture showing the internal opening at 6 o'clock position with secondary ramifications on the right as well as left side. So this is a case of transsphincteric perianal fistulous tract with 2 secondary ramifications, St. James grade 4. Over to Samrat sir for...
Hello.
Hello, Dr. Samrat.
Yes, sir. Sir, good evening, sir, Senthil sir, and all.
Nice to see you there.
Yeah. So before going to the patient, let's see the MRI so that we will have fistula map and pattern. Accordingly, we can plan this case. If we see this is a T1 image, here we can see that internal opening at a 6 o'clock. If we try to trace above, it's going on the left side. It's going on the left side. So for here above we are not able to trace. So better appreciation we can do in the T2 fat sat image. Here we can see that internal opening. Here there is some hyperintense fluid is there. Probably this is a deep post-anal space. And if we go up, you are seeing that this is in the 6 o'clock deep post-anal space. And going above, this on one side track is going on that side, and other side it is in the internal opening in the 6 o'clock. If you try to trace above, then going on the 3 o'clock, means it is on 6 o'clock to 3 o'clock it is going, just outside the external sphincter, Same thing, if we see little bit above internal opening, we can very well appreciate at 6 o'clock. Means it is a 6 o'clock internal opening going to the deep post-anal space. From that, on the lateral aspect of the external sphincter, and from there it is exiting towards the external opening. If we see these sagittal images, in sagittal images we can very well appreciate the fistula. This is the fistulous tract. This is the fistulous tract, as if the fistula is going high transsphincteric going towards the levator. So these are the coronal thing we can appreciate how it is exactly happening. In coronal images we can try to appreciate the fistula. This is the internal opening, this is the deep post-anal space going down, and then it is curving, and it is there along the external sphincter, So taking back on the patient feedback, all these point we can take that axial images, T1 images, T2 fat sat images, sagittal and coronal, we'll try to appreciate on the patient and how things will come. Accordingly we'll plan. So coming to the patient, here we are having the patient in a prone position. It is a lip position we are planning, and here we have kept the anoscope inside the anus, and actually patient in the prone position, most important male patient, your penis has to be ventral, because if we put penis and give a strapping, that may come a later on problem. For that reason we need to make the penis ventral. Then patient, we have given nice traction. The intention of traction is by giving lateral traction, that intersphincteric space become obviously able to visible. So we are trying to appreciate the external opening. We can appreciate very well at a 3 o'clock external opening. And internal opening, I am seeing here, we can appreciate the internal opening here. Are we able to appreciate, sir?
Yes, there is another opening-like thing, even distal to that, as more proximal to that as well, but probably that is just a crypt, I think. So that is the external opening. We can see more clearly.
External opening and internal opening we are having.
Yes.
Sound come.
So the internal opening is more distal to the dentate line, is that?
Usually what happens because of fibrosis, it's true that it will start at the dentate, but every time, I think everyone is surgeon doing the fistula surgery, every time we will cannot find internal opening at the dentate, little bit higher, little bit down. It depends upon the how inflammation and fibrosis has happened. It is a long 10-year prior operated patient, it appear little bit down. So other one challenge is you can see that external opening, and here if you see this track is going like this, means the fistula has started from the internal opening, it has went to the deep posternal space, and as per the MRI it is going like this, and it is just in this space and it is forming like this track. So appear like that. So fistula mapping, if I want to put on this patient, it is a posterior high transpentric fistula. Fistula mapping is internal opening at a 6 o'clock, going to deep posternal space, most probably I feel it is a track, and then infralevator, ischianal, perianal space is involved and opening at a 3 o'clock. This is a map we can keep. As this track appears to be deep, high transpentric, the option is sphincter preserving surgery will be a better option for this patient. So we are planning for sphincter preserving procedure. So before that we can try once injecting normal saline and appreciating. As I got the internal opening which has been mentioned on the MRI, and also I am appreciating, I am happy to start with a lip procedure, that is modified lip procedure.
Dr.
Still
Samrat,
sir?
Sorry to interrupt. Dr. Kamal Gupta sir is about to finish. So we'll be shifting the audio to Dr. Kamal Gupta.
Okay, sir. Okay.
Extend this more. So Dr. Kamal Gupta sir, you're on.
Normal saline. With tip.
Can you just
Dr. Kamal Gupta, we are back with you. You have just finished the case, I think.
So we have finished it. Mass localization has been done.
Yeah.
And so last step which I'm going to do is I'm going to inject, infiltrate locally bupivacaine 0.5% with the pudendana block. Bupivacaine 0.5%, sister.
Okay. Do you inject methylene blue, sir?
Bupivacaine 0.5%. 2 syringes, 10 ml each. Just.
What is the instrument that Kamal Gupta is using?
Monoclave.
Give me 5 needles, 5 ml.
So after marsupialization, the wound looks a bit small.
Yeah,
so
actually it always looks small because, you know, basically the only thing which we have left behind the raw area is the place from where the internal opening has been removed. So all the structures were very clear. Just to give me 26 gauge needle.
Sir, there's a question from the floor.
We can shift to lift.
Yes,
Lift, we can shift to lift.
you want to shift to the lift. Okay. We have
This is the
shifted to
last
the lift.
step.
We
I
are
will
back
show
with you,
how to be
Samrat.
pudendana block. Normally we people palpate for ischial tuberosities, and this is the external margin of the, you know, outer margin of the external sphincter. So these are ischial tuberosities, but basically if you see from anatomy point of view, you have to penetrate just the Milligan septum, approximately 2.5 centimeter low. Just a syringe needle, please. It's okay.
Thank you very much, Kamal Gupta, sir.
Yes, thank you.
Mixed.
We are just moving over to the other theatre where a modified lift is being performed.
Dr. Samrat, the
Yes,
video
sir.
is on for you.
Sir, what I have done here is, I have just done intersphincteric dissection. You can very well appreciate that mucosa and internal sphincter on medial, mucosa, internal sphincter on medial. This is external sphincter on lateral, and we are having internal opening here. So I am just trying to make the side hole so that I can go in intersphincteric plane nicely. Just open up an intersphincteric plane. Once we have opened up intersphincteric plane, then hook the track nicely. We have hooked the track nicely.
Yes.
So as per the lip procedure, what actually to be done here is, we have identified internal opening, we need to transfix the track here and then divide the tract and close the close the intersphincteric space. But actually, the problem, what I have just given morning lecture is, every fistula start with medial to the lateral to the internal sphincter. When internal sphincter goes spasm, then it takes outside course. So what I am routinely doing is, internal sphincter and internal opening I am disconnecting from the medially, so that it will become raw area. That area we will ablate also, and then we will ligate the tract over the external sphincter, and followed by distal tract we will take care. So now next what I am doing is, this is my internal opening, so that area I am just trying to disconnect from the mucosa and internal sphincter. You can appreciate that a thick internal sphincter. This internal sphincter is culprit for all the fistula problem.
Yeah, so it's not just a disconnection, you are excising the internal opening along with the internal sphincter as well.
Yes.
Similar to what Dr. Kamal Gupta did earlier, but with a different view.
Now we have disconnected. Now we are in the intersphincteric plane. That intersphincteric plane, retract. We can appreciate very well, this is the internal sphincter, this is internal sphincter laterally, internal sphincter medial on side, this is the fistula tract which is going here, which has been disconnected, and we can appreciate external sphincter. The problem of us is, we don't want to divide the external sphincter, we are preserving external sphincter. Now another one thought process is there, as per Park, deep intersphincteric space is the culprit. There is a possibility that the gland which bipolar. This is the part bipolar clean go space. This is the intersphincteric plane which has a granulation. We are just trying to cauterize, so that anal gland which is there and which is the culprit, we are just trying to take at the deeper level, we are trying to burn. Patient also had a grade on hemorrhoid, because of that some oozing is there, but anyhow it is manageable. Now this disconnection we have done, further thing is, we need to disconnect the tract from the medial aspect. For that, what I will do is, I will ligate this fistulous opening over the external sphincter. Give me suture. So sphincter pressure is the culprit which causes all the problem, because internal sphincter has gone in spasm. Because of that, it has taken the course to go outside. So primary problem of internal sphincter and intersphincteric space we have dealt medially. Now this is external sphincter. From there it is a fistulous tract. I will ligate the tract over external sphincter, so that we have disconnect the fistulous tract from medial, from anal canal and internal sphincter and mucosa. Rest of the thing we will deal as good as normal curettage of the distal tract. Hold it.
So you're planning to take like a purse string around?
It is like making a hypertensive zone into lowering the pressure inside the anal canal. And this sphincter division, internal sphincter, we do in every kind of fissure. That's not a major problem. And internal sphincter, even in the length, if you have high intersphincteric fistula, whole length you divide, nothing will happen. And more important is, over the external sphincter, ligation tight is not needed also, because external sphincter muscle are longitudinal. When you even just disconnect and just hold it, it will be sufficient.
The suture is...
This is done. There is no damage for the external sphincter, and internal opening we have dealt properly, and internal sphincter spasm, which was the culprit to start all the perianal sepsis, which has been dealt. Deep intersphincteric space, where we expect that some glandular tissue will be there, we have burned with bipolar. So medial part we have taken care, which is the core problem. Now distal part is, we have option just curate, we have option completely excise, we have option laser ablate. More important is make the outside wound wide so that it will not going to have a infected tissue which will cause a trouble. Curate. Whenever you want to curate or do anything, your finger should be inside. So you can see that it is nicely going here and then it is going on that side. We will try to curate all the thing and make a bigger opening. It's a cavity. Because of that, things were not coming. We can appreciate that it is coming like this. It's a whole cavity. In this cavity, because of that, NS also not coming on that side. This is a deep space. We can appreciate that we have come to the deep space. We just wide open the external opening. It's an infected cavity. And also, when we have done MRI also matters, because if MRI and surgery is more than 2 weeks, we can have a cavity because it's an ongoing anoreptal sepsis. Monocular. So what I am trying to do is I am trying to make a larger hole. As there is a cavity, I will put a 8 French tube inside so that patient can wash at least 10 days so that that granulation, infected granulation can be taken care. Fistula probe. Any questions, sir? Senthil, sir?
Samrat, I'm appreciating the procedure you're doing and a different kind of thought process. I'm sure you have found quite a lot of success with that.
Yeah.
When you were taking stitch on that internal opening with the vicryl, what I was expecting was you might just pull it, core out a little bit more of the tract,
it can be done,
more distally, and you will excise off that mucosal and skin part of the internal opening. That was what I was expecting.
No, it can be done, but as track on the MRI and clinically, you also appreciated our probe was going, it is going deep track.
Yes, yes.
When the track is deep, transverse you are having at the same level of internal opening, you can divide and come, even you can divide the subcutaneous and external sphincter. When track is taking oblique, doing that may be a trouble for the external sphincter. So whole track has been divided. We will just open this cavity and put one feeding tube for wash and come out.
Yeah.
And routinely to reduce the pain, what I use is, this is learnt, it's not mine, it has been learnt while seen expert was doing, Dr. Parvez Sheikh sir, that 20 cc bupivacaine with methylene blue I insert. So that gives a good pain relief for the patient. This is a cavity, this is a complete cavity, you can see here, it is a cavity, it is a cavity. So cavity is there, you can appreciate hole, it is going to the deep post-anal space. Here it is a proper hole is there.
Yeah, so it will establish a very good drainage of the deep space.
And this, we will just put one tube and that will give counter incision, will put the tube so that patient can sit on the toilet, he can flush his cavity without much trouble.
How long do you plan to keep that drain?
Usually healing, it is a natural process. Core principle is it is an infected wound. I want infection to subside and that granulation tissue get flushed off. 10 to 14 days is ideal. Patient should have daily swiss bath and daily should wash at least 2-3 times so that whatever things are collecting there, it will get breed outside.
Sure.
Excuse me, sir. Can we have a change in moderators?
Thank you, Dr. Samrat. There is going to be a change in moderators now.
Yeah.
Thank you. You made it look quite simple.
Yeah,
Thank you.
I usually call it as an PIL-TEC. That is, PI is proximal intersphincteric fistulotomy. LT is ligation of tract over the external sphincter. C is distal curettage. So simply I label it as a modified lip. It is nothing more than that. It is a combination of what Dr. Parvez sir does and Dr. Rajna Sukal sir does. Yeah, I label it as an PIL-TEC or modified lip, I will call it.
Do you plan to close this wound, sir? The external opening?
There is a question, Samrat, whether you are planning to close any of the wounds.
No, it is a basic surgical thought process is fistula is nothing but the infected wound. Infected wound, we need to leave everything open, allow it to heal by secondary intention, so that only we will get a healing.
Now, since there is a drain, so does it serve the purpose if you close the wound? Dr. Samrat?
Yes, sir.
Sir, just for the in the interest of the audience, so this external opening is there. Since there is no active abscess there, since you have curated the whole thing, so and also there is a drain in situ. Would you want to put 1 or 2 bites and?
No need, sir. We need to. The basic principle is fat will heal later, the skin will heal early. We want wide open so that even some abscess or something is there, it should get out. Having a 2 centimeter, 3 centimeter, even complete open fistula tract is not a problem. For me being a surgeon, we need to save the external sphincter and we need to heal the patient. Second time seeing a patient with recurrence in OPD is not expected. Having even if needed, I will be happy to divide completely skin because I want patient to heal, not to come with recurrence. So it is better. Why to keep and allow it to again cavity to form, again get the way into the anal canal?
Okay, why not take the drain directly through the external opening itself?
What, sir?
Why not keep a drain and secure it?
Not able to audible, sir. Can
No. Why not keep the drain tube through the external opening itself and secure it?
Sir, it is a dynamic part. We need to understand that fistula is, anal canal is not a static part. It is a dynamic part. Today, even if I close completely, it is going to be, when anus is going to stretch, it will get stretched up. It's better to leave it. If we are having cellulitis or the end, what we do, we allow it to heal by secondary intention. Until and unless it heal, we don't go for the skin grafting, we don't want to close it. That's what. It is an infected wound. It is not. The basic, our thought process as a surgeon, fistula and abscess, we keep a difference. It's not like that. It is an anogenital sepsis. Every fistula has, we have came with a only fistula. We are seeing a large cavity here. This is abscess cavity. We want everything to heal. So if we keep there, allow it to flush it, it's better to heal for the patient.
Thank you, sir.
And this is not the cosmetic area where I want proper stitched and other thing. Let it heal by secondary intention will be better rather than just closing.
What of the main wound wherein the mucosa can be brought to the skin and sulfate, sir?
Sorry, sir, not audible.
Actually, the main wound, intersphincteric space, the mucosa is, excessive mucosa is there. Can it be brought peripherally and stitched to the skin?
That's secure
Like
to the external
muscle
sphincter, sir. That is secure to the external sphincter. That can be treated like a fissure in ano. That will heal like a fissure in ano.
Or else this motion will be coming and disturbing the wound. So the mucosa can be stitched to the skin.
So anyway, that is going to get sloughed out, sir. So just advise the patient to keep the area clean and follow.
Good. Any questions, sir? Fine.
Sir, there is a question from the floor.
Huh.
Could you please comment on the post-op care?
Post-op care is patient should have daily cyst bath. It is a perennial wound. I want patient to have daily 3 to 4 times cyst bath. With proper cyst bath, we need to train the patient that tight and relax the external sphincter so that it will wash off. Every motion afterward you do the cyst bath so that it will get cleaned off. That is a cyst bath. Second is I add the laxative for the patient. At least first 10 days he in a fear that he will have pain. For that you have laxative, stool will be easily coming bulky stool. Third thing is washing. Washing is this area, I want to wash the cavity. Inside the area cyst bath is doing, it will get cleaned up, or it is always better to clean every second or third day in the OPD so that that area will not get a soiling and other thing. So that much is more than enough, and 2-3 days antibiotic more than enough because we have dealt with the infection completely. So this is methylene blue with bupivacaine 20 cc. Mix and give.
Thank you, sir.
So for post-operative pain, this is actually has been published by Dr. Roy sir. Paper is there for the hemorrhoid, and in fact I have seen personally the master of fistula surgery Parvez sir use for the post-operative care methylene blue. In fact, it is also working for me in last 2 years.
Thank you, Dr. Sunay. Thank you, Dr. Chitra. I welcome the next set of moderators, Dr. Rajat Raghunath from CMC Vellore.
Sir, excuse me, sir. How do you dilate this methylene blue, sir? Sterile methylene blue? Sir?
Dr. T.K. Swami, SG Erode. Sir, please to the stage. Dr. Kannan from Chennai.
Betadine NS. Mudinchida.
Hello, this is Dr. Karnan. For the benefit of the audience, can you just elaborate about the methylene blue dilution and as well as how much you can inject? Hello?
Hello.
Is it audible, sir?
Yes, sir. Tell me, sir.
The methylene blue usage, because a lot of literature is there, still there is some controversies also. But what is the routine dilution and as well as how much maximum we can?
Sir, actually published data is 20 cc bupivacaine with 1 cc of lignocaine, 1 cc of methylene blue. If we are having obese patient, you can use 1 cc 10 cc lignocaine, 20 cc bupivacaine plus 1 cc of methylene blue. It's really help for the patient post-operative to have a less pain, and we need to counsel that patient that post-operatively you have some green urine 1 or 2 days, one thing, and second thing is patient will be happy. Patient will be happy in early phase that pain is less, but after 3 days he will come, that pain is coming. We have to tell that there will be a numbness, but after 3 to 5 days your thing will start paining, you need not to worry, it will go off. So cavity in the tube in the cavity we are just flushing and leaving. I think all the procedure is finished. The principle we have done, explain. Anything else, sir?
Sir, do you have any experience of this permanent discoloration of the skin or necrosis after?
What, sir?
After methylene blue injection, do you have any patients have permanent discoloration of the skin or necrosis?
Didn't get, sir. Not audible, sir.
Is it audible now, sir?
Some. Tell me, sir.
Sir, actually one of the complications of this methylene blue is permanent discoloration of the skin.
Nothing will happen, sir. Nothing happen. After 3 to 5 days, it will get disclosed.
Okay.
I think addition of methylene blue will not cause 10% relief or something. Just lignocaine alone will do, and just somebody has done something and it is becoming very popular. It's not just take it things, and it has to come in any leading journals and all.
Samrat, will you be flushing post-operatively through the tube? Samrat? Hello?
Hello, sir.
Will you be flushing through the tube post-operatively?
Yes, sir. This tube is going to be near the scrotum on anterior aspect. Patient can sit on the toilet and he can flush 90 ml of normal saline, 10 ml of betadine. It will just flush the cavity. Things will come out.
Okay. That's the idea of putting the tube. Very good.
Yeah. Procedure is done, sir, and this is external opening. This will be the inner side. We can appreciate there is no bleeding, nothing is there. Absolutely okay, sir.
So this tube will be useful only for flushing.
Yes, sir.
For drainage, the wound is bigger.
What, sir?
It will drain through the wound properly.
Yes, sir. It's like, just give normal saline. This is like it is there on the anterior aspect, and then you just flush it. The flushing, everything will come out.
Yeah, that's
so it will get flushed completely. He is happy to do his dressing at home.
Correct. Very good.
And usually 8 French tube doesn't cause discomfort for the patient. If little bit higher, patient will feel uncomfortable in post-op, sir.
Well done, well done.
Done. Give me a pack, betadine, lignocaine soap pack, lignocaine jelly, and gauze piece. Betadine.
What's the next case, Samrat? Is the next case ready?
Simple gauze piece will keep, and that can be taken out after 4 hours.
Hello, sir. Next case is not ready, sir. It will take around 5 to 10 minutes.
One wheel, chinna gauze piece pottu. Procedure is done, sir. Over.
Why do you keep the gauze inside the anal canal?
Hello, sir.
Why you are keeping the gauze piece inside the anal canal?
This is at the opening, sir. If some oozing something is there, it will not going to soak and make a fear for the patient. Even if not keeping, it doesn't make any difference. In the anal canal, I kept a gauze piece just to have a hemostasis after relieving the traction. We are operating with the traction. After relieving some hemostasis, it will help. Before spinal effect goes up, we can remove out the gauze piece.
It's very uncomfortable to the patient.
That's before spinal anesthesia effect goes up, we can take out, sir.
Okay. Some people keep a bit of gauze piece in the tube inside after doing hemorrhoidectomy. It's very uncomfortable to the patient. If you keep your finger, you will know. You know you should not keep anything inside the anal canal. If there is bleeding, you must see to that there is no bleeding and then come out of the theatre. You should not keep anything inside the anal canal at the end of the surgery. This is very, very important. I've seen many people putting a big gauze piece inside, big tubes inside. It's very, very important. Small gauze piece.
This is the strapping which I am taking out, sir. This is very important for any intersphincteric dissection we want. We need to have a good strapping. Thank you, sir.
Thank you, Samrat. Well done. How often you do lips? People are really afraid.
Mic off பண்றீங்களா தம்பி brother mic off.
And the subjective way of doing a Cleveland Clinic score and a Mark score.
For all patients,
All
even the first
patients are
time
going
they are
for
coming.
If first time, second time, third time, how many ever time, every time it's graded and scored. That's what helps us make a decision
So
about
that's
what
it.
we hope.
I actually missed one patient. Actually, most of the patients, they don't complain that they have got incontinence for flatus. They don't complain. If they have incontinence for liquid also, they come with diapap. So you know that the patient has got incontinence. But flatus is very, very important to ask them. And then they will tell you that they have got a lot of gas, but it is only in incontinence. They will tell, sir, I am passing a lot of gas. That means he has got incontinence. It's very, very important. You have to document it in the case sheet. Very, very important.
Moderators, in a short while we'll be starting the next case.
Yes, sir.
So I would like to present the history of the next patient. He's a 33-year-old male who had presented with persistent perineal discharge on and off for the past 3 months. He had underwent incision and drainage on 18/10/2022, another episode of incision and drainage in around 21/2/2003. This is a young patient with not much of comorbidities. This is the external picture of this patient. He's got an external opening which you are able to see at around 3 o'clock position on the left side. And this is roughly about 1.5 centimeters from the anal verge. I think we are able to clearly see the external opening of this patient in the picture. So per rectal examination, he's got an internal opening at around 6 o'clock position posteriorly, which is roughly about 1.5 centimeters from the anal verge, which obviously we are not able to see right now in this picture. So this is the MRI picture. You are able to see a horseshoe-shaped abscess, which is predominantly on the left side, and a fairly not well delineated internal opening, preferably situated in the 6 o'clock position, which definitely correlates with the per rectal examination. So he's also got a superior extension which is evident on the MRI, and we are also able to palpate this extension on per rectal examination as well. And we did elicit a clinical amount of fairly decent amount of tenderness as well, which suggests that he's got an extension, superior extension to the left levator near the bulb of penis. So this is the third MRI picture, which shows an external opening corresponding to the 3 o'clock position which we saw on the gross picture. So this, the MRI fistulogram is a linear transphincteric fistulous tract with an external opening in the left paramedian location of the gluteal region, and the horseshoe-shaped tract or abscess in the internal intersphincteric space with an internal opening at around 6 o'clock position from the anal canal. There is a secondary ramification of the tract with superior extension and ending blindly along the left levator ani. So this patient is right now under spinal anesthesia and he is in the OT. Dr. Kamal Gupta will be demonstrating a laser on this patient. Then sir is getting ready in a moment, and then we will be live streaming it from OT4.
Hello, Kamal Gupta sir.
Sir, he's just getting ready, sir. He's getting scrubbed up. He'll be there in a few moments, sir, for you.
You do sigmoidoscopy. Do you do for all patients or you do?
For all our patients.
But the trust you do for all patients?
No, sir.
No.
As very rightly said, we base it more on our clinical examination. If clinically we think it's a low fistula, there's nothing complex about it, then we just take the patient to theatre. But for complex fistulas, then an MRI.
Trust sometimes they misguide, they tell that they have got another tract there because of the fibrosis, you know, the secondary damage. It's operator dependent, isn't it? So if the operator is good, they will definitely give a good, better results, you know. That's it. Good. Yes. Okay. Yes. No, if you were operating on the anterior side of the anal canal, it is better to be in the jackknife position. You'll be very comfortable. But he is comfortable for all the cases. He is putting the patients in jackknife position. But for anterior fistula, it is always better. You can stand by the side. You know, your assistant can stand by the side. Otherwise, it will be very, very difficult for anterior fistula.
Also, I said he is very comfortable with that position.
Yeah.
Whether it is anterior or posterior. So mostly for the anterior cases, he is very much comfortable. So for which is accustomed.
He is
so
comfortable.
routinely doing the procedure. And he shows in and around only failure rate is 6%. That is fantastic because most of the study shows there is more failures in lift. That is mainly because of the improper selection of the cases and inexpert in the management of the fistula.
Yes, right. Majority of the time we think that the surgery has helped the patient, but the patient goes to some other surgeon if there is recurrence. You don't know whether there is recurrence or not. This happens. Yeah, see, that's what happened. See, one patient underwent truss, then he underwent lift surgery. He came to me. I laid open the fistula. He was in the immediate post-operative period. He was there in the bed, and the other previous surgeon is ringing up that patient. That patient is taking the phone, and the doctor is asking, "How are you?" He is telling, "I'm fantastic. I have operated for the second time after the lift procedure." This is what happens. We think that our surgery is working very well, and we are thinking that we are following. It is not so. So whatever the surgery that you feel you are comfortable, you do it. Just because someone else is doing, don't do it. Or otherwise, you go there and then get trained and then start doing. Just because you have seen one surgery, you should not do. You must do the surgery which is you are comfortable. That is very, very important. If you are very comfortable with laying open, you don't produce any incontinence, do that. No problem.
Sir, Dr. T.K. Sami sir, what is the final output actually, how to choose patients for fistula, you know? The external opening is very near the anal verge, bit away, complicated. How will you just put in a nutshell, sir?
See, for me, somebody, it's okay. For me, if this is going to create incontinence, I will not lay open the tract. See, my simple guide is, if you put one index finger inside the anal canal and you pinch the side of the buttocks, and if it is within that range, you can boldly divide. Nothing will happen. Because it's only subcutaneous part, you can divide. That's what I do. If it is more than 3 or 4 centimeters, what I do is, I circumvent the opening, keep on opening, keep on extending the incision. When it goes into the muscle, I stop there. I stop there. Most of the time, it will not go into the muscle. It will go into the intersphincteric space. If it is going into the muscle, how do you know that it is going inside the muscle? You put the diathermy there. If it contracts, you are inside the muscle. Stop there. Cut it there. Leave it out. Tell the patient, I will not operate. Now put an aceton. Later what I do? I do Lift also I do, no doubt, but very rarely I do. But majority, 90% of the time, I'm able to exercise the tract completely. Completely, that's what I do. But all these recurrences we have seen only after these type of procedures came in. This is what? It's a real, see, we are all older surgeons. We are not new surgeons. We are all older surgeons.
From the very fact, all the 3 cases initially showed were lift recurrence. That itself shows we have to be very careful.
No.
After learning curve only, we are forced to do cases.
You should not decide like that, but there are there are better surgeons who are doing, but probably that surgeon whom done the previous surgery is not well experienced. That's what
Another is, all the cases the tract was well preserved and no signs of tracing of the tract was found. I think here we have to conclude that they haven't traced the tract properly. Within 1 or 2 months, how the new beautiful tract was formed with full extension.
That's good. You must get trained properly. That's very, very important. For not only for this one, for all surgeries, it is like that.
The proctology is the one area it is highly challenging.
Yeah. You cannot
Proper
predict.
selection of the case and the perfect procedure for the particular patient is important in the success. Especially avoiding or restricting the incontinence, primarily for the transsphincteric, low transsphincteric. I will exercise the tract completely external to the external sphincter, and the fistulotomy will be done, the tract piercing both the external sphincter and internal sphincter. So what will happen? There will be less dividing of the sphincter complex. Suppose if you totally exercise, then there is much damage to the sphincter complex. So for that, just fistulotomy in the sphincter complex area and fistulectomy in the external to the external sphincter. So then the healing will be better and less incontinence. Even then, if the patient is getting incontinence, it will be for flatus for transient period.
Arun, just push it further.
And nowadays, the minimally invasive proctology is coming up in a big way, and Dr. Kamal Gupta is doing a lot of work in laser, and he is a laser man of India, like that everyone is called because he is having enormous experience.
Sorry to interrupt.
Let us see
Dr. Kamal Gupta sir is about to start his next case. Dr. Kamal Gupta sir, you are live with audio and video, sir.
Yeah, thank you.
Sir,
Good afternoon once again to all of you.
Yes, sir. We are eagerly waiting.
I think already the history has been given to you.
Yes, sir.
And this patient, basically it looks like A2 type of fistula. That means that the external opening is there and that extension is going towards the levators. So let us see, I can make out very clearly the internal opening. So we'll be starting at the first step with injection of hydrogen peroxide. Sister, just cover it. Sister, just cover it.
So what is your plan, sir?
Yes, sir, your voice from the auditorium is not clear to me.
What is your plan? So you want to assess the internal opening, then you will decide.
Sister, this is very bad. Just cover. Good.
Hello, sir, is it audible now?
So just give me hydrogen peroxide. Hydrogen
As it is,
peroxide.
one area it is contraindicated whenever the
Into.
patient is having pus. So it should not be used. It is absolute contraindicated. So let us see what he is going to do.
Sister, butterfly forceps. Butterfly proctoscope. Hydrogen and methyl blue.
Lasers in proctology, recently published.
Give me six French infant
There is
tube.
a lot of demand. And also you can get it through all the websites.
That's all.
Especially
That's very dilute actually it is.
Amazon, everywhere. it is
Give me
available.
hydrogen peroxide,
Now
please.
It is 8,500.
Yeah, but one person should come this side. Huh? So can you back out, sir?
Yes,
it
sir.
is straightway coming from the internal opening.
Yes, sir.
So now I'm going to place one butterfly inside cyst of butterfly with jelly, lubricated the other one. Yeah, I don't want that circulated. I don't. So can you make out the internal opening very nicely over here? Sir, am I audible in the auditorium?
Yes, sir. Audible, sir.
Yeah, Dr. Kannan, am I audible?
Very much audible, sir.
Okay, sir, your voice is not that clear actually. So it's a big opening. I will show you. Sister, give me one artery forceps. Artery. Clean it, please. Just to hold it. Let's go hold it. So can you make out a big hole over there?
Yes, sir. It's very clear.
So what is it? Please lift the table slightly up. Slightly up. Slightly. Please just hold it very nicely like this. Like that. थोड़ा सा up कर दीजिए. Slightly up. So can you make out the large internal opening over here? Radkanan, am I audible to you? There's a dustbin. No, give me the dustbin. Just keep it this side, no?
Sir, ask the cameraman to go towards the right. And upside down.
Come on, the cameraman over the right shoulder of the surgeon, it will be right always. The cameraman has to be over the right shoulder of the surgeon.
Better focusing on the other.
Sister, this side, please. This side, please. Methane blue. Just hold it like this, huh?
When you want to inject the
Yeah,
hydrogen
don't do
peroxide,
like this. Just hold
it
it
is
like this,
better
okay?
if you inject only a few ml.
So this
You
is
should not
a
keep on pushing
demarcation
it inside.
of the tract.
Just 1 or 2 ml is enough actually.
So we can make out very nicely. It is coming through the internal opening. So first step, what I'm going to do is, I'm going to remove the central source of infection.
Use methylene
That is
blue
the
also,
internal
sir.
opening. I'm going to open the deep intersphincteric space. Cautery, please.
Methylene, the problem
Hello,
with the
sir,
methylene,
is it audible?
Just to clean it from inside. No?
yeah. The problem with the methylene blue is that you can't repeat it. Hydrogen peroxide you can inject any number of times.
Light from here to here, please.
Right, large internal opening.
Good, sister. So this is typical pass technique. This is internal opening. Going to start half a centimeter above it on all the sides.
The first step, you are going to remove the internal opening.
Yes, sir.
Along with decryptoglam.
Yes, sir. Only two
The source
techniques
of
are recognized throughout the world. One is Park's technique, that is excision. Second is Eisenhammer, that is instead of removing the internal opening, you open the tract and do a fistulotomy. That is followed by curating. Park believed that we are removing the anal gland, but it was Eisenhammer who said the anal gland gets dissolved once the infection sets in, and which is true also. Just hold it, please.
If you
Give
can
me,
bend the tip of the pencil little bit, this part of surgery is easier. You can tip, if they bend the tip of the pencil,
30 to 40 degrees.
yeah, it's easier. You can do that with an artery forceps.
So that is the muscles, internal and sphincter fiber, whitish in color, very easy to make out. And there is no contraction, there is no twitching once I touch them, because basically it is smooth muscle. Yeah, there appears to be granulation tissue, unhealthy granulation tissue over here. We will just look for that. Just push. अच्छा भाई मेरा मास्क नीचे करना, मेरे फेस पे सारा वो फॉग हो गया, नीचे कर दो, नहीं नीचे कर दो, पूरा नीचे कर दो. Okay. So very gently we have to go, not to be in a hurry.
Sir, there is a question from the audience.
Put the light, please.
Okay.
Light is not adequate.
Invariably,
So this track, can you make out, sir, from here, Vadakanam?
you can be able to identify the internal
I
opening.
think they are not listening or
In
what?
that case, you can do the fistulotomy and a drainage abscess. If it is low-lying internal opening, if it is high-lying, and if you are not able to identify the internal opening, always better to drain the abscess and then come out. After 6 to 12 weeks, once it's getting dry, then you can be able to assess the internal opening. In that time, you have to do the MRI, assess the tract, based on that you can proceed further.
Give me one artery or fine
Having low
probe.
submucous
Just a
abscess or
probe, please.
intersphincteric abscess with low internal fistula.
Or curate, nice curate.
So most of I try
Not
to
very
drain
bright,
the pus
broad. Yeah,
and then
this
inject
good.
the hydrogen peroxide. And you have to
So
keep the
once I have
cross
removed
over
it,
the injecting site.
over here,
So what will happen, the hydrogen
this
peroxide
is a
will come out
space
through the
which is
opening.
going up.
So if
So
there
can
is
you
an
make out?
internal opening, no, there is no much edema. It will
This is
open.
the unhealthy granulation tissue which is
Curettage
easily
plus
curatable.
low lying.
That ball is there?
So single stage procedure of drainage of the abscess.
Tell all the patients that they will get a fistula.
चारों तरफ जा
This is
रहा
very,
है,
very
यहाँ पे ना
important. Though
intersphincteric
the
branch,
incidence
okay?
is only 50%, you must tell them that
Actually,
all of
they are
them
not
will
able
get.
to listen to
If
me,
he is
yeah.
not getting, you will tell, sir, Varun Chonenge, Valla sir, he is happy, okay. What you tell them, you will get a fistula.
Based on our
मैंने निकाल तो दिया पूरा, ये देखो.
Suppose if we feel there will be any chance
Unhealthy
of
granulation
recurrence,
tissue.
you have to inform them at least 10% of chances.
मैं यहाँ से.
If you feel there is chances,
We can go
you
for
get
quick season, we
90%
can go
chance
for
of
laser,
getting
but इसको
against
पहले curate कर लो.
second stage fistula. Because immediately after surgery, whatever you say, the
See
patient
this.
will accept.
This is a
Only
deep
the problem
intersphincteric
starts
space where infection is
There is
present,
any failure.
and how we can make out, because lot of unhealthy granulation tissue is there. Sister, keep irrigation ready.
Sir, you are curating
Suction
from
and
inside,
irrigation
eh?
ready.
Sir, is it audible?
Anybody from the
Look at
theatre?
this part. Yeah.
So
See,
the audio
this
connectivity
is
is
very,
done.
very nicely over here, and it is very easy to understand. Oh. So that is a deep intersphincteric space. This side is this is what we have opened, okay? Now, this is this one boundary is there. Okay, this is the anal ring, okay? This anal, we have opened it almost over there. So what we can do is, we are going to laser bit. Am I audible to them?
Sir, are we audible now?
Okay. Sister, give me one sponge, this gauze please. No, give me a non-touch. Right. So, sir, we have opened the intersphincteric plane and the deep intersphincteric space. Both the planes have been opened and curated, and all the necrotic material which was present over there, it has been removed. Now, as per original parks, we can open the internal sphincter up to the anorectal ring, and this is somewhere anorectal ring is, just below my tip of the index finger. This is where I can make out the anorectal ring. So the part which is over here, we can just curate it, and after that we can laser plate it. Arun, can we have laser? So the laser fiber which we use over here is radial fiber, and I think Dr. Arshad has already told you everything when he was operating the case. Energy given is 10 watts per millimeter per second, and in England, St. Mark's they use 13 millimeters. And everybody should be with specs. So ideally, once the laser is activated, nobody should be without specs in the OT. Gauze. So I'm just still dealing with the proximal part. Just make a curate though. Give me curate, please.
You can have it fixed.
Yeah, yes, specs have. Both of you don't look over here if you don't get specs. Both the girls, both the girls are not supposed to look over here, right? In case you don't have specs, don't use laser, no? Just hold it. Even she should. So don't stand at my back without specs. Huh? So laser which I am using is 10 watts per millimeter per second, and this is the area where we are going. Is it ready? Can I activate?
Sir,
Yeah.
sir, is it audible
You can
now?
hear the crackling sound. So we are burning.
Hello, sir.
Yes, sir. Yes, please go ahead.
Sir, is it audible now?
Yes, sir. Laser, actually the intersphinctic part, partially it was opened up to the anorectal ring. This is the anorectal ring. I will just show it to you. So this is the anorectal ring. So this is the intersphinctic space which we have opened. But since it was going towards the levators as per the report, so we have curated it. After curating, we are just laser ablating it. As such, one should be very, very clear. There is no role of laser in, the presence of an abscess. I have seen few people operating perinodal abscesses with laser, but practically there is no role. So once you have done it, again irrigate it, again curate it, and then it should be followed by irrigation system. Yes, saline. Suction, please. Oh, sister, this is hydrogen. It's okay, no problems, no problems. It's okay. Relax. Just take one of the specs, please. Arun, specs निकाल दो.
See, the hydrogen is the
So now one more step I would like to see that in the MRI they had mentioned there is a horseshoe at 6 o'clock. So let us see in case there is any extension which is going towards the 7 o'clock position. So this is a curate. Nothing is there. I cannot make out the curate going anywhere. So it must have been opened when I was opening at 6 o'clock.
Anand sir, your voice is not audible here. Just make sure your mic is on.
My mic is
it
on.
audible now?
Yeah, sure, sir. I will just give me a minute, please. I think मेरे को ना ऊपर कर दो mic.
It is little bit
Just put
feeble,
it,
not very.
Just put it near my mouth. Sir, am I audible now?
Sir, now it is audible. Is it audible now?
Yeah, you're audible, yeah.
Okay.
Okay.
So basically, this is the part which we have opened up. Now, the proximal disease has been taken care of. Intersphinctic, you can make out, sir, my probe inside, intersphinctic space.
Yes, sir.
So that has been taken. It was curated, followed by irrigation. Again, it was laser ablated and irrigation. So once again, I will curate it. Section. It's okay, no problems.
Sir, this is
So that is what we have done now. Now the distal part is left. So that is the distal part, and it is not a very big tract. But see, sir, it is going over here. So can you make out the probe coming
yes,
up?
Sir. Yes, sir. Yes, sir. Both internal and external, it's very well seen.
And it is blue color stained. So I can laser ablate it. After laser, I can just go for fixation also. Serous and necrotic material which is coming from there.
Yes, sir.
I hope my voice is clear.
Yes, sir. Very clear. Are we audible clearly? Hello?
Yes, sir. Am I audible now?
Yes, sir. You are audible.
Okay.
What about us? Are we audible?
So, Dr. Kanan, the proximal disease has been taken care of, and when I had inserted it was accurate, it was straight away coming in the intersphinctic space. So that is the deep intersphinctic space I was talking to you. So now what I am planning to do is, After curating, I will laser ablate it. Sister, give me laser. Irrigation, please.
So there was a communication going
Arun,
anteriorly,
give me,
isn't it, in MRI?
Specs, please. Arun.
So what is the laser setting for laceration?
Everybody.
Hello?
So, sir, somebody had asked in the previous case, can you open the track? Now, the answer is, in such cases, you can. But only thing is, it will create a very large wound. And there is no point of cutting the external sphincter. So, that is laser ablation, 10 watts per millimeter per second. Sister, hold it. So give me curious.
Sir, are you satisfied about the lacerization for this type of cavity, having active infection?
Sir, I am not able to hear you. Dr. Kannan, not at all. There is no audio in the OT. Sir, please correct it. I am not able to listen to the moderators, please. Just keep it for histopathology, okay? So remove my specs. Specs, please.
Hello, sir.
Yeah. So, sister, give me fixation now. Fixation. Straight away shaft.
Kannan, sir.
Yeah, please. Yeah. So, this is the fixation instrument. I am now going to take it straight away. Last time I have showed you all the steps just to save time.
Hello?
Yes, sir.
Sir, just
So, automatically it has come up. No, one should never try to
So
push
there was
it
a tract
against the resistance.
extending onto the anterior side.
What is the problem?
Sir,
I am not audible? I am not audible?
Still not audible.
Dr. Balu, I am not audible? Yeah.
some technical challenges.
Yeah. This is exercising, huh? With this one? Huh? Curative.
Okay, hello. Yeah, Dr. Kannan, am I audible now?
Yes, sir, you are audible.
Yes, sir, now your voice is also audible. So, sir, I am now dealing with the distal tract. So, that is a fixation instrument. I am trying to use it over here. And already in this case, I got a chance to laser ablate the tract first.
This works
No,
well
sister, give me
before you
artery.
actually.
Give me a
What
forceps.
happens,
Forceps,
the
not
blood
to.
becomes bigger. So it doesn't gather the tract.
So that is a track which we have separated now. So I'm going to bring it outside. Sister, keep a gauze piece over here. Gauze piece, clean gauze piece.
Are we connected?
Sir, where is
Yeah,
the
yeah, you are
instrument
connected.
available, sir?
Is the video coming? Is the video coming? Dr.
Yeah,
Kannan?
yeah, sir, I can hear you.
Okay.
So that is a part of the track which has come out, and little bit I had already taken it out with the help of a forceps. Now I'm going to wash it again. Sister, irrigation, please.
Okay, let me know when we have to start. Give me a thumb faucet.
Sir, can you make out very clearly the fluid coming from inside?
Hello?
Hello.
Yeah, yes, sir.
Am I connected? Or Dr. Kamal Soti is connected?
Yeah,
Whichever-
Dr. Arshad, I am connected actually.
Okay, you go ahead.
Yeah, just give me a minute, please, huh?
Okay, no problem.
Sister, give me this, and give me the 20 bicryl. So I'm going to close this tunnel from inside. So that is a place. Sister, give me those forceps, please. Those forceps. That is a part of the track which has to be cut.
You have long curates?
Sister, hold it, please. Sister, thread, please. 20 Vicryl, 27 mm needle, 5 by 8. That is what I use in routine. So after that, we are going to go for marsupilization. Any questions in case they are from the audience? Dr. Kannan, any questions?
Sir, it's not audible.
Not audible.
Now, is it clear, sir? Are you audible now?
Yeah, I can hear
sir,
you.
what is your experience and what is your outcome for this closure of the?
Sir, actually, outcome is very, very variable.
Okay.
Because, to be very honest, we put it in between somewhere 90 to 95% overall success rate. But that we still feel is very good. The reason being, these are very difficult cases once, extensions are going upward towards the elevators. And most important is, it's a minimal invasive surgery. We have not cut any sphincters. Sister, give me another this thing. And in case we have to revise the procedure, even then there is never any problem.
Okay.
So these procedures are not new. They first started way back in 1961. So I am not doing anything which is new. These are all hybrid procedures which we take, and we have been following the literature. Sister, just pull it out gradually. Pull it out, pull it out. बाहर निकालो इसको.
Sir, is there any instance of recurrence and how do you manage all those cases?
It came out easily? Easily or with difficulty?
Easily.
Easily means I was not behind the track. So she says she came out very easily, and that means I was not behind the track. So I'm going to take another stitch over here. And we are almost done, sir. So that is closure of the tunnel from inside.
Yes, sir.
So before taking a stitch, I will just see from here whether any saline is coming from here or not. Sister, give me saline, please. Syringe with saline. So if nothing is coming, that means it is still coming. So I will take one stitch deeper. So that is an important step. This is partial, it has been taken. No. So I will just try to cover take one more stitch, or I will just try to tighten it, so that the liquid part of the motion doesn't come out of this place.
So do you come across any recurrences after these type of procedures?
He's talking about? Recurrences. Yes, sir. Recurrence, I told you that success rate is not more than 90 to 95%, somewhere in between. So we are conducting multiple studies and for fistulas, and just trying to figure out that which technique is going to be the best. So as I've been telling, that laser has got very, very limited role as far as the fistula surgery is concerned. So you have to take out the internal opening. There is no alternative until and unless the central source of infection is removed.
Arshad, my name. Arshad.
Nothing is going to happen, sir.
Any questions from the audience?
Sir, he used one coring system to core out the tissue. What is the necessity of using laser then? Laser coring or mechanical?
Sir, actually laser, basically what is the principle behind use of laser? Laser is a thermal energy, and once, the cytoplasm, which is all these fistula tracts, they are lined by the endothelium. So endothelium means they are cells. So what happens, once the laser heat is given, after that the water content gets evaporated, which is present in the cytoplasm. So that leads to shrinkage, not the closure, it can shrink, but I have never seen any tract closing till date.
So what happens, the diameter which is supposed, it was 6 millimeter or maybe 5.5, that becomes small. So once the diameter is small, it becomes very, very easy for us to use fixation. Sister, give me curate again. So see, now you can make out all the structures very clearly. That is a internal sphincter fiber. This is the external sphincter. So this is the intersphincteric region, and this is the deep intersphincteric space. And this is where I have already ligated. So nothing is coming out from here, but just going to curate for my satisfaction. That's all. And now the final step is marsupialization. Already been discussed in the last case. Why we do marsupialization? There is a book, sir, by Pescatori. Sister, leave it please. By Pescatori, and the book is on complications in proctology. So he is very clearly mentioned that because the submucosa is lying over there, submucosal, the hemorrhoidal patches, they are lying in the submucosa, or you know, that is the reason there may be massive bleeding sometimes. So one should always try to go for marsupialization. And as I have shown you in the last case, the size of the wound decreases remarkably. So post-operative, it is always easy to manage small wounds. Dr. Jaspal gave a very good lecture in the morning about the management. So what we tell the patient, sister, I am not happy with this. So what we recommend the patient, that they should be using hand faucets. Cut it please, cut it, sister, cut it. So hand faucet, and then they can take a plastic bottle, make multiple holes at the tip, at the top, and use it as for pressure. Any water which is good for drinking is good for the wounds. So that is the principle. And after that, we in our practice, we use N-O-metrogel, which is a combination of metrogel, lignocaine and sucralfate. So idea is very clear that metrogel will take care of anaerobic infection, and of course analgesic effect is here, and lignocaine again analgesic action. Sucralfate is just a coating. So once the coating is there,
whenever you say,
yeah. No, I am leaving that. I am leaving that. I am leaving that. This is the portion. I will just put a loose
Conference will be showing the different armamentarium.
Yeah, yeah.
Just to show you. That's
No,
all.
I'm done.
You
I'm
have to
done.
decide which is better for you. In the same case, if you give it to Parth Sarthi, he will do lift.
am I connected?
So whichever is better, you follow. The conference is to show you
Dr.
all the
Kannan.
armamentarium.
One question to moderators. You can
Somebody from the auditorium?
Scoring he did know.
Can you hear,
Indo
please?
scoring or ecto?
Yeah, Dr. Kannan, Dr. Usher is on the line, and this is the last stitch I am taking now. And I just one important point over here, which Dr. Balu has just pointed out, and which I am going to just tell you what it was, that the part, the drainage part, which we have opened, that should be left open. I am going to take a very, very superficial stitch over here, but not involving the muscle fibers. And this space, intersphincteric space, should be left open for future drainage.
It is for the hemostasis purpose.
And the last step which we prefer to do in all our cases lately is a pudendal nerve block. That we give in all the cases now. Dr. Balu, where is he? Oh, okay.
Dr. Ashraf, you are on, you are live, sir.
No. Okay.
Hello,
so,
Dr. Ashraf.
Dr. Kannan.
Yeah.
Am I audible? Okay. So you're getting the pictures. You are
Hello.
getting the pictures, video of this patient. I'm not getting your feedback. Anybody from the auditorium? Are we connected?
Hello.
Hello. Are we connected, sir? I am Dr. Arshad from OT 1.
Yeah, this is the next case.
I'm not getting any feedback from the auditorium.
Sir, can you hear us?
Auditorium? Anyone from the auditorium?
Yes, sir. Can you hear us?
I can hear you now. So are
Fantastic,
you
sir.
getting the pictures?
Yeah, we can see your probe and...
Okay.
Yeah.
So now this is a complex case with openings here, groin area, lower abdominal wall and groin area. Can you see here? Can you bring the camera here? See, the opening is here with a large scar. Patient have had several operations earlier. So you can see the opening here. Can you bring the camera here? And then scars here. However, these scars are dry as of now, but he had discharge. So this is the flank area, groin area of the abdomen. Can you bring the camera? Show here. Can you see these scars? Is it visible?
Is it the right flank which
This
looks like
is
an
the right
appendectomy
flank, yeah.
scar, sir?
Scar, but it is dry at the moment, and either left groin area, patient has
Yes, we
this
can see that.
discharging opening. You can see that?
Yes.
When I'm putting the probe, this
Is this a
probe is
standard
going all the
fistula
way
probe,
down.
sir,
Can you
or-
see? Can you see?
Yes, sir.
This is going all the way down. Okay. Now this is a scar here. Give me Locks jelly. Now I will do a PR examination, and I can feel a internal opening at 6 o'clock, right? So now before proceeding further, let me show you the MRI. So come, bring the camera there, so that I can show you how these fistulas reach to anterior abdominal wall. Focus here, this. Focus here. Can you see this? Where I'm pointing with the probe? This is the intersphincteric plane and the place of internal opening, this. See this. Can you
Yes,
see
sir.
this?
Yes, sir.
Now see, as we go up, this is moving towards the left, intersphincteric plane. We are going up, you can see this is moving up, right? And this infection. Now look at this picture. First look here. This is in the pelvis, lateral pelvic wall, okay? And now you can see here is the prostate, and this infection is coming anteriorly, and this is here. This is the bladder, and this infection comes in the space of Virgius, that is the retropubic space. Now show here the coronal view, and you can see this is how this infection is going in the supralevator space. And then from here it goes to abdominal wall. Can you see this breach?
Yes, sir.
So this is how this infection can ascend. Instead of going down or laterally, it is ascending up, all the way up to abdominal wall, but continues to be extraperitoneal throughout its course. Saline, just saline water. Now I'll just push some saline from the external opening over the abdominal wall and see whether it is coming from, you can see it is coming down there. Don't put this. Is it visible?
Not yet,
Show.
sir.
Show this and then this.
Yeah, we can see some water. Yeah, we can see the saline coming out of the anal verge.
So I'm pushing the saline from the opening over the groin area on top. Again, I'll show you so that it is clear. Show here first, here. See this? I'm pushing the saline from here. Sister, hold this scrotum. And now you can see. Is it visible?
Yes, sir. It's quite clearly seen.
Okay. So that's it. So now we will put a speculum, large one. Yeah. Put end up, table up, put end up. Sister, you have to hold this, okay? Jelly, more jelly. Table, foot end up. Hold this, sister. Foot end up. Yeah. More. Foot end up. Probe दीजिएगा. Gauge. Small pieces of gauge. Light, down and inside. Further up. Table up कर दीजिए. Foot end up कर दीजिए. Table up कर दीजिए. और करिए. Keep on doing it. I'll tell you when to stop. And foot end up also. Like this. More. Keep on doing it. Wait. Okay. Now, can you see the internal opening here? No, light is still not good. Bring the light down and throw in. Hold it like this. Give me 2 lever retractors. Lever, larger ones. Retract it here. Okay. I want one more person who can come on this side. Yeah. Come forceps. Get one more person scrubbed up. Okay, so now get me a suction with a small tip. Suction with a small tip. This tip will not. You have a small steel tip. Just so you hold this. Hold this. Okay. So this is the opening basically. If I can show you here.
Where
My
exactly
camera
the
person can
opening
show you here. Is it visible?
Yeah.
I don't know whether you are able to see or
Internal
not.
opening not clearly see. Yes.
Show here.
You don't have
Show
a
here.
self-retaining retractor there in the theatre?
Throw light here inside.
You can use bladed retractors so that you can adjust and see.
लीवर रिट्रैक्टर थोड़े बड़े ले लीजिएगा.
Quite large opening with the puckering.
सर आप होल्ड किए रहिए एक लोग इधर बुला लीजिए.
So the retraction is not good. That's why he is feeling it.
Yeah, I'm asking for more assistance so that we can have a better retraction. Okay. The big one, okay. So we need larger retractors and more people to assist us. Okay. You have larger lever retractors? Larger than this. Okay. Good. Hold it now. Good. और आपके पास सेक्शन है वो स्टील वाला पतला टिप, स्मॉल टिप सेक्शन. Okay, we need one person on this side. Okay. So, in these cases also the strategy is to get into the intersphincteric plane, take out all the disease from below as well as from above as much as possible. Okay. Because naturally in these cases there is no option of going for any fistulectomy or fistulotomy. Those options are non-existent. The only thing we can do is the best debridement of the tract, as much of disease we can take out, and then keeping the wound accessible for thorough drainage, proper drainage. Because those options of fistulotomy and fistulectomy do not exist for these cases where the disease is going through the pelvis, across the pelvis, and going up to the abdominal wall or groin area. किसी को बुलाया आपने, sister? Somebody is coming. Okay, hold this from this side. Hold it from this side. Okay, you hold it like this. Now show me good light. No, you don't hold it. Sister, you hold it from this side. Yeah, good. You hold this suction. You hold the suction. Okay. Sister, you hold this. Okay. And you have to hold it like this. Actually, the internal opening is quite deep because I was told by Dr. Balu that this patient was operated earlier, and there was some surgery was done from below also. So now we are able to see the internal opening clearly. I don't know whether it is visible from there or not because it is very deep inside. It is slightly.
The opening is partly visible.
Above the pectinate line. Give me cautery. No, give me monopolar cautery. Yeah. So, this. retractor, sister, retractor. This lever, yeah. You have to hold it like this and you have to keep showing me.
Hello.
Okay, so we are again going the same way. Sister, you have to keep sucking and you have to keep retracting. We are going to exercise the internal opening. Keep showing me. Give me a gauge, 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 gauge. Okay. Hold this. Be steady, sister. इतना jumpy मत होइए. एक touch. You have touch. You have touch. It's very difficult to show you inside because the internal opening is deep, but we are going all around the internal opening. We will go into the intersphincteric plane from below and try to do thorough debridement from there.
Okay.
And then we will also take the help of fistula scope to do debridement from the external opening present over the abdominal wall. So I don't know whether you can see inside or not because it is a little deep inside. Can you focus inside?
Yeah, it's
Camera?
visible. It's visible.
Huh?
It's visible.
Okay, I don't know whether they are able to see something or not.
We are able to see.
You are able to see? Okay. That's Dr. Kannan, I suppose.
Yes.
Yeah, Dr.
It's an
Kannan,
excellent
your voice
discussion.
is so pleasant that it gives lot of confidence when you are operating complex cases and someone like you are sitting there. So, it's not, these cases are always difficult ones.
Yeah, always have all the recurrence cases.
Yeah. Dr. Balu has been very kind today.
Yes.
To keep all the very complex cases for us. So I think in an operative workshop, having these cases, but definitely, but important thing is follow-up is very important for these cases. Operating these cases is one thing, but so I will keep on disturbing Dr. Balu for a long time, taking feedback, and then because once he has posted complex cases, then he should be ready for the follow-up also, and we will not, we will keep bothering him, asking about these patients. So you can see we are going all around the tract. Is it visible or not? I don't know. Okay.
It's visible, sir. It's visible.
So we are going into the intersphincteric plane, trying to excise this lower part of the tract from internal opening, which is quite wide because of the earlier surgeries. So, and a little higher also. We are not cutting any sphincter further, a little bit of internal sphincter only, in order to get access to the intersphincteric plane from below. And we will try to go as high as possible from below and as much debridement possible from below and then from above. I need a tooth forceps, sister. Lagai, suction. You have to keep sucking all the time, okay? Because we are. Do you have a tooth forceps? Tooth forceps. So, this surgery can be very messy sometimes when you are operating in a narrow space, and very soon we will see after laser the next thing would be robotic, because people will be fed up of laser after some time because every patient is talking about laser. So naturally nothing lasts forever, so something will put an end to this mass hysteria of laser. Maybe robotics in proctology may come next. Dr. Kannan, are you there?
Yes, sir, we are here.
Please keep.
You have removed only the part of the internal sphincter? Or?
I have removed the lower part of the internal opening and trying to get access into the intersphincteric plane. Then we will carry out thorough debridement.
Okay.
So this will make the internal opening broad and some healthy granulation will come there over a period of time. Now give me curate, sister. Curate. Okay.
For reducing the bleeding, have you used adrenaline saline?
What did you say, sir?
For reducing the hemorrhage or hemostasis purpose,
Saline,
are you using
adrenaline.
saline with adrenaline or not?
Should I lower it down a little? So we are using yellowfin retractors here. These lithotomy fins, yellowfin. So we can change the position. That's the advantage. It's a luxury rather. So I'm slightly putting the legs down so that I can go up and start debridement from there. Do you have fistuloscope ready? Okay, let me come. Come here. Give me the curate. Give me the curate, please. Okay, so now I'm putting the curate from here
External opening.
and try to debride it from here.
Space of edges.
Jelly? Yeah, I can feel the tip of my, now this is the curate. Now I'll come down so that I can show you that we have reached the intersphincteric plane down there.
Other end.
Give me the stool, please. The speculum, sister, and light, foot end slightly up. Jelly. Use plenty of jelly, sister. No, hold it. Give me something to wash.
To get a good exposure, the position of the
Okay.
patient is very important.
Now,
You have to keep the
give
buttocks
us
at least 5 inches away from the edge of the table.
these two
Then
retractors.
flex
Yeah.
the knee properly.
Okay.
Otherwise, you will not
Light.
have a good exposure.
Light here.
Position is very, very important. Here, the problem is
Go there.
they are working
One
from
person
above
should
also.
go there.
So that's why they have put the
Go there,
position
no?
like this.
One of
So
you go
position
there.
is very, very important to get a good exposure.
Okay, give me suction.
You have to flex
Give
the
me suction.
knee, flex the hip properly.
Light. Hold it. Light inside. Okay. Sister, you have to hold it like this. Not like this. You have to hold it like this, okay? Okay. You have to hold it like this as I'm. Don't turn your hand.
This is really the complex fistula. isn't
Hold it from here.
Of all the cases,
Hold it
real
from here.
complex.
Yeah.
Challenging one.
Yeah, challenging.
Okay, hold
Very
it.
challenging.
So, okay, now give me thumb forceps and gauge.
He is having lot of experience in
Okay.
this department. He's doing
Hold it like this. Okay.
Okay.
You can see the curate out there. Is it visible?
Yes.
Dr. Kannan?
Yes, sir, visible.
You can see the tip of curate.
Yeah, it's visible.
So that's the intersphincteric plane where we have gone from below.
Okay.
It is coming down there. Okay?
Yes, sir.
So we have opened this in the central part of disease. Now we will carry out a thorough debridement from above and below. Okay?
Okay.
And fistula scope, laser, everything will assist us. So now we understand the concept basically that we have to get access to that area. That is very important. And then we use all these tools for the purpose of thorough debridement. So now I am using this curette, then everything else that we have will assist us. See how much all this debris are coming out. Lot of debris are there. Okay. Again, you need patience because it will also require a lot of thorough cleaning and debridement. Somebody give me fistula scope. We put a Foley catheter in these patients where the disease is going across the pelvis, and when we are using fistula scope and using any energy source, we make sure of two things. One, we remain intraluminal, we don't breach the tract, and we also are judicious in our energy expenditure, so we don't want the laser or fistula scope to burn surrounding structures and patient later on presents with a more complex disease. So that caution should always be there. Give me irrigation, sister. Irrigation, plenty of irrigation. Suction, 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 everywhere suction. In some cases where the tract is very neat, we can even close the opening down there with advancement flap or primary closure. But where there is a lot of infection, lot of granulation tissue, it is better to keep all the areas open for drainage rather than closing them. So a lot of tissue is being debrided. I can feel the bone on my left side. My curette can give me the feeling of bone close by. So give me fistula scope, please. Is it ready? Okay. Glycine, glycine. Where is glycine? Connect it. So already we have discussed the description of fistula scope earlier in the previous case. So now we are putting this scope. Camera. Okay. Picture is not coming.
Excuse me, sir. Can
So
we have
you can see the entire
new set of moderators?
15 centimeter of fistula scope has gone in.
Thank you, sir. So I welcome our next set of moderators, Dr. Ravikant,
So you can
Rajagiri
see
Hospital, Alua,
the saline flowing down there.
Dr. Madheshwaran, Surgical Gastroenterology, Coimbatorepsg,
Okay.
Dr. R.G. Mahendran, Salem.
So the fistula scope has gone all the way to the intersphincteric plane into the opening which we had created from below, and you can see the water flowing from below. Is that visible? Can show here. Is it visible? Okay. So now we can see the endovision they are getting. Are they getting the endovision also? I don't know. Are they getting the endovision? Okay, so this is the inside of the tract. We have removed plentiful of debris and infected tissue from inside. Now we need further debridement. So what you see here this fistular scope is actually into the, what you see here is my finger actually. Can you see this? Can you see this finger?
Yeah, sir, we can see.
So I am moving, this is from below. I have put my finger in the hole which I have created from down in the intersphincteric plane. So this is my finger. So we have gone all the way in from the opening over the abdominal wall into the intersphincteric plane below. So now we will carry out the process of debridement and deepithelialization from both sides, and that process will take some time because you need lot of patience for that. नहीं, cure it और monopolar connect करा लीजिएगा. So cauterization and then debridement, curettage. So that is the key basically. You can see all these debris which are coming out. So we need to make this area completely clean from inside. So all this tissue must be taken out, and sometimes there is oozing also because you are see all this which is coming out, not healthy tissue. Light ऊपर कर दीजिए ना, अभी ऊपर कर रहे हैं काम ये light.
Sorry to interrupt. We
yeah.
have the luxury of WAFT now. Okay.
Pardon?
You have the luxury of WAFT with you now. Suppose in case we don't have WAFT means in these situations what to do?
What I am doing right now, I think that is the only option.
Okay.
But I think if you are operating such cases, you should have all the paraphernalia. Otherwise, it is better to refer to that place where those people who have all the paraphernalia. But before this WAFT era, before when WAFT was not existent, then this mechanical curettage was the option which I am doing right now.
Okay.
So do you use PRP sir, nowadays for WAFT? Not for such cases, but simple straightforward cases?
See, simple straightforward cases you can use, but as I said, very simple cases we can manage with fistulotomy. So doing WAFT is not harmful. WAFT means fistuloscope assisted treatment, but even if you are planning fistulotomy, after doing fistuloscopy, it doesn't harm. So fistuloscope is a very useful tool basically. Even for those simple cases, you can put fistuloscope, examine the patient, and then do a fistulotomy if you think fistulotomy is deemed to be good for this patient. Give me monopolar. So fistuloscopy can help you, assist you in many ways. But definitely it is very useful for like this case or the one endocautery, the one which we operated earlier where the external opening again was very far away over the left gluteal lesion. Then I'll show you in the video when external opening can go up to thigh, up to knee. So in those cases where the disease trajectory is very large and large wounds would be created if you try to do, if you try to cut all the tissue all the way. However, in this case, which we are operating right now, we don't have that option of doing a fistulectomy. In the previous case, we had that option. But in this case, we don't have this option. Monopolar switch, foot switch.
As you rightly point
Foot
out,
switch
in the
इधर रख
previous
दीजिए.
case also, sir, if you take care of the
So
central
in this
disease,
patient, we don't have the option of cutting the tissue all the way, because what do we cut? It is all the inside the pelvis. It is inside the bone, not outside the bone. It is not a scrotal soft tissue fistula. It has gone through the pelvis, inside the pelvis to the abdominal wall. So you don't have the option. Those scrotal fistulas are different because they are traversing only through the soft tissue. Connected?
as you said that if the
I
central
don't know whether
disease,
it's
the
connected or
source is
not.
taken care, I don't
So
think
here,
for the peripheral portion, this valve
don't have
or
the
laser
option.
or scooping out, anything will work out, sir. 90% of your job is done if you do a proper scooping out with the scoop.
All right. Huh? Cautery is not working. Monopolar is not working. No, it is not working. It's not working. Now it is working. Now working.
Arshad
Okay.
sir. Arshad sir.
So, yeah.
When do you decide that, okay, this is the point, the waft is enough, we will stop it?
Not in this case. Well, in this case, definitely.
For today, sir.
In general cases, you are asking ki, when do I decide ki I should cut the whole tract, remove the whole tract? This is what you are asking.
No, I'm asking, you're seeing the scope view I can see. When do you decide that, okay, the ablation is enough, the scooping out is enough, we'll stop?
When I see healthy tissue.
What, sir?
When I start seeing healthy tissue. Healthy tissue or in ischiorectal fossa, when we start seeing fat coming out in the scoop, or when the healthy, like in previous cases also we showed you that we could see healthy oozing tissue. So that is the point, because the idea is to remove all the dirty tissue, not the normal tissue. So all the dirty tissue need to be removed from inside. So burn and remove, that is the idea basically. Because the better debridement you are carrying out, more are the chances of healing and recovery. So the idea is, for fistula treatment, the best treatment when you remove all the disease, 100% disease, when we do that in fistulectomy or fistulotomy. So the chances of cure would also be close to 100%. If we can't do fistulotomy, fistulectomy, then at least we should try to remove as much disease as possible. Because the more disease you remove, more are the chances of recovery. More disease you leave behind, more are the chances of recurrence. Especially in the central part. And that is the from internal opening up to intrasphincteric. So this part especially is a little bit, you need patience for that, and you cannot be too aggressive that you start damaging surrounding structures. You have to remain inside the lumen. Do it gently. Sometimes bleeding, oozing can be very bothersome, but definitely packing weight, all those things will be helpful. So a thorough debridement, and we will do that debridement from below also. We will put the fistuloscope from below also, and we will show you. We are not doing anything from the left side because the left side is already dry. So again, we are repeating the process. Okay. Can you show inside? That endovision view. लेंस को थोड़ा वाइप कर दीजिएगा, आगे से गंदा है. It's very dirty. आ नहीं रहा है कुछ. सेटिंग गड़बड़ है क्या आपकी? Wipe the lens. Do white balance properly. Okay. Do it. Give me the curate. Not yet. Setting यहाँ से करो ना. यहाँ से करो. It's not coming. So see, lot of granulation is still coming. See. So all this tissue needs to be taken out. Mr. Wash. So, any other questions in the meantime while we are doing the same thing again and again, and they are trying to set the focus of fistuloscope and we are debriding? Any other questions from the auditorium? Anything?
So my question was, nowadays are you using PRP, sir? PRP for closing after the waft is done? The track, are you using PRP nowadays, or the concept is changed again?
Using what?
Platelet-rich plasma?
No.
You're not using?
We are not using. Still it is not working. Let's see what is the problem. See, as we said, fistula is an infective disease. In infective disease, the idea is to remove the infection. You cannot replace the infection, or within the infection, whether you put a plug, you put a glue, you put anything which promotes healing, in presence of infection it will not work. Unless you remove the infection, and once you have removed the infection properly, the healing is a natural process. So that infected tissue has to be removed. This is the crux of fistula surgery, especially from the areas where it is, which are the source. So that source point should be managed, and unless we do that, no matter what we are doing, we are using stem cells, plasma, plugs, glues, whatever, sealants, whatever we are using, it will not work. So infection has to be taken off, again cure it.
Ultimately, it will all come to the thing, remove the source and drain all the tracts and cavities completely, leave it open.
Pardon?
Remove the source and drain the cavities and tract.
Yeah, remove all the dead tissue, infected tissue, and allow them to drain. All the draining areas should be wide open.
That's why in most
Whether
of
it
the
is
cases,
inside or outside or multiple tracts, all the draining areas should be wide open. Don't keep mouths of draining areas narrow. They should be wide mouthed. That is the idea. Thorough, and if you can remove the whole disease, like fistulectomy, nothing like this, removal of setova. Okay, so now I think they are able to do something. Let us see how the tract looks like from inside. क्या है यार ये? मैं सेटिंग में कुछ गड़बड़ है. इसको यहाँ से खोल के सेट करो. या तो लेंस यहाँ से गंदा है. अभी आने लगा. वहाँ से प्रॉब्लम है. लो सही करो आप. वॉश कराइएगा. सिस्टर जी वॉश कराइएगा. हम नीचे आएंगे, नीचे से करेंगे. अच्छा. So this process is actually, you can see still lot of granulation is coming. So you have to have some patience.
Instead of curating like this, can you pass a roller gauze from above? The opening is very well seen.
Pardon?
Can you pull it down?
Your voice is not coming, sir. Please ask somebody who has a mic to ask this question.
So can we pass a roller gauze from above?
We
so
can
you
do
get
that
the
also.
Roller gauze below.
Yeah, we can do that also.
That's
But
a better
sometimes
option.
it is broken, some fibers are broken inside, so in a blind space usually I don't pass anything which can get broken or which can leave behind its particles or something which again becomes an nidus of infection. But you can do that. So I personally avoid using any such thing because some fibers may be broken inside and then they all lead to source of infection. So the idea is so mechanical curettage is a good option. A curette is a very good tool. It scraps out the tissue. So the same thing we are doing from above and from below. See, lot of granulation is still coming.
Arshad sir, in your experience, you would have come across so many cases.
Abdominal wall fistulas, I think approximately 18 to 20 cases. I have recorded a series of approximately 14 to 15 cases. 2-3 cases were lost to follow-up, and interestingly, most of these cases were from Bihar. I get lot of patients of complex fistula from Bihar, from AIMS Bihar as well as from Indira Gandhi Institute of, that is IGIMS Patna. So I get lot of referral of complex fistula, and out of these 18-20 cases, I think majority of them, they were from Bihar. And most of these cases actually healed well. In 2 cases, we had to repeat the procedure 2 or 3 cases. 2 cases, I think they have not come back for some reason or the other. But the remaining 12, 13 cases, they have healed well, and two, 3 recently operated, I think in last 3-4 months. So we don't say recurrences are not there. Sometimes we have to.
These kind of complex cases, we should definitely accept those kind of recurrences, sir.
What?
In these kind of complex cases, we should accept those kind of recurrences.
Yeah, we have to accept.
These kind of complex cases, sir, on an average, in your experience, how many sittings of WAFT you needed it, sir?
No, I am not intending to go for another sitting.
Okay.
I don't want to come again. Dr. Balu will do that if it is required.
At least in these scenarios, WAFT definitely has some advantage.
As I said,
yes, sir.
see, I'll show you a case where openings were here, here. So all around. So as you move out from the central part,
yes,
peripheral part, so the scope of these scopes increases, because central part actually you have to do surgically,
Only for the peripheral disease you need WAFT, laser.
Yeah, these things are more useful for peripheral disease. Central part you have to surgically tackle.
Yes.
Surgically you have to address that.
At this point, I want to ask you one more question, sir.
Yeah.
Many cases, many of the surgeons here would have seen a main tract with lot of ramifications.
Yeah.
In my experience, if you treat the central disease, drain the main tract, there is nothing much to be worried about the ramifications.
But don't leave all those areas which are accessible undrained.
Scoop it.
Always drain them. Always, ensure that all the dead tissue, infected tissue is removed, and they have access for drainage.
Yes, sir.
That is important.
Yes, sir.
So drainage access should always be wide. So this basic principle should be respected and addressed, I think, whenever we are. हो गया सही हो गया? Okay. So I'll come again. So you have to change your position again and again in order to, because from both sides we want to accomplish this task of thorough. ये इसको करने से हो रहा है, इसमें प्रॉब्लम है, हाँ? हाँ. Okay. वो वहाँ से close था ना? Okay. That was the problem. Now, again there is problem. See there? Connect it to this side. There is some problem with the scope. I don't know. It's not. नहीं कर रहा है क्या प्रॉब्लम? देखो भैया, चेक करो, इसको बंद करते हैं तो सही आता है, देखो. बंद करने पे ठीक आ रहा है, और चालू करने पे आ रहा है प्रॉब्लम.
Ashish sir, post procedure in this case, would you like to insert an infant feeding tube from the opening where you have inserted the WAF now for future cleaning?
See,
in the OPD?
yeah. See, you can put any form of drain after this. You can put some form of drainage, sit-on, feeding tube, Foley catheter, those things. But I generally don't put many drains. I keep the areas wide open, and but definitely that option is.
Do you regularly inject some saline and clean the tract in the OPD during follow-up, or no, sir?
I call these patients regularly. I'll keep these patients daily dressing for at least a week or up to 10 days, maybe 2 weeks, so that they stay in the same city if they are from outside, so that they can come for dressing. And after that, again, we have to call them frequently to see the status of wound, so that these external openings don't close, and there is some cleaning, granulation required. We can do that on OPD basis, rather than allowing it to recur. So that is very important part. Aftercare is very important, and that is the apprehension, basically operating these cases at a place where you will fly down and then go back. And so follow-up is actually very important. So that is the apprehension of operating such cases. If you do a fistulotomy, MIPH, LIS, those cases in operative workshop, those cases usually do not require very dedicated follow-up. Anybody can follow. But these cases like this one or the previous one, they need more comprehensive follow-up care by the same physician or surgeon or the team who knows actually what is to be seen. So that is why I said Dr. Balu will be bothered by me again and again.
The first week follow-up, what do you do in this case, sir, other than inspecting the wound, the cleanliness and the bleeding spots? What else you do, sir, extra, just because the patient is coming and seeing you, the OPD? What else we need to do? Do you give wash?
No, we give wash, but if we see any area is dirty, we will debride it. Maybe we can use some chemical cautery for that. Maybe if needed, we can debride some area in local anesthesia. So that debridement part, wound management part is important for complex fistulas. So that is possible only when we see what is required. That may be without anesthesia, that may be local anesthesia. Rarely you need a proper anesthesia for that, but mostly these patients can be debrided in minimal anesthesia or no anesthesia. And when patient is told that a little bit of cleaning will be done, he usually tolerates a little bit of pain and allows us to clean the wound, because he is very fed up of the disease.
Yes.
So little pain he can bear, and you can simply, or sometimes you can put some carbolic or something just to chemically cauterize those areas.
That's where in these kind of cases, if you can keep an infant feeding tube for 1 or 2 weeks, you can just
You can keep for feeding, for irrigation, yeah.
Irrigation.
Yeah. See, all these options are there. As we said, some people will put something else, some people. So there is no scientific evidence to say that one option is better than the other. If putting a feeding tube or not putting a feeding tube, putting a seat on or not putting a seat on in these cases. So case to case and personal experience to personal experience, those things may differ. But what we are doing right now is constant. There is no confusion that I will not debride it, I will not clean it, I will not leave it open. There is no confusion. Putting feeding tube, putting seat on, putting corrugated drain, those things, there is no evidence. So you can definitely, to facilitate drainage for few days, you can put any form of non-absorbable material to allow or to facilitate drainage. But what is more important is this, what we are doing just now, and leaving the access for drainage. Don't close the draining area. That draining area should remain open.
And regarding your internal opening part, you have removed the mucosa and submucosa, the muscle is exposed. As Dr. Kamal Gupta sir said, do you do a marsupialization, suturing the exposed mucosa to the muscle?
Generally, when I do fistulotomy, I do marsupialization in majority of times.
Okay.
Right. When the two edges are very too apart, and I have also excised the fistula tract, and the two edges, maybe some area I may marsupialize, but generally I do marsupialize. Intraanal also, we generally do marsupialization. Marsupialization actually helps in 2-3 ways. One, it flattens the wound. The wound is flattened. Hemostasis is also there. An external part of wound becomes smaller and looks better cosmetically also. So marsupialization basically it's a sort of saucerization of wound. So generally I do marsupialize after most of my, fistulotomies and lay opens. Yeah, areas of internal opening, definitely. We take a 3-0 vehicle, like in this patient I will show you how I do that. We take a 3-0 vehicle and we simply put 2-3 stitches on both sides, just to make sure that this area continues to drain. Like, curate दीजिए. ये तुम्हारा कुछ प्रॉब्लम कर रहा है. वो किसका है? यहीं का है या वो कंपनी वाले का है? Working? You have told me 4 times. but it doesn't work. The light is too bright. Give me monopolar. It is a problem has. I don't know. क्या problem है, but you have to see. It's not working properly. Earlier it was working. ये मुझे लगता है ना यहाँ पे कुछ है problem. कहाँ है इसका? It's not very clear. Earlier it was very clear. And you keep telling me it is okay. Huh? It's not okay. Like sister, curate. So curate is a wonderful instrument for these situations. So definitely fistuloscope is one instrument which can help you in doing undervision this part in far off areas, inaccessible areas like this. So definitely, and I did not use laser in this patient. In previous patient I had used laser. Okay, I have finished. All I will do is pack. Is there any other case? No other case. So we can close the case because I am done with this. I will simply make sure that this opening also continues to drain. That opening continues to drain. Put packs from both sides. If somebody wants, you can put a IFT or something also.
Thank you so
but
much.
What we have done so far was more important.
Thank
right?
you, sir. Wonderful
So,
demonstration and
thank
very
you so
complex
much
cases.
for
Thank you so much, sir. Thank you, sir.
being with me. Thank you.
Next, we'll be going for master video session.
Yeah, I'll join you there.
Thank you, moderators. We will be ending the live session from now on, and then we'll be going for the master videos and further discussion from there on. Thank you.
कॉटरी दे दीजिएगा जरा. नहीं नहीं मोनोपोलर यार बाहर वाली मोनोपोलर. हाँ.
Balu sir? I think we can start, sir. Is it okay? Start.
One of the procedures that luckily for me was not shown in this beautiful operative live surgery where we saw such brilliant surgeries done was a mucosal advancement flap. I'm just going to go through a few stuff how we do a mucosal advancement flap. So indications for a mucosal advancement flap, as I said previously, is a fistula that is not amenable to a fistulotomy. We don't do advancement flaps when there is active sepsis, when the tract is not mature, and we usually don't do it for a non-cryptoglandular disease, though there are some studies showing it being done for Crohn's. Usually for us, when we want to do a patient for a mucosal advancement flap, the patient would have had a ceton for some time, the sepsis was being controlled, only all the pus comes out with the ceton, it's all dry, and you can see a mature tract present. I'm not saying mucosal advancement flap is the be-all and end-all for every fistula surgery, but it is one method to do in a patient who has a complex fistula. For us, tips and tricks, we like to have a good headlight or a good light source. So when we do a mucosal advancement flap, we have a light on top of our heads. We like to use a fine cautery tip, bipolar, and a fine tip suction, which was demonstrated so well today. Usually, we do this in lithotomy because usually it's at 6 o'clock, but usually if the patient has an anterior internal opening, sometimes we do it in prone jackknife. Our method of anesthesia is GA or spinal, but it can be done under pudendal nerve block. So I hope this works. Yeah, so this is the assessment. The patient has a ceton in place. You can see it's a high transsphincteric fistula. I'll run that again. So first we assess, it's all clean. You can see the internal opening, there's no pus. It's a high transsphincteric fistula. Next, we mark our advancement flap. So we are using the name mucosal advancement flap is a misnomer. It's not only the mucosa, it's the mucosa, the submucosa, and the internal sphincter. So a better name for it would be a myomucosal flap. So what we do is mark the flap that way, that you can see with the apex being very close to the internal opening. And a part of the procedure is to remove the internal opening with the internal sphincter, as you will see. So I'll run that again because it's a very short video. So some people like to give a bit of adrenaline because when you make the flap, it can bleed. The only worry with the adrenaline is you have to make sure the flap is the correct thickness, because if by chance you take a thin flap, the flap will necrose. This is the final marked flap that you can see. A lot of books describe the flap to be like a rectangle. We like to make it a bit more trapezoid, so the base is a bit broader and the apex of the flap is a bit narrower. So then we raise the flap. It's myomucosal, it's not mucosal. You have to make sure good hemostasis. You excise the tip of the flap which contains the internal opening, and you close the internal opening. You can see the internal sphincter being lifted off and the intersphincteric plane being entered. The tip of the flap with the internal opening is taken, and finally what are you left with? As you can see, that is the flap that has been mobilized and now going to be advanced to cover that internal defect that we have created. If I can, I hope this works. If I can point out, these things are retractors that we use to open up the anal canal to make it easy for exposure, what we call the Lone Star retractors. It's quite available, very useful in proctology and for exposure. Then finally, the flap has been mobilized, the internal opening has been taken out. What we said, the disease process has been excised, and now we suture the flap. What we use is a 2-0 vicryl to suture, and first we suture the apex and then go on to suturing the remaining part of the flap. We use interrupted suturing to make sure the flap is sutured well. Hemostasis is very important because if you develop a hematoma, it will very easily lift up your flap and the whole operation becomes a bit of a failure. That's the last bit of the flap being sutured. This is how it looks at the end, myomucosal flap covering the internal opening defect that we had created. Post-operative, so after that you're left with your external component that you can treat in multiple ways. People have treated with laser, excision, fistulectomies, curettage, but all that is up to you. But this treats mainly the internal bit of the fistula. The external bit can be treated in multiple ways. Usually we just curate out the tract, open up, make the external opening a little bit bigger so that the drainage is possible. Post-operative care, analgesics, we don't give any routine antibiotics, sitz baths, and some laxatives to prevent constipation. Success rates, in our hands, it's about a 65 to 75% success rates. If the flap is myomucosal, it has much better success rates. Studies have shown an incontinence rate of about up to 10 to 12%, which mainly flatus, but an incontinence is incontinence, and main thing is to avoid hematoma. Thank you. I can take questions if there's anything.
Any question?
Yes, sir. We try and make sure the flap is as tension-free as possible. Unfortunately, yes, if we have not mobilized the flap enough, if we have taken a not a broad-based wide flap or a very short flap, yes, there is a risk of wound dilatation, sir.
Sir, any length-breadth ratio we should
Sir, at least the studies have shown that it cannot be obviously more than 1/3 of the circumference of the anal canal. Otherwise, if there's a problem, you will cause it to the stenosis. But what we like to do is at least keep the flap about 2 centimeters from proximal to distal and about a centimeter and a half wide. We want to make it more trapezoid rather than just a flap like that. Usually that works for us, sir. But you have to take it as per situation.
How do you know the depth where you have gone is right?
So we have to go, as all my seniors showed today, we have to go into the intersphincteric plane. The flap involves the mucosa, submucosa and internal sphincter. So we enter the intersphincteric plane, raise it off the intersphincteric, and then only we close. So
How
that
is
is what we
the
use.
post-operative pain?
So it's up.
Because the internal opening is in the dentate line.
Yes, sir.
You come below the dentate line.
Yes,
The moment
flap is above the dentate line. So the lower end of the flap comes to the dentate line. Yes, definitely pain is an issue, but we take steps to make sure as less as possible.
Sir, regarding this mucosal flap, proximal part is okay. The distal part, you want to scoop or anything, just put the flap and come out. Is it?
So, sir, we have taken out the internal opening. Just like you saw today, multiple times, the internal opening was taken out with the internal sphincter. We sometimes close the defect in the external sphincter, and the remaining tract, there are multiple ways of treating that. The tract from the external opening up to the external sphincter, there are multiple ways. We usually just curate it out, but people have described laser and other procedures like that. Yeah, no, sir. If you remember, the flap is myomucosal. So the internal opening is taken out with the internal sphincter. That is closed with the advancement flap, sir. That is closed with normal, healthy muscle, internal sphincter muscle and mucosa that comes and closes on top of that, sir. But we have taken out the disease, what we think is the cause of the disease. We've taken out the cryptograndular tissue. So hopefully that will cause it to heal, sir.
So have you ever used it as a primary, have you ever used it as a primary repair or?
Never, sir.
On a recurrent
we've never used, when I say primary, we have never used it in a patient coming first time for a fistula surgery to us. As I said, most of our patients would have, in our protocol is that they would have had a ceton for about 3 months, controlled sepsis, then only we would consider any of these procedures. So we would do a flap only if a patient has had a ceton for about 3 months.
And your indication said wherever fistulotomy is not possible.
Yes, sir.
So practically if all high fistulas.
Yes, sir. So if after the ceton placement, 3 months sepsis, anal sepsis is better, we would, if we cannot lay it open, then we would consider advancement flap.
And you said no antibiotics.
We don't give antibiotics post-op, sir. True, sir. The two things that anorectal advancement flaps are classically known for is one is suprasphincteric fistulas, because lift is a bit difficult to do in a suprasphincteric, or Crohn's disease. To be honest, we are a bit worried about doing it in Crohn's disease, especially with the proctitis to take inflamed mucosa and muscle. We are worried. We don't have experience in doing it in Crohn's. We just put draining cetons and treat it in Crohn's. So I wouldn't, but literature does say that anorectal advancement flap is one way of treating Crohn's fistulas.
Thank you, Rajit sir.
Thank you.
Wonderful.
Thank you.
Slight change in program. Dr. Balu sir want to hand over the memento for the faculty who has come, and after that we will continue master video in few minutes.
Sir, I call upon Dr. Kamal Gupta.
Few of our faculty are leaving, so we thought we should honor them before they leave.
Sir, Dr. Samra. Dr. Jaspal Singh. Dr. Mahendran Ji. Dr. Tilagarajan. Dr. Vikrant. Dr. Kannan. Dr. Parthasarathi. Dr. Sendil Ganapati. Dr. Rajat Raghunath. Thank you, sir.
I thank Dr. Balu and the entire organizing team for giving me the opportunity to talk about lift here. We'll just go directly into the videos. I just want to tell one thing. The original inventor of lift is Dr. Arun Rojanasakal. He published his first paper in 2009, and since then it has spread like wildfire. And we have Dr. Parthasarathi here, who has done the maximum number of lifts in the whole world, I think. So for doing a lift, we place the patient in the prone position, exactly like what it was done in the morning. Both the buttocks strapped and pulled apart so that the anus is nicely exposed. And then we start the procedure by introducing the anoscope, which you all saw, once again devised by the inventor of lift, Arun Rojanasakal. So the anoscope is introduced, and the cut end is kept where the internal opening is, and through the external opening we start the procedure by injecting either hydrogen peroxide or saline or betadine, whatever. So here we are doing the same thing, and we see the fluid coming out through the internal opening, and then we start the lift by doing the incision around the anocutaneous junction and then deepening the incision. The incision has to be deepened in the middle until the tract, and on both sides well beyond the tract, so that a right angled forceps could hook out the tract, and here it is being sutured by transfixing it along with the internal sphincter muscle fibers and tightening the suture. And tightening it a little bit more, because this part can be quite crucial, because quite a bit of times we can see the knot becoming loose later on. So this part is extremely crucial. And then we cut the first tie and then divide the tract over the right angle forceps And like getting results in the exam, for the students, we get results straight away where we inject and it comes into the intersphincteric space and not into the internal opening. So, and then what is being done is picking up the external sphincter side of the tract and removing it from the external sphincter. And then finally coring out of from the external opening side. So circular incision is made around the external opening site and incised all around. And as much curettage is done of the tract, and as much as possible, the part of the tract which is outside the external sphincter is cored out. And that is the part between the external opening and the sphincter. And suturing is done of the small defect in the external sphincter muscle in order to close off that defect as well. And then finally the anal verge wound gets closed with the 20 vicryl sutures. Finally cut, and finally the dressing can be applied over the wounds. So this was a simple anterior type of fistula. So I'll go on to the next video. So this is a patient, once again, already placed in the prone position. Here we saw tracks all the way up to the root of the scrotum. This is one another case where the external opening was at the root of the scrotum, and we can see how we are proceeding in this case. So once again, in order to demonstrate the internal opening, hydrogen peroxide this time is being instilled through the external opening. As once confirming the internal opening, we are just doing the dissection to isolate the tract, and this time what we found was suturing, transfixing, as Dr. Parthasarathi mentioned earlier. Suturing and transfixion, there was a small chance that the suture was getting loose, but after starting to use the endo loop with a plastic pusher, we are encountering that less often nowadays. So here the endo loop pusher is being used to tighten it. And here the crucial thing is, with each bit being cut, it is important that we tighten that endo loop a little bit more, with 1/3 cut a little bit more, half cut a little bit more, and when it is finally cut, we do the final tightening of the endo loop, and then we get this result straight away where we can see the hydrogen peroxide coming out through the hole in the external sphincter muscle. So this is another like transfixation suture for the intersphincteric part of the tract, just as a second line of defense that is being done. And then now we are lifting up the part of the tract which is the within the external sphincter, and then that is being cored out. And then we can see that the tract is extending all the way up to the root of the scrotum. So here a counter incision after about 3 centimeters of the tissue was cored out through the anal verge wound. A counter incision was given about 4 centimeters away, and it is pulled out through the counter incision, and then further dissection is being done. And then finally the complete tract is being taken out at the root of the scrotum. So instead of laying open the complete tract from the root of the scrotum to the anal verge, this is a very useful alternative where we are ending up with only 2 small wounds, one of which will be left open and the middle one will get closed. So you can see that the length of the thing corresponds to the length of the tract, and then the middle wound can be closed and the anal verge wound can be closed as well. The only wound which is left open is the one at the base of the scrotum, so any collection there can drain through that. So finally, a dressing, an ointment-soaked gauze can be inserted through the base of the scrotal wound, and then dressing done. Once again, the same slide is playing. Okay, so now we come to the third lift video. So we saw the two anterior tracts, one a small tract, one a long tract up to the base of the scrotum. Now we are demonstrating a lift with multiple external openings. I'm sorry for the slightly lower quality of the video here. So you can see the multiple external openings on both the right and left hand sides. So all these swellings or sites of external opening with just granulation tissue on top. You can see that instilling hydrogen peroxide comes through the internal opening, and once again hydrogen peroxide to the right side comes through the other openings as well as the internal opening. So now, in spite of having all these multiple external openings on both sides of the gluteal region, still we always do a transrectal ultrasound in order to demonstrate exactly where the internal opening is. And transrectal ultrasound had shown the presence of internal opening at the 6 o'clock position, and that's why we are proceeding to do a lift of the tract at the 6 o'clock position. So here, once again, the incision is being made at the anal verge in the intersphincteric and entered into the intersphincteric space. So the tract and dissection on either side of the tract. So most often you can see that it is traversing past the intersphincteric space at the 6 o'clock or the 12 o'clock position, most of these tracts, and then it curves. When it comes outside the external sphincter, then it curves to go to all parts of the gluteal region, but at the intersphincteric space, it's usually the same as the internal opening position. So the tract is isolated by dissecting on either side of the tract, and then once again endoloop is applied to tighten over the sphincter, and then we check whether there is any flow in the, because of these multiple openings, it needs to be checked whether we have got the correct tract, and then it is not coming anywhere. So now we will divide the tract and see where the hydrogen peroxide comes through. So the tract is divided in the intersphincteric space, and then after checking that it was coming into the intersphincteric space and not through the internal opening. So the external wounds are all widened in order to give a good drainage, and finally the anal verge wound is also closed, and dressing is applied for this patient. Okay, so and this is, there was a lot of discussion about the internal opening. This is once again another video showing an internal opening which is anterior and almost close to the base of the scrotum. And in this patient, initially I searched for the internal opening at the 12 o'clock position, which wasn't there, and the hydrogen peroxide was coming nowhere. And then I turned it to the 6 o'clock position and found that the hydrogen peroxide was coming through. So it goes all the way around to come posteriorly. So this should not be missed as well, because we should look on all parts. So after finding this, once again, the lift was performed. And this is just a case where initially it went into the cavity and then came out through the other opening, but only when we close the other opening, then it goes to the path of higher resistance, that is through the internal opening. And because lots of times we may decide that there is no internal opening, or internal opening could not be demonstrated. So closing the other will allow the hydrogen peroxide to go through the internal opening. And once we demonstrate that, it is a relief, and then we can proceed to lift as usual. Thank you very much. Once again, I thank the organizers for this opportunity, and I thank Dr. Parthasarathi for providing me the first 3 videos. Thank you very much, sir.
Thank you, sir. With time limitation, we will go for the next video. Next video is?
I call upon Dr. Mahendran to present his video.
Good evening, everyone. I thank the organizers and Dr. Balu for giving me this opportunity. I'll be going back to the presentation on fistulotomy and fistulectomy, which is still going to be considered as a gold standard procedure with which we will be comparing all other rest procedures like WAFT or lift. My presentation will be 2 simple videos on fistulectomy and 2 other on fistulotomy. And the whole world has started changing from fistulectomy to fistulotomy. They claim the wound is minimal, the bleeding is minimal, and as well the recurrence rate is almost equal in both. Coming to the general principles of both the procedures, treat the source, the internal opening need to be excised because infection in the internal opening will keep the tract open. An open tract will keep the internal opening open. Drain all the tracts, remove the infective foci, keep the wound clean. This is the first case where we have an external opening at the 6 o'clock position and internal opening at again 6 o'clock. It is a intersphincteric tract. I'll be showing you clearly about the handling the internal opening here. We have just marked first, find out the internal opening. Don't poke the probe to find out the internal opening. Always be free to use hydrogen peroxide with saline or betadine. You can very well appreciate the internal opening at 6 o'clock. Most of the time internal opening will be at the dentate line, most commonly at 6 o'clock or 12 o'clock. You mark with your diathermy, the mucosa and submucosa, the thing what you are going to excise. I come along, I make an elliptical incision, I include the tract and go beyond the external opening, include the induration around your external opening when you are excising or making the incision. As soon as you cut the mucosa and submucosa, you will be coming across the internal sphincter. So always the complete removal of mucosa, submucosa means the internal sphincter has to be exposed. So you have removed the source. Before cutting the apex, the proximal end, most of the time it might bleed, so I used to put a bipolar first, then cut it so that you can keep the field less messy and less bleeding. So now I'm going to come at the root of the tract, go circumferentially, include the exterior as well as the internal portion of mucosa, submucosa. And now you can start from below and raise the whole tract up. Don't bother about the sphincters. Here you will be usually coming across only the subcutaneous part. If at all, if it is even more deeper, you will come across the superficial part of the external sphincter. This is the internal sphincter I am cutting. Now you can see a sprouting granulation tissue there. There you have to suspect, is there any other cavity left behind or is there any ramification of the tract? So after you have cut and removed this tract as a whole, then you can put in a probe and see in that granulation tissue portion, is there any other cavity left over? Like you can appreciate in this video. Yeah, this is the whole tract removed, and that is the sprouting granulation tissue area. which is an intersphincteric cavity, which I'll be doing a fistulotomy. I lay it open, cut the internal sphincter muscle and lay it open. After this, the principle of surgery, as we told, remove the source, we have removed, opened and drained the tract and cavity, we have done it. Now remove the granulation tissue, use a simple scoop and granulate it. You can granulate it. At the end of the surgery, I will be washing it with hydrogen peroxide and saline. A simple tricks, use a vaginal speculum which will give you a very good retraction. Pack the anal canal with gauze, because hydrogen peroxide going inside might give some discomfort for the patient in the immediate post-op. So pack the anal canal with gauze. This is the next case of fistulectomy, where we are seeing an external opening at 1 o'clock. It seems to be quite far from the anal verge, but it's actually a simple transsphincteric fistula. We are going ahead with the fistulectomy. Before starting your fistulectomy, always feel with your finger the internal opening area. It will be most of the time at the dentate line. You'll be feeling like a pit or a papilla or just a puckering, or the opening itself will be felt with your palpable finger if it is big enough. These are all the superficial perineal muscles. As you come closer to the anal verge, you'll be coming across the subcutaneous and superficial part of the external sphincter. You can cut it. Especially in female, be careful when you're doing an anterior fistula, because the perineal body in female is not as thick as a male perineal body. It is quite incomplete. So easily you can cause incontinence. And this is the internal sphincter. I'm feeling the internal opening when I'm doing the same thing. Now we expose the internal opening by retracting the mucosa, submucosa. You can appreciate the internal opening there. So go around the internal opening, make a PA shape of a circumlinear incision and remove in total. Here the muscle exposed is the internal sphincter. You can go away from the tract so that you can remove the tract in total. So wash the area, proper hemostasis. I pack these days with Abgel. I don't do any anal packing, no pad, no T bandages, nothing. A gel foam or a Abgel will do. In female patients, I usually suture whatever muscle I have cut, even though it is superficial, I do a suturing of this muscles. The twitching differentiates external sphincter from internal sphincter, but internal sphincter also can twitch. The deeper parts of the internal sphincter can twitch. The twitching muscles, what you see is the superficial part of the external sphincter. In this case, it was sutured together. So we are removing the tract in total. I have come near the internal opening, we have removed. This is a third case where we are going to see a fistulotomy. As I told, fistulectomy, whichever procedure you are comfortable with, you can go ahead. There is an external opening at 11 o'clock, internal opening at 12 o'clock. It is a transsphincteric, but it's a low transsphincteric. You can appreciate the picture in this. This is the coronal view. I'm sorry. It's a wonderful transperineal ultrasound, not transanal. I do it here for the last 9 years. We get a wonderful report. I'm injecting a betadine. It's a very low internal opening area, just below the dentate line. I mark the internal opening with the diathermy first, because you start cutting, you can miss by traction. So first mark where you want to go all around, then start cutting, remove from the anal verge. The internal sphincter is exposed here. I've removed the mucosa and submucosa. Then I'll be going and handling the external opening. I always go all around the external opening area, and I'll remove this, because the dirty granulation tissue, a scarred portion, will not allow the wound to heal faster. So remove the area all around the external opening. Then you have a probe inside. Never try to poke and come out through the internal opening. In most of the cases, the mucosa, submucosal area might have been fibrosed, so you may not be able to pull out the probe through the internal opening. So don't bother. Over the probe, keep cutting, open the tract, make the fistulotomy. As you proceed further and further, you will be seeing the end of the tract and end of the probe. I'm just opening it out. Once this fistulotomy is done, either always you scoop out the granulation tissue there. Later, the exposed fistula tract, you can excise it if you are comfortable with it, or you can marsupilize. So I'm just scooping out the granulation tissue. I also use bipolar cautery liberally here, because the concept behind in waft or laser, they ablate the granulation tissue, thereby they promote healing and reduce recurrence. So this is the last case. There are controversies whether in a primary fistula, the primary abscess, whether you have to drain only the abscess, or you can go ahead and do a fistulectomy. In most of our cases in our center, we are comfortable doing a primary fistulotomy for abscess cases. In most of the cases, we were able to find out the internal. We have a wonderful radiologist who picks up the internal opening in almost in all cases. This is an MRI showing a right ischio-anal abscess with opening at the 6 o'clock position. If you are not comfortable, drain the abscess and come out. Later on 6 to 8 weeks, go ahead and do a fistulotomy. Here, we can see the pus coming out at the dentate line at 6 o'clock position. Pus is coming out. There is a bulge at the same 5 o'clock in the right perianal region. We have made a cruciate, drain the thing, wash it with saline, then peroxide, put in a mosquito artery or a fistula probe inside, open up the tract by fistulotomy. In certain cases where I have an abscess cavity which is deeper, I'm very comfortable putting a seton, where I use one silk. The seton, here there is absolutely no fear for any incontinence. The seton I have used here there was a lot of pus, so I need some drainage. So I made a seton in the residual, the internal sphincter portion, which I will be removing after 6 weeks. So abscess, these days we have started doing a primary fistulotomy. Anywhere the principle is going to be the same: remove the source, drain the tract, preserve the anal continence. Thank you. Thank you so much.
Thank you, sir. Thank you.
Thank you,
nice
sir.
presentation.
Thank you, sir.
Next, we will call upon Kamal Gupta, sir.
Good evening. So today is fistula, that is a theme of today's conference, CME. But I just talked to Dr. Balu, he just said that you can show all the small videos related to lasers in proctology. So I will be showing you all the videos whichever are possible in 9 to 10 minutes. So starting with the first one. Third-degree hemorrhoids, that is the first video. So we know lasers are in vogue, but there are always limitations of every surgical source of energy which we use. So that is palpation of spiral hemorrhoidal artery vessels, which we do in hemorrhoids, grade 3. And this is a modification of DG Hall, Doppler guided hemorrhoidal artery ligation. So FG Hall is a procedure, means you just palpate the vessel with the tip of your finger. Very nicely you can palpate it. After that, Just keep on ligating all the vessels which are palpable. They are all the branches of superior hemorrhoidal artery. Then from the mucocutaneous junction, that is white line of Hilton, you enter, take the laser fiber inside, and we give energy that is 6 watts, 3-second pulse. And at the end, keep a ice finger to reduce postoperative cellular damage or edema. So what is the tip and tricks? Don't keep on giving energy even if the pile mass does not shrink on the table. That is a take-home message for this slide. Grade 4. So these are grade 4 hemorrhoids. So how we can do it without Milligan-Morgan? The first step will be injection Hylase. So injection Hylase means it increases tissue permeability. That is the principle behind it. So just you can give multiple injections at all the pile masses in the submucosa. Immediately within few seconds you will see marked reduction in pile mass. So once the pile masses are reduced, the steps remain the same. That is hemorrhoidal artery ligation followed by laser hemorrhoidoplasty. So that is at 3 o'clock. Milking is very important. That is another tip and trick. Just ask your assistant to milk it so that there is disengorgement. The pile masses go inside, and later on there is de-arterialization. That is the principle behind hemorrhoidal artery ligation. So wherever you can palpate 3, 7 and 11, it is not mandatory. You will find vessels over there. Even when we are going for Milligan-Morgan, we are putting blind stitches at the pedicle, thinking the vessels may be there, which may not be true. So there are many publications now. So 4 to 6 branches normally you are able to palpate and ligate. So once you are done, rotate the proctoscope 360 degree. So that is a marked reduction after first 2 steps. That is Hylase and this thing, hemorrhoidal artery ligation. So once you are activating laser, make sure it is not too bright. Too bright means you are too near to the mucosa. If light is not very much visible, it is dark field, it means you are somewhere into the internal inner sphincter. So these are the tricks you should know while operating for laser hemorrhoidoplasty, and any skin tags or external hemorrhoid component, if it is there, that has to be excised. Insertion of ice finger for just 8 to 10 minutes is sufficient to reduce postoperative edema. Otherwise, lot of edema is going to be there. Once edema is there, lot of histamines releases there, which can lead to pruritus. So that is something which we should keep in mind. So that is fistula nano. That is internal opening excision and horseshoe fistula type A4. A4 means there is no external opening. So that is very important. Today we had so many complicated cases, but this is another complicated case, A4. So you have just seen in the last speaker, Dr. Mahindra, he just showed you how to mark it. So same thing you have seen in the morning. So this is the excision of the internal opening. That is deep intersphincteric space we were talking, and this is a case we have shown you today. That is how the branch was going intersphincterally on one side. In this case, it was a horseshoe. That is from 6 o'clock to 9 o'clock as well as 3 o'clock. That is a horseshoe. So just curate it, and after that laser ablate it. So this is a case you have seen today morning in the afternoon session when I was demonstrating. And the most important is that once you are going for laser ablation, always have a thorough curating. If you don't curate it, the necrotic material which is present over there will not come out, and leave these wounds open. Marsupialization should be done at the margins, but this area one has to make sure that it is left open. So we have discussed about the advantages of marsupialization during operative session. So this is what you have been seeing since morning. That is the final wound. Anterior fistulas in males, how to approach. So you don't want to produce big wounds. Then this is somewhere at the penoscrotal junction, the external opening. So again, this is typical Parkes procedure. Whenever I am demonstrating this, it is a Parkes technique, and just go for complete excision of the internal opening where is the source of infection. Just gradually pull the fiber up to the base of the scrotum. Always these patients should be catheterized because these are anterior fistula. So never ever operate any case without catheterization. And then take the laser right up to the wound where we have gone for laser ablation. Dosage 10 watts per second per millimeter. And finally the marsupialization of the fistulotomy wound. Now if you want, you can place a seton in this case for maybe 72 hours or maybe for a week, and just for drainage purpose. There is no other purpose for this. Only drainage, so that any necrotic material, if it is left behind, it will come out. That is how the final picture looks. In females, now you heard about weak perineal body. Somebody just talked before me, Dr. Mahindra just talked about that. So this is a young female anterior fistula. We know why perineal body is weak anteriorly, because the length of external sphincter is just half. So just go for excision of the internal opening. Now the most important is you have to open the deep intersphincteric space. If you don't remove it, you will not be able to remove the complete source of infection. As Dr. Arshad told you, it is a central source. So just concentrate on that. It's a central source which has to be removed. Then this is laser ablation of the tract. So laser ablation, the main purpose is for shrinkage. It causes shrinkage of the tract. So this is a procedure you have seen in the morning. And if the tracts are less than 5 millimeter, they normally come out. Very nicely you can bring them out. But otherwise, even if they come out partially, even then it is fine. The reason being that you are just removing the cryptogranular infection which is lying over there. And that is marsupialization of the margins. And the tunnel I have shown you in the morning, how you are supposed to close each and every tunnel which is created after the fixation. So these are the fibers of the internal sphincter. Subcutaneous part of external sphincter is also there. So Vicryl 20, which we use in routine, no PDS over here. PDS we use only for primary sphincter repair. So that is there. Another common condition in our day-to-day practice, pyoneal sinus. So first is pit excision. All of us know about that these pits, that is primary source of infection. So insert the warped scope. You have seen in fistula, this is for pyoneal sinus. Immediately you will see a lot of hair, necrotic material which is lying over there. Go for sharp curating. You can use a brush also, but sharp curating is always better. So all the necrotic material has to be removed. So that is through the working channel of the scope. We take the laser fiber. Always keep it away from the lens. Just remember, it's a very important thing. Otherwise your scope will get spoiled. Pit closure is very, very optional. This is just for demonstration purposes. We don't close the pits in general. And the last video, just a very short video, that is for anal fissure. Now I personally feel it's an overrated procedure. Fissure, use of laser in fissure is an overrated procedure, but close you can do it. So that is the important structure. You have to mark the dentate line, then you have to mark the intersphincteric groove. We talked in the morning about the anatomy. Then from there you can take the fiber. Now the guidelines are very clear, irrespective of the length of the fissure, you should always cut it up to the dentate line. Now this is to make sure that no partial sphincterotomy has been done. So whenever I do this procedure, I am always apprehensive about the partial sphincterotomy. And this is the right way of cutting the sentinel pies or skin tags. Always invert the butterfly scope, proctoscope, half cut, and then rotate it and then cut it. So that is the way it should be done. So, as they say, the most dangerous phrase is we have always done it this way. Fistulotomy, fistulectomy, they are all great procedures, but time has changed. Laparoscopy has taken over everything. Same is with lasers. Thank you very much.
Sir,
Thank you, sir.
Sir,
Thank you so
excuse me, sir. HAL can be done with laser itself, sir? Hemoidal artery ligation can be done with laser itself?
Sir, I don't do it. I don't recommend
Because while taking bite, sometimes we may miss it. Whereas laser, if you are applying for a small area, definitely the fibers will be coagulated.
Sir, actually, to be very honest with you, I am very fond of reading anatomy. There are 3 dimensions. Mr. Sudarshan is sitting and he has got a book in his laptop. 3 dimensions of surgery. First dimension is anatomy. Second is operative. Third is use of laser energy sources, whether cautery or laser, whatever you want to do. But one thing is very clear. If you read the anatomy, nowhere it is mentioned that with 1470, the depth of the laser is only 1 to 2 millimeters. You are spraying it 1 millimeter away, but the vessel is 3 to 5 millimeter deep. How can you do laser ablation with that or dearterialization? It doesn't make any sense to me. Thank you.
Thank you, sir. Next, I call upon Dr. Baller to present his master review.
Can we have the slides up, please? Okay. I'm going to talk about fistulectomy with primary sphincter repair. Fistulectomy, yes, the best procedure because proved cure rates of more than 90% across many decades. So there's no procedure which can really come closer to that. So why are we trying to do a primary sphincter repair? We don't do fistulectomy or fistulotomy because of the risk of incontinence, and most of the fistulas, at least what we see in referral centers, are not simple transsphincteric or simple low transsphincteric or intersphincteric. So when you are dealing with a recurrent fistula, you see what we are blessed with in our day-to-day practice. All of them are our patients which we see in our day-to-day. So you get a lot of complex cases. If you are forced to do something as a one-time procedure with good cure rates, then you have to do a fistulectomy and a primary sphincter repair. We will touch upon this topic and show a couple of videos. Why should we do a fistulectomy or a fistulotomy? Because 93% cure rate, nowhere else, and all the infected wound can be cleared by this definitely because you're seeing and removing everything, but the issue is sphincter compromise. In a female, you will not like to cut any sphincter anteriorly and probably less than 1/3 or maximum 50% posteriorly. In a male, anteriorly less than 1/3 and posteriorly less than 50%. So this is if the sphincter function and anatomy is normal. If anything is compromised, we will not like to do even that. Right? Why primary sphincter repair? So you are doing the best procedure, which is fistulectomy, and to address the incontinence or to decrease the incontinence, you are adding on a primary repair. So how can you really do this in the perineum? This is what is being done for an obstetric trauma. Obstetric trauma, when you have a complete perineal tear, this is what we are doing for years together, and the results have been fairly good. So this is not something which has been newly discovered or proposed. We have been doing this for obstetric trauma, and this is similar to that. So the results are definitely good because the obstetric trauma is much more uncontrolled damage, and what you're doing here is a damage which is controlled by the surgeon himself who is going to repair that. So you can achieve a complete disease eradication, and if you are going to suture back a good vascular tissue, then this is going to heal reasonably well if you can take care of the wound post-operatively reasonably well. Right. So what are the advantages if you do a fistulotomy and leave or a fistulectomy and leave the wound open for a high fistula? Then you have a larger wound, problems with going back to work, managing the wound, pain. But if you do a closure, then the wound is smaller, they can manage it better, pain is relatively lesser. You don't need specialized equipments. This is my personal indication whenever I'm called to do a fistula case outside, because in the institute you have laser, you have WAPT, you can do whatever you want. But when somebody calls you from outside and says, I have a fistula, and you come, you look at the MRI, many times the report is not very descriptive as you would like it, and you don't have the luxury of seeing it pre-op. If I don't have specialized instruments and if there is not much sepsis, this is one operation which has always rescued me. I'm going to show you 2 videos, both of them not done inside the institute. I had to do it outside when I was called to operate on patients with a fistula in ANO. And the incontinence rates are definitely there, about 10%, but the blessing is that if you do a proper repair, the bad incontinence, meaning a stool incontinence, is really, really less, 2 or 3%. 10% says that it is a gas incontinence or sometimes a liquid incontinence, and it is usually a worsening of pre-existing incontinence, and it improves by 3 months, especially if you start the Kegels exercise. Yes, incontinence is a problem, but it's not as scary as where the patient is going to have a wet perineum all the time or a urge incontinence if you do a proper repair in a selected patient. So what are the concerns? Without a good imaging, you can't really do this, because you cannot end up cutting wherever you want as you discover on table. You have to be clear about what you're cutting and can you reconstruct that in your hands. Good anatomical knowledge is needed. You have to be identifying the structures properly, otherwise you cannot cut everything and then reconstruct, especially anteriorly, where you may end up cutting the perineal body and it's trouble. Issues of reconstruction definitely occurs if you have an abscess cavity or a large cavity. So if you have an abscess or a large cavity, then trying to suture back is a nightmare. I'm going to show you a video where I was caught in a nightmare outside and I was forced to do it. Given a choice, I won't do it again, because you won't want to do a sphincter repair when there is an abscess or a cavity. Post-op restrictions in squatting is another very, very important problem in our patients, because many of them still use an Indian toilet. You do a primary sphincter repair, at least 8 weeks, we don't want them to squat. So this is again an important problem. So tell your patient, ask your patients before you offer this if they have access to Western toilet. I had a patient no access to Western toilet. The hospitals have a chair commode. I asked him to buy, and he used it for about 8 weeks at his home before you used, and thankfully he healed. And then recurrent cases, or if you have a previous failure, then it's a concern. You don't know what has happened. Even if somebody says, OT notes is that I have done drainage 2 times, you don't know how much of sphincter was compromised during those drainage. So if somebody has underwent a previous operation, then we are really, really worried about doing a fistulectomy and a primary sphincter repair. That will be another concern. So what are the key principles before we venture into this? Good pre-op imaging to see the disease status and also the sphincter status. Pre-op manometry, if at all you are doing a recurrent case or if it is a multiparous woman. Avoid if there is any clinical or manometry evidence of sphincter compromise unless you want to do a repair of the previously damaged sphincter. So that is a good indication for you to do this, because you can go in and repair if you can identify it with MRI. So the risk of incontinence has to be discussed, and the patient should be motivated enough to do Kegels exercise. You have to eradicate all the diseases before you try to do this. Try avoid cutting more than 50% of sphincter at any cost. Trying to cut till the PR sling is for real experts like Dr. Parvez Sheikh. I wouldn't venture into cutting the entire sphincter. And if it is a female, less than 30%. If I cut more than that, I can always reconstruct. Mark the end of the sphincters, at least in the initial part of your career, so that you can put them together when you are cutting them. And you do a tension-free end-to-end anastomosis. Overlapping is indicated for the delayed repairs of the sphincter injury. End-to-end is good. 2-0 PDS is good. If at all you have a very bulky sphincter, then you may think about a 1-0 PDS. If you don't have access to PDS, then a 2-0, 1-0 Vicryl is a good option. Single layer closure is good enough, except if you are doing an anterior fistula where you cut the entire perineal body, you'll have to do it in 2 layers, because superficial and deep transverse perineal muscle are there. And part of the wound, the distally should be left open so that it drains outside. So post-op, avoid squatting. Laxative wound irrigation is definitely needed. One of the things we have started telling all our patients is that if you Google, Amazon, Flipkart, everything has a sitz bath tub which is available for 1,000 rupees online. So all my patients who get a surgery these days, we tell them you Google and find out a sitz bath tub so that you can use it on a Western closet instead of really squatting in and doing a sitz bath for all this. And then a donut pillow, which is again easily available online, so that these patients can get to sit comfortably. Both of them cost about 2,000 rupees and they make their life easy. And sphincter exercises, if you want to start, you'll have to wait for the reasonable healing to happen. So Kegel exercise is usually started about 8 weeks later, and you have to really assess incontinence during follow-ups, at least with your PR, asking them to strain, squeeze, and then also with the Exner score. If at all recurrence, you preferably do a non-sphincter cutting operation if you have an unfortunate recurrence. So 93% healing, published in DCR. High anal fistula, 89% healing. So this is another long-term evaluation of fistulotomy and sphincteroplasty. Overall healing of 84%. And in high fistulas, there is a 4-fold increase in incontinence. High means more than 1/3 of your sphincter being cut. And 1 in 5 high tract patients had continence deterioration, which was again to gas and liquid. So another well accepted publication from diseases of colon rectum, 95% healing with low incontinence rate, and recurrent fistula, again like a high fistula, 5% higher risk of incontinence. So if it is a very high fistula or a recurrent fistula, try avoid this procedure as a first go-to procedure. So I'll just show you one video of an anterior transsphincteric. This again in private, you are called 16-year-old girl, anterior transsphincteric fistula. You can see we are doing a fistulectomy. Because anterior, you don't want to cut any external sphincter in a female. You can see the external anal sphincter twitching, but when we come to the internal anal sphincter with current, it will not usually twitch. So lay open. It's a simple, if it was a male patient, I would have left it open like that. If it is a female patient, I would like to reconstruct the sphincter. So that's what we did for the 16-year-old girl. Fistulotomy, make sure there were no side tracts. Excise the posterior wall, meaning the entire tract comes out along with the internal opening and the anal mucosa. And then we try to put it back in a single layer repair, and then the mucosal repair is also done. Something similar to what Dr. Mahendran showed you already. This is the middlemost stitch of the internal sphincter. I've hardly cut about 8 to 10 mm of the sphincters. Now I'm putting back the external sphincter. A part of the transverse perineal muscle is also coming from the superior flap, but I'm okay with that. I'm just putting it back together. So we are done with the sphincter with these 3 bites, and the rest of it is obliterating the subcutaneous cavity. Then we close the skin and then leave the distalmost part so that it drains. So the next is a nightmare for anyone and also for myself, but I did it. As you can see that in this patient, this was a rectovaginal fistula opening just at the fourchette. I tried doing a lift. This was in periphery again, but then I found out that there was a lot of immature tract granulation and the lift would not have just worked for me. So the surgeon wanted, because this was after a drainage, second procedure, he wanted a definitive procedure. Patient and surgeon not keen on a C10, so I went ahead and did fistulectomy, primary sphincter repair. I've cut open the perineal body also, at least a part of the perineal body, and there was this large cavity which prevented me from doing a lift or putting a simple draining C10. Curate out the entire tract. And there was a side tract which was joining into this cavity, which I again curated out. And then cauterize the base so that none of the infected granulation is left over, and there was a fairly wide internal opening which you can see. I'm excising the internal opening. Then it was a very wide defect, so I cut open the internal sphincter till the anal verge, basically making a fistulotomy, sort of cutting the mucosa and the internal opening. Now you can see the flap there. So I'm starting the reconstruction. Initially I'm doing the mucosa, submucosa with a bit of internal sphincter reconstruction, and then because I've cut the entire perineal body, I'm going to do the reconstruction of the perineal body in 2 layers. The transverse perineal muscle and the sphincter in 2 layers. The advantage of this is that you just carry your own lift and fistula instruments around, and you are able to do this without any specialist instrument. But the disadvantage is that you are not following up the patient if you are doing it in a periphery, and it's your fellow surgical colleague who has called you, who has to follow it. So he's going to send you back only when you have a failure. So this is reconstructing the mucosa and the anal verge, and then the sphincters will be put back together. There is no, you have to identify the edges of the sphincter, take about ½ centimeter or more than that as a purchase, and then do a tension-free end-to-end approximation. The length of the external sphincter anteriorly is almost 50 to 60% of the length posteriorly. So the sphincter length is not the same anterior and posterior. So anteriorly it is much different than the length of the sphincter complex posteriorly. So video and fast forward it for want of time. So I take the sutures interrupted, hold it, so you see the edges, have good purchase, pre-place the sutures and then finally tie them. So this makes sure that you are taking enough depth and enough sphincters in every bite. So that's what we do, and the superficial transverse perineal muscle was approximated and then the skin was put back together in this patient. So this is about fistulectomy and primary sphincter repair. There was one talk in the morning. I'm not going to bore you with the entire talk, but I want to show you one video of a Crohn's fistula, which we have done, and Crohn's is one of the most craziest things you can ever get. We are seeing more and more young females with Crohn's, and the principle in Crohn's is drain, Seton. Drain, Seton. We are not going to cure this fistula by our surgical technique. We are only going to have some sepsis control so that your medical gastroenterology colleague can hopefully, with the medication, control and cure the Crohn's. So the principle is very clear. In Crohn's, it is drainage and Seton. So this is typically what we will have to expect or do in a patient with a bad Crohn's, and this is what many times we get because of the robust medical gastroenterology department we have here. We get a lot of patients with Crohn's. I'll show you a few clinical photographs and then move on to a small video. See this? Can somebody from the AV see this? The slides are not coming up. It's not moving. I've actually skipped these slides. I just want to show the video. Just the video of that Crohn's. The Crohn's video. We'll go to the next presentation. There's some problem.
We'll call upon Acrsi sir, and I will request Dr. Balu sir to felicitate sir also, to give a token of momentum. I think at 6 o'clock also people are there to learn the fistula. This is really amazing to see. No, that's on the Sunday. That's really very important. It is very appreciable for Dr. Balu and PhD Surgical Gastro team to arrange such kind of wonderful workshop. I think last lecture, it is worth to hear. Sir is a master in fistula, really appreciable, very complicated cases he has done today and shown, demonstrated.
Thank you, Dr. Balu. It was a pleasure for me to be here. So it was worth it staying at Chennai and then taking all the trouble to be with all of you. So already we have discussed so much about WAFT. So I'll just start from where I stopped in the morning, that complex anal fistula is an issue. Still we have no direct treatment. We cannot say that this is the treatment. There is there are gray areas in every case, every situation, that okay, you can do this, you can do that. So those overlaps in opinions, and they are still there. So in complex fistula, we have basically two options. One is we do for FPSR, which Dr. Balu just demonstrated. So nothing like this, because you are removing the entire disease. And then you are reconstructing the sphincters. And the second option is you do sphincter preserving surgery. You treat the fistula without cutting the sphincters. And this is the area where you have so many options, and yet none of them is gold standard. So the basic principle behind the slide is very important. You have attended all the day. So I think the slide is the crux of what we all have been discussing since morning. So this is the summary of that. What I have learned in last 10, 15 years doing only proctology, only high volume fistula, what I have learned in last 12 years, this slide is crux of that, that when we do a sphincter preserving procedure, then we have three areas. Scientifically, we have three areas to address. One most important is central disease. Central disease means from internal sphincter from internal opening to intersphincteric plane. Second is debridement of the tracts. Third is drainage from all the accessible areas. Now the first part, which is central disease elimination, if the tract is mature, fibrous, cord-like tract, then you can do a lift procedure or a laser or advancement flap or even slough. So all these procedures can be carried out when we have a mature tract, fibrous tract. But if there is no definitive fibrous tract, then there's an abscess in the intersphincteric plane, then that needs to be drained either directly from the internal opening by cutting the internal sphincter or through the intersphincteric plane. So this is, now you have various tools to accomplish these goals. This is the scientific concept that you have to achieve. Debridement of the tracts, fistuloscope can help you, laser can help you, mechanical curettage, we all have seen how we accomplish that, and widen all the external openings, and if the internal opening or the internal part is, central part is also infected, then you have to allow that to drain also. So to accomplish this, we have so many techniques. Some of them failed, could not stand the test of time. Some of them are still evolving, and some of them have now been accepted as a standard of care, like lift and waft. So you can see the grade of recommendation with the level of evidence. So this waft procedure, which we have seen in the morning, this is a fistuloscope. This is, I think, one of the most useful armamentarium in advancements in proctology, because we have seen so many. I am doing exclusive proctology, all the advanced procedures in hemorrhoids, fistula, everything I try to learn, try to do. So I find this is a very useful tool. This is a 8-degree telescope, 18 centimeters long, 3.3 into 4.7 millimeters wide, and it has places for irrigation and also for putting these instruments for assistance and for debridement. Now, how this instrument can help us in various ways in managing complex fistula? One is identification of internal opening, which again is very important, a paramount important part of fistula management. Sometimes everything fails, your methylene blue fails, your saline injection fails, your hydrogen peroxide fails. So light can reach there in the internal opening and can guide us. The light of fistuloscope can guide us that this is the area where internal opening is. So this is one area where it can help us. Then sometimes there are secondary tracts, which even on MRI we are not able to pick up. So you can see here that this is one tract, and then there's a bifurcation here, and we are leading to another tract. So when you are directly looking inside, those secondary tracts can be picked up with fistuloscope. So this diagnostic part is how it helps in your mapping of fistula, identification of internal opening, and then thorough debridement. Thorough debridement with monopolar cautery, endocautery, and brush and scoops and all those things, it can help you. So this is how it can help you in various ways, but you have to accomplish the basic principles of surgery. Like in this case, this is a external opening, one is dry, one is active, patient in prone position because the disease is posterior. So this is the internal opening approximately posteriorly, 5 o'clock position. You can see the light reaching there, again indicating. So in this case, on MRI, we found a mature tract, so we decided to do a lift procedure. So because the tract was mature, you can see this fibrous cord-like, tube-like tract. So we are simply ligating and dividing the tract, and this is the disconnection from the internal opening. This is the central disease part. You can see the methylene blue, which is inside the tract, and the white fibrous cord-like tract. So this, and then some tissue can be removed also. In order to, you can send it for histology also. And then fistuloscope can help you in the remaining extra sphincteric portion of the tract can be debrided with the help of fistuloscope, and then this incision is closed. So this is one simple way how you can combine these tools to accomplish your goals. Another similar case managed in a similar manner. You can see we saw in the morning also a case where the external opening was wide away from, far away from the anal canal. So this is the inside view. And again you can see the light is reaching there. In this patient also, we had a mature tract, so we preferred doing a lift procedure. We dissected in the intersphincteric plane, found the tract, and this is the tract, white cord-like tract, dissected out, and we divided the tract. We haven't ligated it yet, we have divided the tract. You can see the lumen and the methylene blue also visible there. So the tract is divided, central disease taken up, and then we are using endo brush to debride, cautery to debride. After thorough debridement, we also use laser to ablate the tract to cause shrinkage of the cavity. So you can see these tools can help us in various ways. They will not spell magic. Laser will not spell magic. But if you, in line with your scientifically correct procedure, then this may be, productive. But if you are simply putting laser in, taking laser out, like patients come and demand that I want laser treatment. Every patient comes and says I want laser treatment. They think it is like a magic stick. It is not a magic stick. So, but you can use it in a wise and precise manner. Similarly, this patient, like the one we saw in the morning, had many openings in the abdominal. I'll run this video fast because my purpose is to just make you understand. In this patient also, we went all the way into the intersphincteric plane, excising this portion from here, from internal opening, and we demonstrated a similar case in OT also today. So this area was completely excised. We are taking stay sutures so that this tract can be, just to give traction over the tract. So we excise the tract up to the high intersphincteric space, and then after doing that, the rest part was very simple, that is debridement, curettage, and fistuloscope assisted debridement, all those things that we have already seen in a previous case. So these cases are not uncommon. We have had so many cases. Another case similar, slightly differently managed. This patient also had undergone laparotomy as misdiagnosed to be a case of pelvic abscess, but the disease was extraperitoneal, as it is always. So you can see this is the area of internal opening. So again we proceeded in the same manner, that we started from the internal opening, right? This is the fistuloscopy done from external opening, and you can see the inside of the tract. So in this patient, you can see we find a very mature sort of tract, so we are taking stay sutures across the internal opening to facilitate our dissection. So we are going all around the internal opening, and we will go up in oblique manner, cutting the lower part of internal sphincter, and we will enter the intersphincteric plane, and we will go in the high intersphincteric plane and excise the tract from there. because in this patient we found a very mature tract. There was no spread of infection in the intersphincteric plane, so we decided to close this defect after excising it. In the previous patient and the patient we operated in the afternoon, we did not close because there was a lot of pus, lot of spread of infection. But in this patient, we mobilized the mucosa on both sides after excising because the defect was going up, so a standard mucosal flap was difficult to bring down. So instead we mobilized the mucosa on both sides and then closed the defect in 2 layers. First the defect in the internal sphincter was closed and then the defect in the mucosa was closed. So we took all the sutures as stay sutures, first the sphincteric sutures, and we did not tighten them. Those sutures were taken out as stay sutures, and then we took out the anoscope, anal stretcher, and first tightened the sutures in the internal sphincter and then tightened the sutures in the external sphincter. So in this, because the tract was mature, so one side was closed and the other side was wide open. When tract is not mature, both sides were left wide open. So, and after doing this, just 2-3 minutes, the rest of the job was very simple, that you debride again the remaining tract with fistula scope, and the last part was just making this, enlarging this external opening, that is the drainage area, so that whatever infection secretions are left, they will continue to drain. So this is the case after a few weeks. This patient had disease, just last video, 1 minute maybe. This disease had he had disease reaching up to thigh. Some of them were active, some of them were discharging, some of them were dry. So in this patient also, the fistula was reaching to, you can see this is the MRI picture showing the disease going down into the thigh. So in this patient also, first we tackled in the same manner that from internal opening up to intersphincteric plane. This video is unedited, just last month, so just small clips and just trying to convey the message. So we went into the intersphincteric plane and then we did a thorough curettage from there. Whatever disease was there in the intersphincteric plane was taken out. And once this central part of the disease was taken care of, then the remaining part was simple, that just excising the external openings from skin up to subcutaneous tissue, because the tracts were traveling through the muscle subfacially, so they were thoroughly debrided. And here also fistuloscope was very useful because you have long distant tracts, they are offshooting from this intersphincteric plane, so definitely these tools, fistuloscope and laser, could be very useful in situations like this, where you can simply excise some portion and then you can use a fistuloscope to do a thorough deepithelization and debridement of the tract. So fistuloscope is one of the useful tools of modern proctology, and I think it should be exercised in a scientific manner. It's not important, the tool is not important, it is your procedure which is based on scientific, merit. Every fistula should be treated on its merit, okay, because fistula continues to be a tricky problem and it continues to outsmart surgeons. So whatever tools, whatever armamentarium we have, we need to tackle the disease in a smart manner so that patients are benefited maximally, instead of getting, paranoid with what industry is calling and talking and, shouting, and patients are coming and demanding, and they have their own fancies and whims that laser spells magic. You must tell the patient that we do laser but in a scientific manner. We don't just, laser will not treat you. It is the scientific treatment will treat you. Laser may be having a small role in your entire treatment. So I think that is the message to be conveyed. Thank you so much.
Thank you so much, sir. Thank you.
This brings us to the end of the master video session. We have some case-based scenarios with a brief panel discussion. The audience can take a, can we go ahead and present those cases, or would you like to wind up? The audience can decide. Yeah? Okay. So we'll have the panel discussion. I request Dr. Samrat Jangar and Dr. Balu Kupasamy to Samrat. Dr. Samrat to be the moderator.
Before that, just we want to inform you two things. One is the Lasers in Proctology book. Dr. Kamal Gupta has written that book. Actually, he has mentioned everything about laser for the proctologist procedure. So the importance of that he will elaborate you. The second one, we are having the Acrsi conference at Indoor coming 29th, 30th and as well as 1st of October. As you all know very well, in Acrsi in we are having live workshop and as well as all the debates, CMEs and the external lectures and invite lectures from the international faculties. So, yes, I would like to request all of you to register for our Acrsi conference in Indoor 29th, 30th and as well as 1st of October. Display. So I will forward the brochure in our ASI group and as well as our Acrsi group. And because of the ACRSA and as well as ACRSA South Zone, we once again thank Dr. Balu and as well as the Department of Surgical Anesthesia PSG for wonderfully conducting this single team CME and a live workshop. I request Dr. Kamal Gupta sir to elaborate about the lasers in proctology book.
So, thanks, Dr. Kannan. Actually, I was apprehensive that one should not boast about himself wherever you go. So this is a book which has been written by me, that is Lasers in Proctology. Dr. Balu kept a very interesting topic in master class, that is tips and tricks. So this book, when I started writing, it was only of lasers, but it covers almost everything in proctology. Even what Dr. Arshad has shown you about waft, what Dr. Parsarthi has shown you about lift, everything is covered in this book and it is a bestseller. But my humble request, please do not buy from Amazon. They have actually pirated the book, and few laser companies, they have also pirated the book. So if you want to really buy it, take it from CBS Publications. They are the sole distributors of Springer in India. So the book is published by Springer and just authored by me. It is very rare you get a single author book, but I had very good friends with me, Dr. Kushal Mittal, my own teacher, Arshad, my younger brother, and
Dr. Niranjan Agarwal. So many good people were there when I was going through the book at that time. And thank you very much for all of us for being there. Thank you very much.
We will just quickly run through the case capsules. We are having 10 to 11 small cases. So we'll just see the thought process or approach towards the different cases. So this is 38-year male with history of pus discharge and having external opening at 5 o'clock. So simply we can see that we are having some simple fistula where external opening at 5, internal opening. How to tell this one is to map is internal opening at 5, intersphincteric there is a tract, low intersphincteric tract and having external opening. So it is a simple low intersphincteric fistula. When it comes low intersphincteric fistula, then it will become very clear to us how to manage it. It will be just simple fistulotomy. Need not to think about too much what need to be done, what need not to be done. So coming to second case, so this is actually what Acrsi sir demonstrated. So 23-year-old abdominal sepsis 4 months back underwent a laparotomy. Outside they have drained the pus and no evidence of any pathology they have mentioned and had been referred after 4 months. Abdominal part has healed and perianal pain, perianal discomfort and perianal pus discharge was continued. So internal opening found at 6 o'clock. So what need to be done? MRI has been done. MRI shows that there is internal opening at 6 o'clock and some inflammatory thickening towards the supralevator region. This is a horseshoe-shaped collection. So this is just to see internal opening at a 6 o'clock is there. So for this, the fistula map pattern will become a high intersphincteric fistula. If it is a high intersphincteric fistula, this fistula will go in higher level and have some supralevator thickening. For this, it will be easy to think of what need to be done, that is intraanal fistulotomy. We can just do the cutting of the internal sphincter and mucosa, what sir has demonstrated morning. That's simple intraanal fistulotomy we can do with lithotomy. Even it can be done in prone position, whichever preferable. Identifying the internal opening will be the most important. Coming to case capsule 3, patient coming with a perianal pain, fever, and having the peranal tenderness, not able to appreciate any internal external opening. So this is the case where we made a small hole outside and put a hydrogen peroxide. We can appreciate that hydrogen peroxide is coming inside the internal opening area. So it becomes a simple that it is just around the anal canal and hydrogen is coming, means it will become a pattern 1 low intersphincteric fistula. If it turns to be a pattern 1, again for us it will be easy. Pattern 1 is we need to go for simple fistulotomy. So just done the fistulotomy, divided the tract. Case capsule 4, there is a perianal pain, pus discharge since last 10 years, perianal discomfort. 3 times surgery has been done prior to this and the resting tone is good, scarred perineum, internal opening at 6 o'clock. There are 4 external openings. So this is the thing, identified the internal opening, the hydrogen peroxide is coming into the anal region and seen. So MR fistulogram, it is a type 4 pattern of posterior high transsphincteric fistula going in infralevator and ischioanal space forming the abscess and then it going down in a 4 opening at a 7, 8 and 9 o'clock, 4 external openings are there. For that colonoscopy was done which was normal. We can decide this, we need to go for the sphincter preserving procedure, whatever we prefer. Here lift has been done. In fact, intersphincteric space, there was a collection that has been sent for TB also that came to a negative. Tract has been divided, tract ligated. ligation done and followed by division of the tract done. After that, reinforcement stitch also has been taken so that it should not recur. And other external opening has been thoroughly debrided and curated. Case 5, sorry, it is a pus discharge coming at the coccygeal area, perineal discomfort and perineal surgery done 1 year back. Now he came with a recurrence. It is internal opening at 6 o'clock, external opening at the level of tip, that is a pilonidal area. So this is the patient. If we flush from the that area, we are seeing that internal opening, which is a high transventric, posterior high transventric. It is pattern for posterior high transventric fistula. MRI also done to confirm. This is a less likely posterior transventric fistula. Most of the posterior transventric fistula have a horseshoe-shaped tract, but this is a rarely to get. It is also usually present. So for that, there is no question that it is going below the anococcygeal ligament. Then we need to think about something sphincter preserving procedure. As a sphincter preserving procedure for this case, we did the lift procedure. But interestingly, after ligation before division, we tried to flush the hydrogen peroxide. Hydrogen peroxide was coming into the anal canal. So that is one of the problem with lift is we will have if not able to ligate the tract properly is one of the important cause for the failure of the lift procedure. Lift is one of the wonderful procedure because it is a very good sphincter preserving procedure. We are seeing anus also, we are having the hydrogen peroxide is coming. So for that reason, we just again went in, taken a reinforcement stitch and divided the tract. Now after division of the tract, we can see that hydrogen peroxide is coming inside the intersphincteric dissected area only. So division has been done, and outside pilonidal area, the tract was going straight down below the anococcygeal raphe. It was forming the cavity, and then it is connecting. It is type of high transsphincteric, posterior transsphincteric, pattern 4 fistula. So outside we curated, taken out the tract down. We can appreciate now that cavity is going below the anococcygeal ligament. Down there is a cavity was there. That has been kept one tube to flush it. This is, we can see that down it is going as a cavity. This is a 26-year male, 2-time IND has been done for left-sided horseshoe fistula abscess. Now he came again with an abscess. He wanted to get the definitive procedure done at the same time. We can appreciate that here to identify internal opening, I try to press on the abscess cavity. We see the puckering at the internal opening area. So that deep postanal space abscess and transsphincteric fistula internal opening at 6 o'clock. This is classical posterior high transsphincteric fistula, type 4 fistula. If we want to map it, it's kind of abscess on the infralevator, ischioanal space and perianal space and giving the blind ending. So for this, simultaneously fistulotomy has been planned. We just done the intersphincteric dissection. Identify the internal opening, code out the internal opening so that we disconnected the internal opening from the mucosa and internal sphincter, and ligated the internal opening over the external sphincter so that that internal sphincter spasm goes off. And later dealt the lateral as good as routine abscess drainage, drained the abscess and cleaned the cavity, put a drain for irrigation easily. 8 French to 10 French tube we usually will keep, and after 2 weeks we can pull out the tube. This is 46-year female, perianal pus discharge since last 9 months, having induration at 12 o'clock and external opening at 1 and 2 o'clock. So this lady, if we press over the external opening, there is a pus is coming. We can appreciate pus is coming at the internal opening area. So MRI done, MRI wise it is a type 2 low transsphincteric fistula, but it is anterior fistula. Anterior fistula in female, it's better to think about the sphincter preserving procedure. So it is forming 2 tract outside the external sphincter. For this, just done the intersphincteric dissection as a part of procedure what we do in the lift, identified the tract, hooked the tract, and tract has been completely disconnected from the internal sphincter and mucosa. And after disconnecting, we will ligate the tract and the deep intersphincteric space, what Kamal sir told, that we will buzz with a bipolar, and also intersphincteric area which is opened, we will buzz with bipolar, so that cryptoglandular, whatever infected source is there, which will get cauterized. And we ligate the fistula tract over the external sphincter, and followed by we will just core out the external openings. This is the 27-year lady with abscess and having the internal opening at 12 o'clock. So this is also type 3 anterior high transsphincteric fistula as per the MRI. For this patient, definitely even the high or low anterior fistula, we need to think about the something sphincter preserving procedure. Simultaneously abscess drainage plus fistula we dealt. Initially, before doing the drainage of abscess, we went in intersphincteric space. And both side of the tract, if we are having the anterior tract, both side of the tract, hooked up the tract. After hooking, rather than doing the ligation in the intersphincteric space, we disconnect completely from the internal opening and the mucosa till the dentate. Internal opening get disconnected, and internal opening we disconnect from outside. For that we will take a stitch across and drain the abscess and put the tube into the cavity, so that we have taken care of the fistula tract and also we have taken care of the abscess cavity. Another 2-3 cases. This is perineal abscess with simultaneously throbbing pain over the perineum, spontaneous discharge through the anus. So this lady was having 2 times done surgery prior. There is no external opening. We can appreciate that the probe inside the internal opening, but outside there is no external opening, nothing is there. And there is a cavity, both sides. Left side was larger cavity and right side was smaller cavity. So MRI done, we can appreciate in MRI 2 abscess cavity are there. Right is larger, left is smaller, and it is coming in an intersphincteric space and just getting in. It is kind of type 3 anterior high transsphincteric fistula, where we are having 2 blind endings that need to be tackled simultaneously. For this patient, this is the fistula mapping coming outside and having the 2. In deep perineum, below the perineum, 2 abscess cavity are there and both on labial side. For this fistula mapping, we can see the sphincter preserving procedure. Just as the cavity outside the external sphincter, we made the hole to drain outside and drain the complete cavity. Again another hole we made on the left side, drain the complete cavity. So that cavity has been given some good way to exit that infected tissue outside, granulation tissue. Now intersphincteric dissection has been done. Around the tract we made a dissection and hooked up the tract, and tract is disconnected from the mucosa and internal sphincter. And then we cauterize thoroughly intersphincteric space and deep intersphincteric space. And this is a internal opening, that fistulous opening. We are ligating over the external sphincter. This is left abdominal abscess with scrotal wall abscess. We had a chronic fissure since 3 months. There is induration at 6 o'clock, induration and fluctuation in left groin scrotal wall abscess. This patient has pus in the internal opening was coming. So CT was done. Again we can see that combined pattern, high transsphincteric and high intersphincteric, posterior high transsphincteric, high intersphincteric. It is one of the complicated scenario. Here, CT and MRI done and confirm the diagnosis. If we see fistula mapping, internal opening at 6 o'clock, intersphincteric space also abscess which is pouring, and that two tracks are going, one is high transsphincteric, one is high intersphincteric. For this, there is a colocutaneous fistula also mentioned on the CT. For that purpose, we done diagnostic laparoscopy, nothing was there. It is a perianal sepsis which was coming to abdominal wall. So what we did, first tackle the down, what was the problem. We did a intraanal fistulotomy down. Then we made an incision to drain the abscess over the abdominal wall. It was extending up to the thoracic wall, lower thoracic wall. Pus, everything was drained. And taken 2-3 counter incisions so that we can drain out the complete abscess. And there is a gauze, what way sir has went with a scope, we put a gauze was coming from the internal opening, thoroughly debrided with a gauze. And that internal opening, we did a fistulotomy, intraanal fistulotomy, and cauterized that area. Rest is we taken care with debridement and dressing. 3 to 4 times taken into OT and complete dressing was done. So it is a day 2 we did second dressing, day 7, and around 10th day he got discharged. But after 3 months, wounds were absolutely healed off. Just 45 day and it is 60 day complete drained off. This is last case. It is a high history of perianal pus discharge with perianal discomfort, 2 times surgery done in last 1 year. If we see this one, we will take that without MRI, it is a simple intersphincteric fistula. So if doing MRI, which turns that it has a supralevator component, it has a horseshoe over the levator, and also it has some internal opening kind of thing, iatrogenic opening at 9 o'clock, and this was having abscess cavity even below the levator. So this is pattern 2 and pattern 1 and pattern 5, low and high intersphincteric fistula combined pattern. For that we are having something which is going down, which will feel easy, but something going up, which is the supralevator component. So for this we again need to go, initially we just went and done simple fistulotomy, taken out the tract completely, went till the internal opening, and we plan to just do the curettage of the supralevator component from the intersphincteric space and leave it. But surprisingly at the end we are having another one, rectal opening. What radiologist was mentioning 9 o'clock, that is a high rectal opening because of prior surgery, iatrogenic opening is there into the rectum. We can appreciate that. Here, the probe is easily coming above the levator. We cannot divide directly because it is a puborectal sling. So, turn the patient into lithotomy, because this area to suture the rectal opening is very good by lithotomy rather than the prone. Taken in the prone and suture the rectal opening with purse string. But we are having below the rectal opening, there is a supralevator cavity is also there, that we need to take care. For that reason, we put a 8 French feeding tube into the cavity. So patient was asked to flush and clean that area. He was kept under dressing. After 1.5 months, all wound got healed. Initial 1 week, he had some fecal soiling, but after that it was absolutely normal. Now it is 3 months, patient is doing absolutely okay. So it is the end of the procedure where we have placed and taken 2 stitches to hold the tube inside the cavity and allowed to flush it. For take-home being a surgeon, we need to put effort to understand the fistula anatomy and images. MRI is a part and parcel for fistula surgery. Fistula surgery is always balanced between the continence and cure. First surgeon is the best opportunity to cure it. Newer technique which are less invasive, more friendly, we need to aware of all these things, but choose your procedure based on the anal fistula pattern, disease along the extent of the sphincter involvement. Thank you and sorry for rushing.
Yeah, very excellent collection, Samrat. It is not a, it is a very difficult job, no, making a panel and having all the videos and with the MRI. Even many surgeons know they have done it, but they don't have this organized way of keeping the MRI and surgery and discussion. It's very nicely done. Huh?
Thank you, sir. Thank you.
Brings us to a very long day. I really thank every one of you for staying the longest hours on a Sunday. I can see most people. Thank you, sir. The head of the departments from CNC are still here at 6:30 in the evening. Thank you so much. On behalf of the organizing committee, we would like to thank every one of you for your participation. We had some issues regarding funds, so we could not make this conference a free affair. That was one. Then we simply don't get the simple cases, at least in our department, so we could not get simple, straightforward cases for demonstration, which we really tried. We went for 3 camps, but we didn't get any of the regular cases. But I hope when you do a single themed workshop, it was to just elevate the level of our understanding, and I hope this has served with the faculty who have participated, and hopefully the cases also helped you understand the approach to a difficult disease process in a better way. I thank every one of you for showing faith in this conference and then coming here to participate. I would like to really thank the ACRSI South Zone, especially Dr. Kannan, and the national leadership was also very encouraging. We could not get Dr. Kushal Mittal for a few reasons. The national leadership and the South Zone leadership of ACRSA was really pushing us to do it. It got rescheduled a few times, but because of their persistence, we did it. And my heartfelt thank goes to the faculty. I started seeing a lot of fistula cases when I was in CMC Vellore for some time. One OT day, 8 fistulas will be there. And I was in GEM for 3 years, and I would leave my major cases to go assist Dr. Partha for his lift. So that's how our journey started, and it has been a very exciting journey and a very humbling journey where all the failures do teach us and push us to learn more from senior faculties. I would like to thank all the faculties for coming here, and I hope it was a memorable and a useful exercise for all of us. Thank you, and I would like to hand over to Dr. Kannan.
Once again, I thank Dr. Balu and his team for the excellent CME and live workshop in this prestigious institution. And I thank Dr. Kamal Gupta, the vibrant personality, the laser man of India, and as well as Dr. Ashok Ahmed, the professor of surgery and his versatile surgeon in the fistula, and Dr. Parthasarathi and all other senior faculties who have come over us and put their fullest effort to bring this conference an excellent one. And invariably, the last but not the least, all the delegates and as well as our seniors, juniors, and as well as fellows, thank you once again for coming this CME. And once again, I thank Balu and his team. And we will all see in Acrsi and indoor in October. Thank you.
Last words, I'll be failing my duty if I don't thank my team. I've been standing in front, but it's the entire team. We are a small team, but it has been the effort of my team. Thank you everyone. Karthi, Arun, Praveen, who has been the big man in front, and then all our support people from our department, including Malati, our staff, Sister Munima and Sister who's here, and also the management here. Thank you one and all.